Okay, I think now it's okay. Fine. Okay, to start. Okay. So first we start with the general pharmacology. Ready? Yes, in case, yes, we start. In general pharmacology, there are two important chapters we have to cover. One is kinetic part, one more thing, dynamic part. So first I go for kinetic. In that four chapter we have devised. One is drug absorption, then drug distribution, metabolism, excretion. What are the points important for absorption? Look here. For any drug to get better absorption, it should be in non-ionized form. Because in this form only, most products will be lipid soluble in nature. So first point, basic point, for any drug to have better absorption, it should be number one, lipid soluble, number two, non-ionized. And then you know the formula, the non-ionization of drug occur based on the environment. For example, acidic drugs, generally acidic drugs become non-ionized in acidic medium. Acidic medium, it's a basic point. Okay, that means my question, drugs that are weak in acid or better absorbed from acidic environment because acidic drug in acidic medium become non-ionized and getting better absorption. For example, aspirin. Aspirin, acetyl salicylic acid on oral route, it will be better absorbed from stomach because stomach is having acidic pH. So in general, acidic drugs are non-ionized in acidic medium and become better absorbed. Okay, now for absorption, drug should be non-ionized. For excretion, the drug should be ionized. Remember, for excretion, the drug should be in ionized form. It should be in ionized form. So, my question starts. Look here. To enhances excretion of acidic drug through urine, urine should be do what? For example, acidic drug, imagine while passing through urine, if the urine is acidic, acidic drug in acidic urine become non-ionized and go for absorption. So I want to excrete mean the drug should become ionized. For ionization, we do urine alkalization. So question, for excretion of acidic drug, we should do urine alkalization. Weak acid become non-ionized in acidic medium. Weak alkali become non-ionized in alkali medium. Strongest acid and strongest alkali always seen in ionized form. Okay. And then urine can be alkalized. For example, alkalization urine is done for excretion of acidic drug. And for example, aspirin poisoning or barbiturate poisoning. Barbiturates are acidic drug. So question, for excretion of acidic drug, we do urine alkalization. And next important question, the urine can be alkalized by injecting sodium bicarbonate or acetazolamide. It is important. Urine can be alkalized by injecting either sodium bicarbonate or by injecting acetazolamide. Okay, acetazolamide, a carbonic anhydrase enzyme inhibitor. Anhydrase enzyme inhibitor, it is acting on proximal convertible where they inhibit absorption of bicarbonate, inhibiting absorption of sodium bicarbonate. Thereby, bicarbonate passes through urine and become urine alkalized. So question can be, name one diuretic useful for making urine alkalization. It is carbonic anhydrase enzyme inhibitor acetazolamide. Very important, very important. So name the diuretic useful for making urine alkalization. Mean answer acetazolamide. Then For excretion of basic drug, we'd have to do urine acidification. So acidification of urine is useful for enhancing excretion of basic drug. For example, amphetamine, morphine, all are alkali drug. So in case of morphine poisoning, in case of amphetamine poisoning, for excretion of this drug, we do urine acidification. In this case, I want to ask one question. The question goes to all my dear people. Please answer. Usually, morphine undergo renal route of excretion. To enhance this excretion, I am using uh, acidification urine. But my question, usually for treating morphine poisoning, I have antidote. Anybody want to answer? What is the specific antidote for treating morphine poisoning? I'm waiting. Please answer. What is the specific antidote for treatment of morphine poisoning? Okay. Yes, good. It is IV, intravenous naloxone. Naloxone is the choice. But naloxone is short-acting drug. So, followed by IV naloxone, we can go for maintenance with the oral naltrexone. Oral naltrexone. So, first drug of choice is IV naloxone, followed by oral naltrexone. Very good. And look here. Urine can be acidified by injecting ammonium chloride or by ascorbic acid. Somebody already told it by injecting either ascorbic acid or by ammonium chloride. Okay. Now, up to this, we discuss how a drug undergo absorption, how a drug undergo excretion, all this we done. Based on this, I just want to ask one question. Ready? One question. This question goes to all people. Can you please answer? The question start like this. Come on. Anybody? What is the answer for the question? Look here. A patient, ready? A patient consumed 100 tablets of aspirin. What could be the treatment for this case? I'm waiting. Can you please answer? A patient consumed 100 tablets aspirin. What could be treatment? Yes, answer. Very good. Answer B. Very good. Because aspirin, a acidic drug. For excretion of acidic drug, we do urine alkalization. That is done by injecting bicarbonate. Very fantastic, fantastic. Similarly, you should know extra point. N-acetylcysteine, a antidote for paracetamol poison, a antidote for paracetamol poisoning. Okay. And of course, glucagon, a antidote for beta blocker poisoning. All these are important points. Anyway, in my first chapter, drug absorption, for excretion of acidic drug, we do urine alkalization. That concept you should know. Okay. Based on that, remaining point I will discuss later on. Now concentrate on our general pharmacology points. Okay. To start next. After finishing absorption revision question, I go for next bioavailability based points. Very important. Next, in absorption chapter, we have to concentrate on biology. The percentage, the percentage of drug that reaches the systemic circulation is known as bioavailability. So, what I want to say, the unit for biorate is percentage. We representing in percentage, 100 percentage, 50 percentage, like the percentage. Okay. Now, look here. And this again very, very important. In biology graph, they may ask, what is T max? What is C max? What is AUC? Like that, they may ask some question. Okay. So now I go on by one. In biology graph, T max, that is maximum time needed for the drug to reach the maximum concentration. T max indicate maximum time needed for the drug to reach the maximum concentration and it reflecting rate of absorption. This point is MCQ. T max indicate rate of absorption. And then C max. C max means maximum concentration of drug in the plasma. It's a maximum concentration drug in plasma. And AUC, area under curve, it is indicating bioavailability or extent of drug absorption. So question AUC indicate area under curve, also called bioavailability or extent of drug absorption. This question can be like this. For example, look at it. For example, the question can be like this. Look here. They may give bioavailability graph. In the graph, they may ask you, see, they give in the x-axis, I'm putting time value. In the y-axis, I'm putting concentration of drug in the plasma. And they may ask you, what is T max? What is C max? What is area under curve? Like that, they may ask question, doctor. Okay, so look here. T max indicate the time, maximum time needed for the drug to reach the maximum concentration. Okay. And one more thing, this portion, the ascending portion of the graph indicate drug absorption and the peak, it's called C max. It's called maximum concentration of drug in plasma and the descending portion indicate drug degradation. That is drug metabolism. So now our question, the C max indicate maximum concentration of drug in the plasma and the T max indicate maximum time needed for the drug to reach the maximum concentration. In this junction, I want to ask one simple question. The question goes to all people. Please answer my question. Look here. Suppose a drug having very low T max. Can you please answer? Very low T max. What is the meaning? If I say a drug having low T max mean what the meaning? T max indicate rate absorption. Lower the T max mean rapid the rate of absorption. Rapid the rate of absorption. Okay. And AUC. Yeah, very good. Fast sound, very good, very good, very good. And AUC mean area under the curve. We call extent of drug absorption, also called as bioavailability. Good, good. So I think you're good in two things. One thing, drug absorption, non-ionized form, excretion in ionized form. Second thing, MCQ based on bioavailability graph. Okay. Now I'm finishing this. Now we want to next. What next? For example, look here. After finishing this, look here. This one another important point you should know. Transport of drug across cell membrane. Look here. Imagine it is cell. Cell. Imagine it is cell membrane. Cell membrane. So cell, it is cell membrane. Drug transport. The drug can be transported across cell membrane by so many ways. The most common method of drug transport is by simple passive diffusion. Movement of drug across cell membrane can be so many ways. It is mainly by simple passive diffusion. For this, drug should be lipid soluble and it should be non-ionized and there's no need for energy or carrier. So question, the most common method of drug transport across cell membrane is simple passive diffusion. It is non-energy dependent, non-carrier dependent. That means it's a lipid soluble on its own it moves. Okay. And then while talking about drug absorption, bioavailability, here you should know first pass effect. Suppose when I give a drug orally, the orally given drug before reaching the system, either in the liver or in the esophagus, it may undergo some metabolism, thereby bioavailability decreases. It is called first pass effect or first pass metabolism. Okay. And one more thing, the absorption of drug or bioavailability of drug can be modified by something called P-glycoprotein. Very, 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 very important. PGP, P-glycoprotein. It is also called as efflux transporter, efflux transporter, also called as ATP binding cassette, ABC1 transporter, also called as MDR, multi-drug resistant MDR1 transporter. Very important, very important. PGP, also called P-glycoprotein, it is called efflux transporter. Here you should know we have something called P-glycoprotein inhibitor and PGP inducer like that. We having verapamil and other drugs like vaccine Q pneumonic, vaccine Q. Okay, for example, verapamil, amiodarone, cyclosporine, and uh, itraconazole, nifedipine, erythromycin, like that. So, question: verapamil is the most important P-glycoprotein inhibitor. So most important PGP inhibitor is very important. And we also have some PGP inducer. For example, rifampicin, the most important PGP inducer. And we also have other like St. John's wort and carbamazepine all are having, even phenytoin all are having PGP induction property. Now I have a small doubt. See, rifampicin, carbamazepine, phenytoin are a simple drug. Rifampicin a drug for TB, and these two drugs are drug for epilepsy, My doubt is going to all people. Please answer. What is St. John's wort? Any idea? What is St. John's wort? It is also old question. It's a herbal medicine useful for treating depression. So herbal medicine useful for treating depression. Yeah. So question, St. John's wort. It's a herbal medicine useful for treating depression. It is also having PGP induction property. Okay. And while talking about drug absorption, you should know some local factors. Sometimes some drug absorption interfered by taking with the food item. For example, tetracycline antibiotics absorption interfered by taking with the calcium containing food item. So question, most of the drug absorption interfered by taking along with the food. Okay. Simple example, tetracycline absorption can be interfered by taking along with the calcium containing food item. Okay. So in the first chapter in absorption, you should know three important things you should revise. Lipid solubility, non-ionization based question, and then PGP inducer inhibitor based question, and graph Tmax, Cmax, the graph based question, very important. And some terminology also is important. Orphan drug. Orphan drug means a drug useful for diagnosis or treatment or prevention of rare disease. Rare disease. We call this orphan drug. Okay. This thing called Orphan Drug Act. This act emphasizing what they uh, they give exemption, tax exemption for the pharmaceutical company. So they give the incentive for company to develop treatment for rare condition, rare disease, orphan drug. So which act giving incentive for the pharma company to prepare drug for rare disease? Orphan Drug Act. Okay. Can you please answer? A drug useful for diagnosis or prevention or treatment of rare case mean orphan drug. Suppose a drug useful for are going to meet the health care need of majority of people mean that's called what drug? That's called essential drug. Essential drug. So a drug going to meet the health care need of majority of population are called essential drug. Okay. And then sometimes you may ask what do you mean by called misbranding. Misbranding mean if the is good mark good if the label having lacking something, suppose in the drug label the label lacks proper instruction, they call misbranding. And another important point, placebo drug. Placebo means it is just to satisfy the patient. It is not a real drug, it's an inert medicine. It is useful to satisfy patient mentally, can be useful in clinical trial also. And one more time old question, what do you mean by placebo surgery? The placebo surgery are known as sham surgery. Placebo surgery are known as sham surgery. It is also old question. Okay. So in the first chapter, drug absorption, all the important point I revised. Okay. Now I move to second chapter called drug distribution. My dear students, if you sincerely listen my 2 day discussion, I am damn sure I going to cover entire pharmacology, which are normally we taught for 4 days or 4.5 days in regular class. Okay, it is really interesting, innovative because we give notes and we explaining all the points. If we go through this, no need to go any other things. Such an important way. So listen carefully. Okay, ABC. Suman, ABC I told ATP binding cassette transporter. The other name of PGP also called ABC transporter. Or we can also call multi-drug resistant transporter. Like that, I just told other name. Okay. Right. Now, regarding drug distribution, here first you should know regarding volume of distribution, VD. Okay. For example, okay, the amount of drug in the body to the plasma concentration. That is total amount of drug in the body divided by plasma concentration. We call VD, volume of distribution. And then this is what very important. When you say VD, you should know some drug having low volume of distribution, some having high volume. What I mean, for example, low VD mean the drugs are distributed in the plasma compartment. That means we have plasma compartment, we have interstitial compartment, and we have cellular compartment. If a drug distributed only in the plasma compartment, only in the 4 liter body fluid, they are called as low volume of distribution. And if they are low VD, that drug can be easily removed by hemodialysis. So, hemodialysis is useful for treating what type of drug poisoning. Any drug with a low VD, in case of poisoning, we can remove them by doing dialysis. And then drug with a high VD mean they are meet that they are generally gone up to the cellular compartment. To go to cell, high volume mean they seen in cellular compartment. That means freely goes to other compartment. Freely goes mean it can be either lipid soluble or it can be non-ionized or it can be minimally binding with the plasma protein. So easily crossing the other compartment goes to cellular compartment. Okay. And this question, last year question man, loading dose depends upon volume of distribution. This point is very important. Loading dose, any drug having high volume of distribution to get rapid action, they need loading dose. So loading dose depends upon volume of distribution. Okay, and this also old question. In when you talk about drug distribution in the plasma compartment, A drug can be seen either free form or bound form. Here question, which drug binding with which protein? That's important. In general, acidic drugs binding with plasma albumin. In general, acidic drug binding with albumin, whereas basic drugs are binding with alpha-1 acid glycoprotein. Basic drug binding with alpha-1 acid glycoprotein, very important. And then once we talk about distribution, you should know something called redistribution, very important. For example, we have one drug called thiopentone sodium. Thiopentone sodium, one of the intravenously given general anesthetic, comes under barbiturate category. It is used for induction. Question starts. Why it is useful only for induction? Why not for maintenance? It is short acting. Why short acting? Why short acting? Because of redistribution. It from the brain cell, it get redistributed to plasma compartment rapidly. And for the redistribution to occur, the drug should be lipid soluble. Lipid soluble. Okay. Yeah. For yes, for any drug to produce proper action, it should maintain adequate steady state plasma concentration. Yes, good, ma, good. Okay. And then when you talk about distribution, you should know barrier. Barrier sub one example, blood-brain barrier. It's one of the barrier of drug distribution. And this barrier is absent in CTZ area postma, chemoreceptor trigger zone area, vomiting center. In vomiting center, we don't have barrier. That's why most of drug acting on the center causing nausea, vomiting. And in median eminence, and also in hypothalamus, and this one, in pituitary gland, in pineal gland, there is no blood-brain barrier. This is important. Look here. I have one drug called please answer. I have one drug called domperidone. One more drug called metoclopramide. Metoclopramide. My question starts. Anybody? Both are D2 blocking anti-emitting. Both are anti-emitting D2 blocker. In this, can anybody want to answer? Which drug able to crosses blood-brain barrier? Only domperidone will not cross. Metoclopramide. This will cross. It will cross the barrier. That's why you know it causing adverse effect of extra pyramidal symptom like this. But one doubt, man, one doubt. Domperidone does not cross. It does not cross. Okay, does not cross. I do agree. But our pituitary gland has no barrier. Since pituitary gland no barrier, domperidone can act on D2 in pituitary, then block D2 pituitary and causing adverse effect of galactoria. Galactoria. So remember, domperidone do not cause EPS but may cause galactoria, whereas metoclopramide causes EPS as well as galactoria. This difference you should know. Okay. So question, domperidone does not crosses blood-brain barrier. Okay. Now I have small doubt. My small doubt is when we talk about drug distribution, you should know this question also. This is another important question. Can you try answer for this question? Look here. Ready? Just try. One simple question. Try. Which of the following is the true statement? Since we are reversing drug distribution, I want question. Which of following is a true statement? Ready? First. Drug with large VD can be removed dialysis? No. Large VD means the drugs are seen in cellular compartment. Here no role for dialysis. Okay. If VD is large, most of drug in plasma, no. It is cell compartment. Okay. Highly ionized drug has low VD. Very good, very good. Already very good job. Good. Answer C. Digoxin has large VD. That's why for digoxin, we have to go for loading dose. So good man, all are fantastically answering. Good, good, good. Okay, good. Now, after finishing drug distribution, I'm just moving to my next topic we call drug metabolism. Okay, in kinetic, another very, very, very important topic, drug metabolism topic. Come on, concentrate. Okay, most of drugs undergo metabolism in the liver. That we know. That we know. And there are two type of reaction. One is called phase one reaction. One more thing called phase two reaction. Phase one means simply oxidation, oxidation, reduction, hydrolysis, cyclization, decyclization, like. And the conjugation reaction, also called synthetic reaction, are called phase two. Here important point, even acetylation, even methylation, also phase two reaction. That's important. Okay. Now my question starts. Look here. All the phase one reactions are taken care by CYP family, cytochrome P450 family enzyme. Now the question goes to all people. Come on, Aishwarya, can I please answer? I'm telling all the phase one reaction are taken care by microsomal enzyme. You should tell which is the most commonest. What is the most commonest microsomal enzyme involved in majority of drugs metabolism? It is CYP3A4. 3A4. CYP3A4. This is important. The most commonest enzyme involved in majority of drug metabolism, CYP3A4. Very important. Okay. And when you talk about microsomal enzyme, you should know there are something called microsomal enzyme inducer, something called microsomal enzyme inhibitors. This you should know. Okay. I think you know the GPRS cell phone. GPRS cell phone. That is your graceolin, phenytoin, rifampicin, smoking, carbamazepine, phenobarbital, all are having microsomal enzyme induction property. Okay, even grapefruit juice also having enzyme induction property. Like that, you should know. Okay, so enzyme inducer, and then you should know. This I told the most common enzyme involved in majority of drugs metabolism, CYP3A4. And this is another popular question after very, very, very popular. For example, look here. Omeprazole, a proton pump inhibitor, undergo metabolism by CYP2C19, also having the ability of inhibiting this enzyme. It has microsomal enzyme inhibitory property also, thereby one very important drug interaction. Omeprazole and clopidogrel. Look here. Clopidogrel, one of the antiplatelet, comes under P2 white blocker. But it's a prodrug. It's a prodrug. Remember, a prodrug means inert. The inert drug means for its action, it needs activation. And it is activated by 2C19. Okay. So question. Clopidogrel is a CYP2C19 inhibitor, thereby interfering the activation of clopidogrel. This is very, very important. To avoid this, can we go for pantoprazole? That has no drug interaction. Is good ma. Pantoprazole has no drug interaction. This is a safer drug. Okay. Another old question. Theophylline, one of the bronchodilator, it is undergo metabolism by which enzyme? It is by CYP1A2 enzyme. Question. Which is the microsomal enzyme involved in theophylline metabolism? CYP1A2. That's why one question. One, can you please answer anybody? If I give theophylline with erythromycin, can you please answer? If I give theophylline with erythromycin, what happened to sorry. If I give theophylline with erythromycin, what happened to plasma level? What happened to, sorry, if I give theophylline with erythromycin, what happened to plasma level of theophylline? Answer is yes, good, increases good, because erythromycin is a microsomal enzyme inhibitor. Fantastic, man, fantastic. Okay, right. Now, the process, I mean, a drug undergo phase 1 reaction. After a drug undergo first phase 1 reaction and they going to produce one metabolites, this further undergo phase 2 reaction and become inactivation. The phase 2 is called as conjugation reaction or synthetic reaction. That is the process of making a drug water soluble, that is making inactivation, is called as phase 2 reaction. So question, most of the drug after phase 2 reaction become inactivated. So the most common consequence of drug metabolism will be they become inactivated. At the end of the phase 2 reaction, they become inactivated. Very important. And then see, I told acetylation, one of the phase 2 reaction. For example, you know the mnemonic SHIP, SHIP, that is sulfonamide, hydro, hydrazine, isoniazid, and prokinamide. They undergo phase 2 reaction by acetylation reaction. And any drug undergo acetylation has the risk of causing SLE problem. Be careful. They cause risk of SLE, systemic lupus erythematosus problem. Okay. And then another popular question you should know, what do you mean by Hoffman's degradation? That is, without the help of liver or kidney, a drug undergo self degradation. That is self metabolism. A drug undergo self metabolism. That is called Hoffman's metabolism. For example, atracurium and cis-atracurium all are non-depolarizing skeletal muscle relaxant useful in surgery undergo metabolism by Hoffman's degradation. Because of the self degradation, these two drugs are safe. Safe in liver failure, safe in kidney failure patient. They are safe. So question, name the safest SMR in patient with the kidney failure. Liver failure mean think of atracorium and cis-atracorium. Okay, and the atracorium, I know safe in kidney failure, but it produces one metabolite that's called ladenosin. Remember, ladenosin is the metabolite of atracorium and it can cause adverse effect of seizure. So question, atracorium may cause adverse effect of seizure because of production of ladenosin. It is also very important. Okay. Now, based on this type of thing, I just going to ask one question regarding metabolism. Can I try this question? Come on, try. Ready? My dear students, come on. All of the following are phase 1 reaction except. I'm waiting. Can I please answer? All of the following are phase 1 reaction except oxidation, reduction, hydrolysis, oxidation. Answer? The answer is acetylation. It's a phase 2 reaction. This type of question will be coming. Common question. And next, come on. Theophylline dose needs to be increased if the patient is on. Can I answer? Theophylline dose needs to be increased if the patient is on cimetidine, Glycopulvin, erythromycin, superoxin. Answer Glycopulvin because it's a microsomal enzyme inducer. Thereby, the therefore undergo rapid metabolism. Of course, you should know it undergo metabolism by CYP1A2. 1A2. Okay, good. All are answered nicely. Very good, very good. Now look at one more question. Microsomal enzyme involved in all of the following reaction except I told microsomal enzyme involved in metabolism of all phase 1 reaction. So here production this phase 1 reaction whereas acylation phase 2 reaction. So answer will be option B. Option B. Okay. Microsomal enzymes involved in all phase 1 reaction. Okay, right. Good, good. So I think you're comfortable. Fantastic. Right. Now, after finishing this match, now I am moving to my next one. The fourth chapter in kinetics, drug excretion. Ready? Drug excretion. Look here. You know, most of drug undergo excretion via kidney. That's simple question. But when drug undergo excretion, the drug can be excreted through urine by two ways, either by filtration or directly secreted into tubule. So the excretion can be either filtration, GF mean glomerular filtration, or TS, that is tubular secretion. Both very important. Now question starts. Look here. Penicillin, a beta-lactam antibiotic, undergo excretion through urine, but most of the penicillin undergo excretion mainly by tubular secretion. So the predominant method of excretion of penicillin through kidney is by tubular secretion. Now one question to all people. Anybody? Sakshi, Tanya, Chogyu, Harshmar. I am spelling, I am poor in reading your names. So can you please answer? I am telling penicillin undergo excretion through kidney by secretion. Now tell me, the tubular secretion of penicillin can be inhibited by one drug. Name the drug that's interfering tubular secretion of penicillin. Answer yes, good. Probenecid. Probenecid. Probenecid inhibiting tubular secretion of penicillin, thereby prolonging the duration action of penicillin. Okay. And once again, very important question, very important. You should revise. For example, I'm telling a drug undergo excretion through kidney either by filtration or by secretion or by both. For some drug, mainly secretion, some drug filtration. For example, look here. I have one drug called digoxin. Look here. The digoxin undergo excretion through urine mainly by filtration. Filtration. Now question starts, man. I know digoxin undergo excretion through urine mainly by filtration, and the filtration done by help of one thing called PGP, PGP, P-glycoprotein. Now question starts. P-glycoprotein permeating the excretion of digoxin through urine mean if I give, come on, if I give digoxin with PGP inhibitor like verapamil or with clarithromycin, what happened to plasma level digoxin? Remember, if I give digoxin with PGP blocker, digoxin will not allowed for excretion, thereby digoxin level get increases, causing more adverse effect. This also important. Good, good. Swapna, fantastic. So they're going to increase. So this probenecid penicillin interaction very important. Similarly, digoxin with the PGP blocker interaction very important. Okay. Next question. This I told already in absorption chapter. I know a drug undergo mainly excretion through urine. For making excretion of drug, I should make the drug into ionization. So question, alkali urine useful for excretion of acidic drug. because acidic drug in alkyl urine become ionized and going for excretion. And when you talk about excretion, you should know first order and zero order kinetic. Most of drug undergo first order kinetic only. Here, constant fraction in first order, constant fraction of drug is created at constant interval time. Okay, constant fraction of drug is created at constant interval time. And here, the half-life is always constant. Remember, actually, in first order kinetic, half-life is always constant. Now tell me, since half-life is constant, question goes to all people. Come on. After how many half-life? Approximately after how many half-life there will be 97 percentage of drug will be getting excreted. Can you please answer? Since half-life is constant, after how many half-life? About 97% drugs will be excreted after 5 half-life. After 5 half-life, about 90. Very good, very good, very good. Very good. And zero kinetic. In zero kinetic, half-life is not fixed, not fixed. And here constant amount of drug undergo excretion. For example, 0 watt power, 0 watt, WAATT, power, power. For example, warfarin, alcohol, aspirin, aspirin, tolbutamide, theophylline, theophylline, P for phenytoin. All these are undergo zero order kinetic, and mainly alcohol always undergo zero order kinetic. Remaining drug initially undergo first order, finally undergo zero order kinetic. Good. So that finishes very, very, very important aspects. So called absorption, distribution, metabolism, excretion. So in GP, the first part is called pharmacokinetic over. On up to this, can you able to follow my speed, doctor? I have done in GP part 1, that is kinetic. Up to this, can you able to follow my speed? If you able to follow this speed, mean you are already too good in pharmacology. You are ready for exam. That's meaning. Okay. Okay. Because you are done already everything comfortably. It's a rapid revision. If you're comfortable, you are too good. You are going to attend all the questions. Okay. Yeah. Very good. Now we move on to chapter 2 called dynamics. Dynamics. We start. When it's the dynamic, it's an action and mechanism action. It's called action and mechanism action. Okay. No. When you say action, mechanism action, small intro, a drug can acting by binding with the receptor. Receptor. What is second T in what? Theophylline, tolbutamide. Come on. One is tolbutamide. One more drug, theophylline. Theophylline. Okay. Now, when you talk about action, a drug can bind with the receptor, and producing action. So, question. My first revision based on receptor. The receptor for a drug can be seen on either cell membrane or in the cytoplasm or in the nucleus. Now, small intro, you should know the cell membrane receptors are 3 in number. One is called ligand-gated receptor. One more thing, G protein coupled. One more thing, enzyme linked receptor. With this intro, now what's your vision point? Among the 3 important cell membrane receptor, fastest acting MCQ. The fastest acting is ligand gated receptor. So question, which is the fastest acting main? It is ligand gated. Okay. What do you mean by ligand gated? A receptor controlling opening or closing some ionic channel. If a receptor control some ion channel. For example, GABA A receptor controlling chloride channel. For example, if I give benzodiazepine, they acting on GABA A. Activation GABA A causes opening of chloride ion channel. So GABA A is the ligand gated receptor. Okay, also called ionotropy. Ligand gated receptors also known as ionotropy receptor. For example, GABA A or NM. NM receptor opening sodium calcium channel. So any receptor seen on cell membrane when activated opening some ionic channel, they call ligand gated or ionotropic. Okay. And next question, very important, very important. What kind of GABA C? We have GABA A, GABA B man. GABA A is the ligand gated, GABA B is the GPCR. Okay. Now look here. We have totally 7 subtype of serotonin receptors. All are G protein. All are G protein coupled to exhaustion 5C. This is very important question. All the serotonin receptors are GPCR exhaustion 5:3. Now question goes to all people. Anybody? 5:3 is the ligand gated receptor. Gating what channel? Gating sodium ionic channel. Remember, Ga GABA. Actually, we have two only man. We have GABA A, GABA B. We have GABA A receptor. One more thing, GABA B. A is the ligand gated. Opening question. B is the GPCR. GPCR. That's all. Okay. Rupanandar GABA, we have GABA A, GABA B. GABA A is the ligand gated, GABA B is the GPCR. Okay, now look here. This is another very important question. You should know, you should know. Growth hormone receptor is a cell membrane receptor, enzyme linked. The enzyme name is JAK, Janus kinase enzyme, JAK enzyme. In this junction, I want to check how far you are good in preparation. Can you please answer? Growth hormone acting on its receptor, causing growth and development. The receptor is Janus kinase enzyme linked. My doubt is in case of acromegaly, to treat this case, I have something called growth hormone receptor blocker. Anybody want to answer? Name the growth hormone receptor blocker useful acromegaly. It is pegvisomant. Pegvisomant. Very important question. Growth hormone receptor blocker. Pegvisomant, very important, very important. Okay. Right. Now, insulin acting on cell membrane, that too tyrosine kinase enzyme linked. So insulin receptor is enzyme linked receptor called Janus kinase enzyme. And there are some receptors located in cytoplasm, for example, steroid, all the corticosteroid and vitamin D, and then hormones like estrogen, progesterone, androgen receptors are seen on cytoplasm. Mainly, all these steroidal drugs acting on cytoplasmic receptor. Vitamin D acting on cytoplasm. Whereas this is another important question. Third hormone acting always on nucleus. Third hormone acting on nucleus. Okay, this is very important. Repeat the question. Yeah. Then some definition. For example, a drug going to have action on a receptor. That is, if a drug having good affinity and positive intrinsic activity. Intrinsic activity means a drug having good affinity and positive intrinsic action mean vitamin D, vitamin A. Yes, good. Rupananda, vitamin D, vitamin A, all are cytoplasmic receptor. Okay. And then a drug having affinity and good intrinsic activity mean we call agonist. Agonist. A drug having affinity, positive intrinsic action, but less action mean we call partial agonist. Okay. And then look here. Another important question. Competitive antagonist. For example, a drug competing with other drug for the same receptor. For the same receptor. In this, imagine a drug. It is antagonist. Both are competing for same. In this, my drug not allowing the action of the other drug mean competition. So competition means a drug binding to same receptor as the agonist and do not activating. There is no action. Action zero. Action zero. This is called competitive antagonism. And this is another important expected question. Pitolisant is one of the example for inverse agonist of H3 receptor. Now I have two questions for you. Can you revise? If I say inverse, what is inverse? Inverse means a drug having affinity but the action is opposite. Opposite action. So action we call minus. Minus. Action is opposite. Now you should tell pitolisant also called tipralisant. It's also called tipralisant. The question goes to all people. Pitolisant, the so-called tipralisant, a inverse agonist H3, useful for what? It is useful for what? My question, useful for treating what? Useful for treating narcolepsy. Narcolepsy. Remember, yes, good ma. Nibidida, fantastic. Pitolisant, a inverse against history, useful for treatment of narcolepsy. Okay. Then, another very important question. The drug of choice for anaphylactic shock. Okay. In case anaphylactic shock, the drug of choice is injection. IM adrenaline is the choice. But question starts. In anaphylactic shock, problem is due to histamine. Histamine. All the physiological actions of histamine antagonist by adrenaline. So question, adrenaline is the physiological antagonist of histamine. The meaning is adrenaline not acting on histamine receptor, but antagonizing physiological actions of histamine called physiological antagonist. Okay. And then protamine sulfate is the specific antidote for heparin. Here comes CQ. Heparin by nature is strongest acidic drug. Protamine is a alkali drug. So question, a alkali drug antagonizing acid drug is an example for chemical antagonism. Anyway, two questions. Find out the specific antidote for heparin. Answer protamine. And protamine is what type of blocker mean? Chemical antagonist. Okay. Next question. Look, imagine it's a cell membrane, a receptor. Look here. What happened to receptor if by constantly activating this? Look here. The receptor become desensitized if when prolonged exposure to an agonist. If we keep on giving agonist mean the receptor go for either down regulation or we call desensitization. For example, remember very important. For example, I have some drug called formoterol, salmeterol. Anybody? What are the doctor? Anybody? Formoterol and salmeterol are what? These are all longer acting beta 2 agonists useful as a maintenance therapy in asthma. LABA useful in medicine. Now tell me, Imagine it's a beta 2 receptor. If I keep on giving formoterol 1 month, 2 months, 3 months continuously, the receptor go for down regulation, thereby drug action get decreases. That's called development of tolerance. Tolerance. The action become decreases. So to get the action, they need to go for high dose. Now my super question to all people. Look at one of the problem we facing with the LABA or developmental tolerance due to down regulation of receptor. But the question goes to all people. Please answer this problem. This problem minimized by what? Minimized. We are minimizing the problem by what? The LABA always given with inhalational corticosteroid because steroid increases sensitivity of the beta receptor. So LABA, good, fantastic man, fantastic. So LABA always given with the steroid to prevent the development of tolerance. Okay. And then if the next question, if the receptor exposing constant to antagonist, it become upregulated. A receptor become upregulated when the response when they responding to antagonist continuously. Okay, okay. And then after finishing this much, next you should know something about dose response curve. Another important. Look here. We now go for discussion of dose response. Yes, very important, very important. Look here. In dynamic chapter, we are discussing action and mechanics action where dose response curve. Look here. In log dose response curve, you should know what do you mean by efficacy, what do you mean by potency. These 2 points very important, very important. Okay, now look here. The concentration of drug producing 50 percentage of max effects. The dose they're producing 50 percentage of max response called EC50, also called ED50. That's the question. The dose at which I'm getting 50 percentage of max response called ED50. Okay, and the ED50 indicate potency of the drug. And Tanya asking physiological, come on now, physiological antagonism. That is in anaphylactic shock, histamine causing bronchospasm, histamine causing vasodilation by acting on H1 receptor. For treating that, the antidote is adrenaline. But adrenaline not acting against histamine receptor. It acting on beta 2 alpha 1 but reverting the physiological actions of histamine. So question, adrenaline reverses physiological actions of histamine. That is antagonizing histamine but not acting against histamine receptor. It is called as physiological antagonism. So simple way, remember Tanya, adrenaline is a physiological antagonist of histamine. Enough. Okay. Now coming to log dose response curve here. ED50 indicate potency of the drug. Okay. And the maximum effect of drug is known as efficacy. Efficacy. Okay. And now one more question. Just to look at the dose response curve, then I can say simple. Look at it. I'm going to explain. Look at it. Look at the graph structure. Look here. 3 questions you should know. First question, look here. It's the log dose value, x-axis, y-axis, response of drug. So we have one curve. This curve is called log dose response curve. It is sigmoid in nature. Shape is sigmoid. Okay. Here my first question, look at it. Here I put MR. MR mean maximum response. That is 100% response. The maximum response is known as efficacy of the drug. Okay, and then look here, consider here the dose at which I'm getting this, the dose at which getting full response, that's called maximum dose. It's called as maximum dose. Whereas all must know the dose at which I'm getting 50 percentage of max response. This dose is known as ED50. The ED50 indicate potency of the drug. This is what important. Okay, ED50. ED50 mean effective dose 50. The dose at which getting 50% response bonus ED50 and 8 indicate potency. Now question goes to all people. Okay, if I say a drug having low ED50, what is the meaning? Can you please answer? If I say a drug is having low ED50, what is the meaning? There is even on less dose, the drug producing very good response. That means more potent, more potent. Lower the duty, more the potency. Okay. Now, based on this, can you please answer in your workbook? I given notes, but can you answer the question? Look here. Imagine it's a dose response curve. Here, the response is maximum response is it's called efficacy. Here, efficacy, and the dose at which I'm getting 50 base points called ED50, that you know. But my question to all people, can you answer? What happened to dose response curve in the presence of competitive antagonism? Anybody? In the presence of competitive antagonism, the TRC shifted to right. Right. That means height is same. That means efficacy same. Potency get decreases. Similarly, what happened to DRC in the presence of non-competitive antagonism? In non-competitive, the DRC shifted down. That means height is decreases, whereas efficacy decreases, potency remains same. This is what I given in your notes. So please look your book. That is, look here. In the presence of competitive antagonism, DRC shifted to right without reducing efficacy. So efficacy is same. Whereas in the presence of non-competition, the curve will come down. That way efficacy decreases. This and all important you should know. Okay. And finally, after understanding log dose response curve, next question. Can I answer one question? Look here. Imagine it's a x-axis, log dose value, y-axis, response value. My question starts. Here I am starting dose, increasing dose, increasing. I am getting a graph. See, it is one drug. It's a dose response curve of one drug. One drug A. And imagine it is a dose response curve of next drug called drug B. And one more drug here, this drug C. Now question goes to all people. Anybody? Drug A, drug B, drug C. In these three drugs, which drug having less efficacy or least efficacy? Come on, least, least. Drug A, drug B, drug C. In this, which having least efficacy? That is, efficacy means look at height. Here, drug C is the least efficacy. Yeah, very good, very good. And one more question, which is most important? Most potent among three drugs, which is most potent? Potent mean ED50. Now tell me A, B, C among three, which is most potent? Most potent is drug A. Drug A is most potent. Like that, you should know potency, efficacy, paste question. Okay. And then therapeutic index, very important. Therapeutic index measures the margin of safety. Safety. It's a margin between LD50 and AD50. It's a ratio between LD50 and AD50, and it indicates safety margin. It is what most important. Therapeutic index of a drug indicate drug safety margin. Safety margin. Suppose if I say a drug having wide index mean it is more safe. More safe. For example, penicillin, a beta lactam antibiotic having wide index, so more safe. Therapeutic index a narrow margin. Window mean for example, window mean, come on, suppose it's a window. This dose producing action, this dose maximum action, beyond which toxicity. Here less than this mean no action. So one particular dose, the action starts. One particular dose, action, high action. So when you go less dose, no action. When you go high dose, more problem. This is called therapeutic window. Okay. Now look at drug having narrow index needs close therapeutic drug monitoring. For example, I have something called lithium, something called digoxin. All are having narrow therapeutic index. Okay, LD50 means lethal dose 50. Lethal dose 50. The dose at which I'm getting 50% maximum death. Okay, LD50 means lethal dose 50. The dose at which I'm getting 50% maximum death. Now tell me, lithium digoxin having narrow index. That means they need monitoring. That means we have to estimate. We have to estimate the plasma level of the drug periodically. Okay, and then this I told index, and very important. Warfarin, a oral anticoagulant, it is also one of the example for drug having narrow index. My doubt starts now only. Look here, I told lithium digoxin have a narrow index. For them, we know medium by assessing the drug level in the body, whereas warfarin having narrow index. Now the question starts: how are you assessing? How are you assessing safety of warfarin? Or warfarin safety assessed by what? Are we estimating the plasma level of warfarin? No, we assessing by using INR, International Normalized Ratio, INR. Okay, INR, International Normalized Ratio. So INR is used to monitor the safety of warfarin. INR, formula INR equal to patient prothrombin time, patient prothrombin time divided by patient PT by control PT. PT means prothrombin time. So question. So it divided by INR. Lower the INR, safe. More INR, more danger. Like this. Okay. So in dynamic, we covered receptor and then dose response curve based question and some therapeutic index based question, and finally clinical trial based question and some adverse drug reaction based question. Ready? Trial. Testing the chemical in human model is called clinical trial. Here, first, we have one thing called phase zero. Phase zero. It's called micro dosing study. Here, MCQ, what is the maximum dose of drug in case of phase zero trial? Here, 100 microgram or 1 by 100th of the estimated dose. So, question. Log do response curve be starting from low value to high value. It is always having sigmoid shape only. Okay. Some toxic drug may have narrow index, they may have steep curve. Now look at this. In phase 0 clinical trial, what we do? Here the MC will be what will be the maximum dose of the trial drug. It can be up to 100 microgram or 1 by 100th of the maximum dose. This is what MCQ. And then in phase 1, phase 2, phase 3, phase 4. What about? Hey, what is GPCR? Oh my God. Adhika, GPCR mean G protein coupled receptor. Here we have something called phospholipase pathway called GQ pathway. One more thing, adenyl cyclase pathway where GS and GI pathway. Like if you want, I will look here. This is Adhika example. Okay, Adhika GPCR. Just watch GPCR. We are having one thing called adenyl cyclase pathway. One more thing called phospholipase pathway. In adenyl cyclase, we have cyclic AMP as a second messenger. In phospholipase, we have IP3 and DAG as a second messenger. Now, all the muscarinic receptors are GPCR. In that, M2 M4 or GI. That is the adenyl cyclase are two types. One is called GES, one more thing called GI. GES means stimulatory, I mean inhibitory. So all muscarinic receptors are G protein couple where M2 M4 GI, M1 M3 M5 GQ, M1 M3 M5 GQ. Okay. Similarly, phospholipase C, for example, alpha 1 receptor, B1, all are GQ receptor, they're going to produce IP3 DAG as a second. Okay. Okay. Now, these are some examples. Now, concentrate on, we are discussing clinical trial. That's here phase 0 or phase 1. In phase 1 trial, 2 point you should know. It is done in healthy volunteer done by clinical pharmacologist, and here the main aim is to assess safety and tolerability of the chemical. Okay. Remember, phase 1 trial done in healthy volunteer is done by clinical pharmacologist, and here the aim of the study is to know safety and tolerability. It's purely PK, pharmacokinetic study. We are not testing for efficacy. Okay. And then phase 2. In phase 2 trial, we are testing first in patient. First in patients with the particular disorder. Suppose if I want to do trial on drug for rheumatoid arthritis, mean I will include rheumatoid patient. If I testing for diabetes, mean I will include diabetes patient. So phase 2 trial, first we are including patient with the disease, and here aim is no efficacy and safety in small group of patients. Okay, it can be single center study, it can be single blind also. So question, phase 2 trial can be single blind study, single center study in small number of patients. Aim is to know efficacy. But to confirm the efficacy, I want to do phase 3. So very important. Phase 3 trial is the confirmatory. It's a confirmatory of efficacy. The question, the efficacy will be best established. In which phase of clinical trial, there's a best establishment of safety. It's phase 3 because we are doing a large number of population in multi-centric and double blinding study. So it's the best way to confirm the result of phase 2. So it's a large number of study, phase 3 trial. Okay. After phase 3 trial, okay, I will come later here. We do one thing called new drug application. That is, after doing phase 3 trial, we collect information from all center and we make an application. So new drug application is done after completing phase 3. This application sent to drug controller in India or FDA in America, and they go to report. If they convince, they approve. Once chemical approved, it become drug. Once approved, it become marketed. Even after marketing, we do trial. That's called phase 4 trial, also called as post marketing. Called post marketing study. Here, no time limits and no need of ethical clearance, and any number of years we can do. The purpose is to know any long-term adverse effect is there or not. To know long-term safety, any new adverse effect occurring or not. This is called phase 4 trial, called post-marketing study. Okay. And then we now go for last adverse drug reaction. The last one more small point in GP classes, adverse drug reaction. There are so many type of ADR. For example, a predictable dose dependent ADR, or I know adverse we can be predictable, sometimes unpredictable. For example, what is side effects? Side effect mean unavoidable reaction that occur even on normal dose. I just give normal dose. Normal dose. For example, zero point 0.6 mg of atropine. Even for this dose, there's a dryness of mouth. Dryness of mouth. It is unavoidable. Question: a unavoidable reaction that occur even on normal dose is called as side effect. And then here I told already INR here mistaken. So it's INR is a international. INR mean international number ratio. It's for our point. So alignment get altered. Sorry for this mistake. Leave it. Okay. Now look at this idiosyncrasy. It's a genetically mediated adverse reaction. For example, some drug causing problem only in some genetically abnormal people. For example, I have some drug called primaquine. Primaquine, an anti-malarial drug. It causes hemolytic anemia only in people with G6PD deficiency. That's called idiosyncrasy, or it's also called pharmacogenomics or idiosyncrasy. Yes, good. Soumya, you are good, ma. Good. And then, look here. The one thing called tachyphylaxis. Tachy mean rapid development of tolerance called tachyphylaxis. For example, some drug like ephedrine rapidly developing tolerance called tachyphylaxis. Okay. Diksha, for dose which initial phase 1 itself, for the dose. What is the dose I have to start in human? That's called phase 1. The purpose of phase 1 is how much dose I can go. What is the maximum? What is the maximum tolerable dose? Up to what dose I can go? That's called phase 1. In phase 0, microdosing, only 100 microgram. Whereas in phase 1, we are testing the dose. How much is dose I can maximally go for that? Okay. Now look here. This is old question. Look here. Ceftriaxone, one of the antibiotic. Overuse of antibiotic can cause infection. It is called super infection. So pseudo membranous colitis. Pseudomembranous colitis. It is one of the adverse effects of ceftriaxone. So ceftriaxone induced colitis is an example for super infection type of ADR. I told already atropine, even on normal dose causing dryness of mouth, it is called side effect. Atropine induced dryness of mouth called side effect. And then ADR can be type A or type B or type C. Like what type A? Type A. A mean augmented response. Augmented. That is, I know when the dose increases, it going to cause problem. It is called predictable problem. I can able to predict because it's a dose dependent reaction. For example, normally insulin controlling sugar. Normally insulin sugar. When I increase the dose, I know definitely it's going to cause hypoglycemia. This type of area is called type A. A means augmenting the response. I know it's going to happen. Then type B. B mean bizarre. Bizarre. Bizarre mean I'm not able to understand why this problem occurred. It is called unpredictable. For example, I have a drug called penicillin. I know it's a very good drug, very good margin safety, very wide safety margin, very good safety margin, but in some people causing allergy, anaphylaxis, so-called bizarre reaction. We don't know what is happening. Okay. And then you should know something about teratogenicity. Very important, very important. There are so many drugs unsafe in pregnancy. Some drug causing fetal ADR, they call teratogenicity. I just listed some important point. Remember, thalidomide causing phocomelia, called C limb, called C limb. Absence, there's a limb, but is there? Limb is not gone fully. One question to all people. Anybody? By what property thalidomide causing C limb problem? Yes, VGFR, vascular growth factor receptor antagonistic property. By VGFR antagonism, it blocks the vascular supply, thereby limb buds are not grown fully. Okay. Isotretinoin is a vitamin A. It's a teratogen causing maximally craniofacial problem, mostly craniofacial abnormality, sometimes causing cardiovascular problem also. Warfarin, oral antigen causes warfarin fetal syndrome. It's called Conradi syndrome. Conradi syndrome, where nasal bone hypoplasia and the stippled epiphysis. So, warfarin causing Conradi syndrome. All anti-epileptics are teratogen. Remember, valproate, most teratogenic anti-epileptic causing maximum neural defects. Phenytoin causing fetal hereditary syndrome. The mnemonic CPM, cleft lip, phalanges, phalanges abnormality. M for microcephaly, small size head. And thiamide, that means anti-thyroid drug like methimazole, carbimazole, PTU. Remember, the methimazole maximally teratogenic causes aplastic cutis and corneal atresia. In this junction, can I please answer? Name the thiamide that is relatively safe in pregnancy. Name the thiamide. Answer PTU. PTU can be relatively safe in pregnancy, that too for first trimester. First trimester. For first time we can use PTU. But when you give PTU chronically for more than 3 months, the mother may develop liver damage. So it is best for first trimester. From second trimester, we can go for methimazole. Very good, man. Very good. All are following. Good, good, good. And then remember, among the antihypertensive, SVT or ARBs are absolutely unsafe in pregnancy. They causes renal and pulmonary agenesis. Antihypertensive AC inhibitor and ARBs are absolutely unsafe causes fatal renal and pulmonary agenesis. Agenesis. The kidney and lung will not develop adequately. Tetracycline is a very dangerous drug affecting both mother and baby. For the baby, it causes discolored teeth and also abnormality in bone growth. For the mother, it causes liver damage. So, affecting both mother as well as baby. So, relate it's a very very unsafe drug in pregnancy. Okay, like that, some teratogen you should know. And finally, finishing question. Pharmacovigilance. It's a branch of medicine dealing with detection, monitoring, and taking action regarding adverse drug reaction. Reporting, stuck. Waste. Methimazole, methimazole, carbimazole, both are causing. But carbimazole pro-drug, man, come on. Carbon is a pro-drug. Only we are using methimazole. Okay. Carbon is a pro-drug. The active form is methimazole. That's the one we are commonly using in practice. So question, when I say aplasticutis or coinatasia, I mean mainly methimazole. Okay. Okay. Now listen. Vigilance means there is reporting, detecting, and taking action for adverse drug reaction. That is called vigilance. Okay. So monitoring, preventing adverse reactions called vigilance. Okay. Now, post, I told this already. This comes alignment mistake. Post marketing is called phase 4 trial involving, and then Vigi base, also called Vigi blow, Vigi flow. That is, it's a software through which we are reporting ADR. For example, in my medical college, in medicine department, there is one adverse effects. A PG or a assistant professor in their ward will report the ADR to my pharmacology department. I will report this ADR through VigiFlow software into nodal center. From the center, the report goes to this one that is called National Coordination Center located in Ghaziabad. So question, a patient or a doctor or a staff nurse will send a reports. That report goes to pharmaca department. From department through VigiFlow software, this area goes to nodal center. From the center, it goes to Ghaziabad. And in other countries, India, we send into Ghaziabad. In other country, all this sent to WHO, World Health. For example, Uppsala Center, locates to Uppsala Center, location Sweden. So ultimately, all the report goes to Uppsala Monitoring Center, located in Sweden, and they will see all the reports. The reports called signal. Signal mean detection of ADR through these reports. Based on the report, they will action whether the drug can be stopped or can be given warning signal. All these things, the action can be taken. So vigilance means a branch of medicine dealing with the detection, reporting, analyzing, take action for the adverse drug reaction. It is called as vigilance. Okay. So up to this, we finish something called general pharmacology. So live rapid revision. First chapter GP over. Okay. If you attended my regular class, and this revision class and some T&D paper or monthly month our GT and CB test. If you attend everything properly, you are the one going to get first to 5 to 10 rank, man. I'm damn sure. Okay. So dedication to the course is most important. Regular class notes, your GT notes, your CPT notes, and division notes. Then DVT. If you go through all these things, you are going to get the first 10 ranks. I'm damn sure. I'm damn sure. Okay. So after finishing this, now we move on to next system called ANS. Just once again. Small break, I know, and only 10:40 by 11 we go for break, man. Just because my plan is I have to finish uh, a morning session up to 12:30, 12:40 ANS. So another 20 minutes we go for something. By 11 we go for break. Okay. Hey, what man? Yeah. Yes, continue. How many chapter? Vivek asking how many chapter? It's not a chapter, it's a system. Half of the pharmacology. Okay, don't say chapter, half of pharmacology. In your PDF, if there is 56 page mean 28 page should be today. That's all. So in your PDF notes, if there's 56 page, I'll go up to 28. Up to AutoCAD, I'm planning to finish. Okay, we start. Yes, good. Look here. Tachyphylaxis and saturation. Come on. Rupandar bulge. Tachyphylaxis mean rapid. Within 2 days or within 3 days, action get decreased mean what? Tachyphylaxis. Saturation mean on suppose I give nitrate for 10 days or chronically, frequently, the receptor getting saturated, thereby action decreases. That's called tolerance. Okay. Yes. Pravina, Pawan, Bhavani, maybe soon to we discuss later on. Okay, we'll discuss later on. Okay. Where do we get the PDF, sir? Thama asking. So I am writing in this PDF and also I'm going to give to each department. I think they may upload the anecdote notes also. So don't worry. Listen, listen, listen. So now we start with the ANS doctor to start. Ready? Autonomic system. Very important. Listen carefully. First, I go for cholinergics. Here we have two things. One is called cholinergic, one more thing adrenergic. First, I go for cholinergic. You know, here acetylcholine is the neurotransmitter. So, first revision question, you should know drugs modifying synthesis, storage, release of ACH. Okay. You know, the rate limiting step in the synthesis of ACH is choline uptake. The choline uptake is the rate limiting step in the synthesis of ACH. This step is blocked by hemicolonium. So choline uptake blocked by hemicolonium. Okay. And then once acetylcholine gets synthesized, the synthesized acetylcholine taken by vesicle. The after synthesis of ACH is taken by vesicle. The vesicular uptake of H blocked by vesa-michol. Okay. And then after synthesis, after entry into vesicle, it gets stored. The release of ACH, the release of acetylcholine blocked by what toxin? That is botulinum toxin. So botulinum toxin going to inhibit the release of ACH. So you should know uptake blocker hemicolonium, colon uptake blocker, and then vesicular uptake blocker vasamicol, release blocker by botulinum toxin. Okay. Now, in cholinergic, we have two important receptors. Acetylcholine acting on two things. One is muscarinic, one more thing nicotinic. So there are two main type receptor, namely muscarinic and nicotinic. Now, all the muscarinic receptors are G protein coupled. I told already. Here you should know M2 and M4 are GI receptor, whereas remaining M1, M3, M5 are GQ receptor. So anyway, all are GPCR. Yes, yes. When the inhibiting synthesis release mean they become anticholinergic. Yes, you are good man. Crunchy, you are good. Botulinum toxin, anticholinergic. Vasamicol, anticholinergic. You are right. Okay, now look here. First, I go for muscarinic receptor based MCQ revision points. Look here. We have M1, M2, M3, M4, M5. In this, only M1, M2, M3s are clinically studied. So, what are the important points? M1 seen on the stomach, it just going to activate the stomach causing release of acid. Stimulation of M1 causing acid secretion. Whereas clinically important question, M1 blocker, pyrancepine, useful for gastritis. That I'll come when I come into anticholinergic. Now concentrate on important muscarinic agonist. Very important, very important. Look here. M2 receptor mainly seen on heart. The drug activating M2 called methacholine, a selective M2 agonist methacholine. It causes mainly bradycardia. But one point, methacholine can be useful for diagnosis of asthma. It is called methacholine challenge. Methacholine challenge test. Methacholine challenge. So question, which is the cholinergic drug useful for diagnostic purpose? Methacholine, called methacholine challenge test. Okay. Then M3, very special, very special. Please watch. We have M3 receptor in the smooth muscle, in the eyes, and in the exocrine glands. Now look here. Cevimeline, a selective M3 agonist acting on the exocrine glands, promoting salivation, lacrimation, sweating. This property useful for treatment of xerostomia in Sjogren's syndrome. Okay. Why, sir? How, sir? What I am not understanding. My question, come on. Sudhakar, you're asking some doubt. I am not getting a doubt. What is the doubt? Increasing. M1 seen on this stomach. Stimulation of M1 receptor activating the parietal cell, causing acid secretion. That is physiology. Pharmacology, I will talk after finishing this because M1 blocker able to reduces acid secretion that can be useful for treatment of gastritis. Okay. Now concentrate on M3. M3 is seen on glands, exocrine glands. Cevimeline, very important, useful to promote salivation, lacrimation, sweating, useful for treatment of dryness of mouth. In case of xerostomia, also useful in Sjogren's syndrome. Remember one more point, we have one thing called pilocarpine, very important. The pilocarpine also having M3 action, two important points. It is available as an eye drop. As an eye drop acting on M3 in the eye, causing people constriction, thereby increasing the drainage aqueous through canal Shellman by promoting drainage aqueous useful for glaucoma. So question, a cholinergic drug useful for glaucoma, pilocarpine. It is by promoting drainage and it is also available as oral tablets useful for treatment of xerostomia. So remember, there are two important cholinergic drugs useful for treatment of xerostomia. One is pilocarpine, one more drug called cevimelin. So question, pilocarpine and cevimelin both are M3 agonists. N3 agonists. Hey, methacholine challenge test. Okay. Methacholine mainly acting on M2. So usually they don't cause bronchospasm. But in some people, it may act on M3 minimally. Even the minimal action can cause bronchospasm. Usually, methacholine acting mainly on M2. Very less action on M3 that is not at all significant. So normally for you and for me, methacholine never cause bronchospasm. But in a sensitive patient, in a asthmatic patient, even the small action of methacholine may cause bronchospasm. This property is useful for diagnosis of asthma. Usually, methacholine do not cause bronchospasm. It's very insignificant. But this become problem in asthmatic. That property useful for diagnosis. If I give methacholine, usually you don't get bronchospasm. Even for methacholine, if you have bronchospasm, you are asthmatic. That's called methacholine challenge test. Okay. Now concentrate on next. Bethanacol, very famous question you should know. Bethanacol, a selective M3 agonist acting on smooth muscle of GAT by activating intestine smooth muscle, also acting on GAT and on bladder muscle by activating its prokinetic property by promoting motility useful for treatment of post-op urinary retention and post-op paralytic ileus. This one you should know. Methanacol, a cholinergic drug having prokinetic property that is promoting motility, thereby useful for treatment of post-op ileus and post-op urine retention. Very important. Okay. And then we have something called indirectly acting drug. We call anticholine esterase. See, all these drugs are directly acting on M3 or M1 or M2. They call directly acting cholinergics. But we have something called indirectly acting. That means by inhibiting choline esterase enzyme, they call anticholinesterase. We have two types. One is reversible, one more thing irreversible. Please concentrate. Very important. First, we go for reversible anticholine esterase. In that, first I go for neostigmine. Next to the next table, very important. Neostigmine, one of the reversible anticholinesterase. It has action. It has direct action on NM also. It is actually indirectly acting, but also has good action on NM. By activating NM, useful for treatment of myasthenia gravis, it's going to improve skeletal muscle contraction, improve skeletal muscle power. This property useful for treatment of myasthenia. Also useful for reversal of non-depolarizing skeletal muscle relaxation. So neostigmine popular uses of useful for myasthenia gravis as well as useful for reversal of non-depolarizing. Okay. And what is special property? Neostigmine is a quaternary ammonium compound that does not crosses blood-brain barrier. It has no CNS action. Very important. It has no CNS action. Okay. Next is Phytoestigmine. Very special, very special. What? Phytoestigmine, a anticholinesterase, excellently useful for treatment of myasthenia because it is a longer in duration action, orally effective drug. So, 2 point lecture. The two most important drugs from cholinergic useful for treatment of myasthenia are one is neostigmine, one more thing pyridostigmine. Both are useful for this, but you should know among the two, the most preferred drug is pyridostigmine because it is orally effective and long in duration action. So wonderful drug, very good and most accepted drugs for treatment of myasthenia. Okay. Next question. Five source treatment. Very important. The five source treatment, super important question. This is lipid soluble drug easily crossing the blood-brain barrier. Because of crossing blood barrier, it has CNS action also. Because of having CNS action, it's a wonderful drug of choice for treatment of atropine poisoning. Atropine, the so-called belladonna poisoning or datura poisoning. So question, the best drug of choice for managing atropine poisoning, physostigmine, because it will control both peripheral and central adverse effect of atropine. So this is very, very important, very important. The best drug of choice for treatment of atropine poisoning, physostigmine. Okay. Next question. Hydrophonium. Hydrophonium is a very, very, very shorter acting drug, acting only for 5 minutes only. And why short acting? It rapidly undergo excretion of kidney. Okay. Because of very short acting, it is useful only for diagnostic purpose in myasthenia, not for treatment. The test name is called Tensilon test or hydrophone test only for diagnostic purpose. Okay, and look at next. The last three drugs, wonderful, wonderful drug. For example, donepezil, rivastigmine, galantamine. These three are having CNS action, and are very useful for treatment of Alzheimer disease. Very important, very important. Name the cholinergic drugs useful for treatment of Alzheimer. Donepezil, rivastigmine, and galantamine. Look here. In Alzheimer disease, there's a deficiency of acetylcholine in the brain. So, donepezil, rivastigmine, galantamine are cholinergic enhancers useful in the treatment of Alzheimer. Extra point, remember, the rivastigmine can be useful in Parkinson patient to improve the memory. So to improve the memory, cognitive thinking in Parkinson also. Okay. And one more thing, the rivastigmine can be given as a patch. So name the cholinergic drug available as a patch for treatment Alzheimer mean think of rivastigmine. Nowadays, donepezil patch also under development, but single response question go for rivastigmine patches are available easily, can be easily given. Okay, right. But one thing you should know, I have one drug called Tacrane. Tacrane. It is also only drug, but we don't use it for Alzheimer because it causes adverse effect of severe hepatotoxicity. It causing severe hepatotoxicity, so not in use. Okay. So far we done something about reversible anticholinesterase. Now we want to irreversible. Small spelling mistake in your book. Please make one here. Irreversible. Irreversible. Solution. Topic is irreversible. Okay. Here we are having organophosphorus compounds. So very important question. OPC. Organophosphorus compounds. Okay. When you say organophosphorus compound, we have something called parathion, malathion, dissonance. All this called insecticide useful in agriculture. Look here. The organophosphorus compound inhibiting choline esterase enzyme by binding with esterase only. Look here. The choline esterase enzyme has two sites. One is anionic site. One more thing called esteratic site. Esteratic site. OPC, organophosphorus compound, inhibiting cholinesterase enzyme by binding with esteratic site only. Okay. And remember, for treating this patient, actually, they are going to inhibit cholinesterase, they will be accumulating acetylcholine. The accumulated acetylcholine going to have muscarinic and nicotinic manifestation and most of them muscarinic manifestation. That's why for treating this toxicity, first I go for atropine. Atropine, a anti-muscarinic agent. That's the one first line drug of choice for treatment of OPC poisoning because most symptoms of cholinergic symptoms like salivation, lacrimation, sweating. So all these symptoms controlled by atropine. So the first line drug of choice for treatment of OPC poison atropine. But atropine will control only muscarinic symptom alone. So for complete treatment, I have to reactivate choline esterase enzyme. Further, we go for oximes. Remember, oximes are a group of drug called as choline esterase reactivator. We have pralidoxime, obidoxime, and diacetyl monooxime. So remember, oximes are called as choline esterase reactivator. We're going to reactivate choline esterase. We are having praldoxin, obidoxin, and diacetylmonoxin. That's about treatment for OPC. And here in organophosphorus compound, we have something called nerve gas. Nerve gas. For example, Aben, sarin, so on. They call nerve gas. Same thing. They also binding with the acidic sites and causing problem. They call war gas or nerve gas. And for this also treatment same. At first atropine followed by paradoxum. And in severe respiratory problem, go for admission with ventilation, all these things. Okay. And oxime binding with the anionic site. See, OPC compound bind with the acidic oxime binding with the anionic site of the enzyme and causing enzyme reactivation. Okay. And look here. We have one thing called carbamide group of drugs. For example, carbaryl, ropoxam. They call carbamide group. The carbamide groups are binding with both anionic and acidic site. So here, treatment is only atropine. Here, oximes cannot be used because oxime need anionic sites. Here, both the sites are occupied. So, for treatment of carbamide poisoning, there is no role for oxime. Okay, oxime only useful only for OPC, not for carbamide poisoning. There are a lot of muscular symptoms, but the regarding atropine used still atropinization. That means until the people start dilating, until the heart rate becomes more than 100, until there's a dryness of secretion. The dryness of airway secretion is most important sign. Until then, you have to keep on you atropine. Okay. And then regarding irreversible drug, we have one thing called ecotherapy. It is also one of the organophosphorus compound called irreversible anticholinesterase. Actually, this drug once upon a time it was used for glaucoma. It was used for glaucoma, but today we don't use because causing adverse effect of severe cataract, so it's not in use. So question, ecotherapy, one of the organophosphorus compound, it was once upon a time used for treatment of glaucoma, but today we don't use because of causing problem of cataracts. Okay, and then just two more. If I finish two more, cholinergic against over, and then we go break. For example, we done reversible and irreversible anticholinergics. Next question, drug therapy for Alzheimer. So very important area for MCQ. Just a rapid revision, revise. Look here. In Alzheimer, there is a problem of reduction of ACH. So, for treating this case, the first line drug of choice will be giving anticholinesterase. They going to increase this acetylcholine level. They call this cholinergic enhancers like donepezil, rivastigmine, galantamine. In this, rivastigmine can be given as a transcranial patch. So topical drug. This we done already. Okay. Now, apart from cholinergic, the other drug useful for Alzheimer is called NMDA blocker. Very important. Very important. Find out the NMDA blocker useful for Alzheimer. It is memantine. Memantine. It is useful for moderate to severe Alzheimer, not for mild case. It is got approval for moderate to severe Alzheimer cases, and it can be given as a combination also. Memantine can be used as a combination with donepezil. And finally, there is something called monoclonal antibody useful for Alzheimer. For example, we have something Lena, sorry, lecanemab, aducanumab, and donanemab. Very important. And lecanemab, aducanumab, and donanemab. In this junction, my small doubt goes to all people. Please answer. All this MAB, I want to know target. They are targeting against what? They targeting against what? Any idea? They are targeting against beta amyloid. Amyloid solution. Lecanemab, aducanumab, and donanemab all are targeting against beta amyloid, useful for treatment of Alzheimer. Okay, and finally, one question called drug therapy for myasthenia gravis. This is also very important area. Please watch. In myasthenia, fundamental problem, there is a weakness. So to improve the muscle power, we go for cholinergic drug. The two most important anticholinesterase, the so-called cholinergic drug useful for treating myasthenia of pidostigmine. One more drug called your neostigmine. Look here. Pidostigmine, neostigmine, both are cholinergic. In this, pidostigmine, the most wonderful first-line drug because orally effective, longer in duration action. So, the most preferred is pidostigmine. Now, myasthenia gravis, a autoimmune disease. Whenever you talk about autoimmune disease, for overcoming the autoimmunity, we can plan for thymectomy. Thymectomy, because thyme is the one releasing autoantibody. We can plan for thymectomy. Okay. And after thymectomy, to overcome the autoimmunity, we can go for immunosuppression like steroids, prednisolone, or some other immunosuppression like azathioprine, mycophenolate, and cyclosporine. All these things we'll discuss tomorrow in immunology class detailedly. Now just watch immunosuppression. And MEB is some more antibody. For example, rituximab, very important target, targeting against C20 and B cell. Rituximab and complement component C5 blocker like eculizumab and ravulizumab. So complement component C5 blocker like eculizumab and ravulizumab, useful for useful for myasthenia. One doubt I have, my question goes to all people. Can I please answer? Eculizumab, a complement compensatory blocker, also wonderful drug for treatment of what? It is also useful for treatment of paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. Okay. And then in case of severe myasthenia crisis for rapid recovery. Yeah, good man, good, fantastic, good. For rapid recovery, in case of myasthenia crisis, for rapid recovery, either we can go for IV immunoglobulin or we can go for plasma paresis, plasma paresis. So the option for rapid improvement in myasthenia, we go for either plasmapheresis or go for intravenous immunoglobulin. Okay, and what are latest? The latest drugs useful for myasthenia are one is called silicoplan. It's again complement compensatory blocker, and then we have something called neonatal FC receptor antagonist like F-gotimod, one more drug called rozanolixizumab. F-gotimod and rozanolixizumab are called neonatal FC receptor antagonist useful for treatment. Okay, the best treatment among all. Syed, first line choice will be pyridostigmine, followed by thymectomy. The best. In severe cases, I want rapid improvement, go for intravenous immunoglobulin or go for plasmapheresis. That's all. So single answer mean the best treatment, routine treatment mean first line choice pyridostigmine. In case of severe crisis, for rapid improvement, go for plasmapheresis or go for intravenous immunoglobulin. That's all. Okay. Now, we have done something about myasthenia, but you should know when you talk about myasthenia, you should know some drug to be avoided. Any drug having muscle relaxing property like SMR and even some antibiotics, like aminoglycoside and then macrolides, and then quinolone. They also having skeletal muscle relaxing property. Avoid using some SMR or avoid using some antibiotic because some antibiotic like aminoglycoside, macrolide, and quinolone they have muscle relaxing property. Okay. Okay. Now a small word about nicotinic receptor based question. If I finish this one table, we go break. Nicotinic. When you say nicotinic, NM stimulation causing muscle contraction. So NM blocker going to cause skeletal muscle relaxation. So what are the NM stimulant, blocker and reversal? NM receptor seen on neuromuscular junction. Nicotinic seen on skeletal muscle. Stimulation NM causing muscle contraction. So, for example, there are something called skeletal muscle relaxant. Actually, it is done by anesthetist. Anyway, I teach you one or two points. We have one thing called succinyl choline. It is one of the depolarizing SMR. That is, initially it causes contraction followed by muscle relaxation. It is called depolarizing SMR. And here, what I am saying, this drug fastest acting and shortest acting. It's used it's a fastest in onset of action in onset and shortest in duration action. Thereby useful for intubation. It initially causes muscle twitching called fasciculation. Later muscle paralysis. That's why it's called now it's a depolarizing SMR. And The short action, why shortest acting? The short action is due to rapid metabolism by pseudocholesterase. Very important, very important. So ultra short acting SMR, SMR, because rapidly undergo metabolism by pseudocholesterase, and it causes adverse effect of main problem, causes hyperkalemia and rarely risk of hyperthermia. Now I have small doubts. Succinylcholine causing hyperthermia, especially in burns patient, in nerve injury patient, there's a high risk of hyperkalemia. And you should tell succinylcholine causing hyperthermia. Please answer. This problem occur usually in a person having abnormality on ryanodine receptor. Not in all people. People with this ryanodine, they are prone for hyperthermia. And for treating this case, Dandrolin is the drug of choice. Dandrolin, one of the directly acting SMR, that is the drug of choice for this case. Okay, yeah, good. Now, here's something called non-deep SMR. For example, those drug name ending with the curare, like pancronium, vicronium, rocronium, atracorium, cisadim, are called non-depressive. They competitively blocking the NM action, causing muscle relaxation. They call non-depolarizing agent. Here, the atracorium, cis undergo Hoffman integration, so safe in liver disease, safe in kidney disease. This already. Now, one question. A patient undergone surgical intervention. During surgery, I given muscle relaxation by using these agents. Now, how to reverse the action? For reversal of this action, I go for neostigmine. Neostigmine is the one commonly useful for reversal because it's going to inhibit cholinesterase, thereby causing accumulation of acetylcholine, that going to improve muscle contraction. So, routinely, the reversal of SMR done by neostigmine can be given along with atropine, or along with glyco pyrrolate to overcome muscarinic problem. Okay, so usually with atropine or with the glycopyrrolate to overcome muscarinic adverse effect. Okay, and this one you should know. You would think of Suhamadex, very, 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 very important, very important. A latest drug useful for reversal of vicronium and rocronium. Such important, useful for reversal of vicronium and rocronium circumbandex. It's encapsulating and inactivating NM receptor. Okay, and this is it undergo renal route of excretion. So contraindicated in kidney failure. And ADR, it may cause alteration of taste sensation, altering taste. So the adverse effect alteration taste. One more thing, undergo renal route of excretion. So be careful in kidney failure. That finishes something about NM blocker. Now time almost 11:15. Take a small break for 10 minutes. Okay, take a break for 10 minutes, and then I start with the anticholinergic and then adrenergic, anti-adrenergic. Right? So small break, man. Just take a break. Okay, man. After finishing cholinergic, we now want anticholinergics to start. We have some specific selective M1, M2, M3 blocker and something called non-selective anticholinergic also there. We go one by one, right? So first, the selective M1 blocker names are pyrinsipine, tyrensipine, useful for treatment of peptic ulcer disease. I told M1 causing acid secretion, M1 blocker useful for treatment of gastritis. This question was old question. Find out the anticholinergic agent useful for treatment of gastritis. Answer pyrinsipine, TNC fine. Okay. Coming to next. We have something selective M2 M3 blocker. We now move next. We have M2 blocker galamine. It is not that much useful clinically, so it has limited use, affecting cardiac function, only experimental, not in use, leave it. But this is what very important. Please focus. Selective M3 blocker. We have something called darifenacin, solifenacin. These two drugs are acting on intestine as well as on bladder. So, as an anticholinergic, they have anti-motility action, reducing the peristaltic movements, thereby useful for treatment of overactive bladder, as well as useful for treatment of diarrheal, dominant, irritable bowel syndrome. Very important, very important. Darifenacin, solifenacins are anticholinergic having anti-motility effects, reducing the peristaltic movements, useful for overactive bladder as well as useful for treatment of diarrheal type of IBS. Okay. Another very important, please watch, please focus. Discussion among the group after in break hour. Now, please focus. I'm discussing one serious topic, very important topic called there are something called anticholinergics useful in asthma. See, M3 receptor causing bronchospasm. So M3 blocker useful for asthma. What are they? For example, look here. We have ipratropium bromide and tiotropium bromide. These two are muscarinic antagonists useful for asthma. Here, revision question. Look here. Ipratropium bromide is the short-acting muscarinic antagonist. Short-acting muscarinic antagonist. Tiotropium longer-acting muscarinic antagonist. So this you should know. Both of them useful for treatment of asthma and mainly useful for COPD. That is, anticholinergics are mainly useful for bronchodilation, useful for COPD. Here, what is important? For example, look here, ipratropium, a anticholinergic, a bronchodilator, but may cause paradoxically bronchospasm. This is old question. The reason for paradoxical bronchospasm can be it is given as a nebulized solution. In the nebulized solution, we have something called benzalkonium chloride, an ingredient, a preservative. So we adding this preservative, benzalkonium chloride. It may be the cause for bronchospasm. So question, which is the bronchodilator may cause paradoxically bronchospasm? Answer, ipratropium. It's due to its preservative like benzalkonium chloride. Okay, that's important. And then apart from ipratropium, tiotropium, we have other anticholinergic like actinium bromide, glycopyrronium bromide, even rivafenacin. Like that, we have some other anticholinergic useful for COPD. But the two main drugs are ipratropium bromide and tiotropium bromide, very important. And then, super important question you should know, there are some anticholinergic acting mainly on urinary bladder. They are called as vesicoselective anticholinergic. For example, we are having oxybutynin, tolterodine, fesoterodine, and trospium. All these are called vesicoselective anticholinergic, reducing the peristaltic activity, useful for treatment of overactive bladder. Oxybutynin, fluvoxate, tolterodine, fesoterodine, trospium are anticholinergic, useful for treatment of overactive bladder. And important question, oxybutynin. can be used as a patch topically as a patch also. Okay. Another very important point, the trospium, very special. Please watch. Yeah, direct also same. Yes, even this also the direct financing. So it's also very same only. Good. Now look at it. Trospium, very special. The trospium is a quaternary ammonium compound. It does not cross blood-brain barrier. One. Trospium, lipid insoluble, does not crosses blood-brain barrier. It has no CNS action. That's why trospium, very important, preferred for treating overactive bladder in Alzheimer disease. In Alzheimer, because in Alzheimer already there is a deficiency of ACH in brain. So all these are anticholinergic. So question can be, which is the preferred anticholinergic for treatment of OAB in Alzheimer? Mean think of trospium because it is lipid insoluble, has no CNS action. Okay, and next question. There is something called midriatic anticholinergic used as a midriatic, useful as eye drop. For example, atropine, tropicamide, and cyclopentalates all are. We have atropine, even homotropin, cyclopentalates, tropicamide all are topical anticholinergic useful as a midriatic. Here MCQ. Anticholinergic causing mydriasis plus cycloplegia, because mydriasis plus cycloplegia, that is paralysis of accommodation. What next? All other drugs will able to puja, all other drug will able to go to CNS, may affecting. So best is only trospium. If not, don't worry. They don't give like that question. Okay. So all other able to cross blood-brain barrier. Now look at this. Atropine, homotropin, cyclopentolate, tropicamide are causing mydriasis plus cycloplegia. Here, atropine is the longest acting drug. Because of longer in duration action, it is preferred in child of less than 5 years. In children, what the best mean? Go for atropine because children need longer duration of cycloplegia. Okay, and Tropic combine, very super important. It's a very shortest acting, very shortest. It's faster in onset of action, very short in duration action. So the most commonly used midriatic drug in practice, tropic combine. It is useful for midriatic purpose. It is the most common drug among the anticholinergic for midriatic purpose. Cyclopentolate moderate in duration action. Once again, you should know when you use midriatic agent, they dilate the pupil, thereby causing closure of angle of antechamber, thereby inhibiting or interfering drainage aqueous. So all these drugs will increases intraocular pressure. So anticholinergics are contraindication in patient with glaucoma. Remember, we discussed pilocarpine, a cholinergic drug useful for glaucoma, whereas anticholinergic worsens glaucoma. So anticholinergics are contraindicated in glaucomation. Okay. And then, so my next question, there are some anticholinergic having good action CNS. For example, we are having benztropine, trihexyphenidyl, the so-called benzhexol is very important drug called centrally acting anticholinergic, very useful for treatment of drug-induced Parkinson disorder. Centrally acting anticholinergic like benztropine, trihexyphenidyl, very good drug for treatment of drug-induced Parkinson disorder. Okay, and then very special, scopolamine, also known as hyoscine. It's an anticholinergic, very good. choice for treatment of motion sickness. Drug of choice for motion sickness. It is applied as a patch behind the pinna. Behind the pinna. Now I have doubt. My doubt goes to Pavani. Come on, Pavani. You are mentioning it's a patch. Okay, right. My doubt is this patch applied behind the pinna, behind the ear. My question, when to apply the patch? Option A, once vomiting symptoms starts or before symptoms start. If at all, what is the timing of applying the patch? Answer, it should be applied 5 to 6 hours before journey. Before journey. At least 4 hours. At least 4 hours before journey. Okay. 5 to 6 hours before journey. It needs at least 4 days. Okay. Sorry, so 4 hours. At least 5 to 6 hours before. At least 4 hours before journey. Okay. And it having sedative property also. On, because having sedative property, it can be tried for narco analysis because of very. But I have two more questions for you. Who is going to answer? The two more questions are anybody? See, normally for a case of motion sickness, the best drug of choice is scopolamine. If scopolamine is not there, mean what is the next option for motion sickness? We can try something called promethazine. Promethazine, a first generation antihistamine. This also tried. Once again, you should know for narcoanalysis, the best option go for thiopentone sodium. Thiopentone sodium is the best option for narcoanalysis. Okay, very good. Now, okay, there are some anticholinergic useful in anesthesia. For example, atropine used as a pre-anesthetic medication to control secretion. But comparing to atropine, best is go for glycopyrrolate. Very important, very important. Among the anticholinergic, it is the most preferred drug for pre-anesthesia because it does not crosses the blood-brain barrier, so no CNS adverse effect. So question, among the anticholinergic, the most preferred anticholinergic for pre-anesthetic medication is glycopyrrolate. This is also very important anesthesia question. Okay, of course, atropine, a anticholinergic for treatment of atrial poisoning, the specific antidote will be physostigmine. One, it is lipid soluble drug able to cross blood-brain barrier, going to control both CNS and peripheral symptoms of atropine. Atropine poisoning, also called as belladonna poisoning, also called datura poisoning. For this case, the specific antidote is physostigmine. Okay, that finishes something about anticholinergic. Now we move to the second part of ANS, so-called sympathetic nervous system. A lot and lot of points I'm going to discuss. Listen carefully. Come on. Topic name. When you say adrenaline, it's also called sympathetic nervous system. Here we have norepinephrine as a neurotransmitter. So I'm going to cover sympathetic agonism and blocking antagonism, both parts. So first question I'm going to revise sympathetic agonism, that do drugs affecting synthesis. Cotinine ammonia compound mean lipid insoluble. They don't cross us membrane barrier. Pressure mean lipid soluble, able to cross. That's all. Okay. Scopolamine having sedative property. It's a sedative. By causing sedation in drowsiness, I can extract the truth. What happened? Tell me. Come on, tell me. Like the extracting. It's called narcoanalysis or lie detection. Also called truth serum. Okay. So because of sedative property. Scopolamine, because of its sedative property, useful for narcoanalysis. That's all, man. Okay. Now concentrate on drug affecting synthesis storage, release, metabolism based questions on norepinephrine. Okay. See, norepinephrine synthesis by so many steps. The first step is tyrosine become dopa by tyrosine hydroxylase. Okay. Tyrosine hydroxylase, it's a rate limiting enzyme. Rate limiting enzyme in the synthesis of norepinephrine. Actually, first step, tyrosine become dopa by tyrosine hydroxylase. It's the first enzyme involved in synthesis of norepinephrine. This is called rate limiting enzyme. This enzyme inhibited by meat tyrosine, very important. Meat tyrosine inhibit tyrosine hydroxylase enzyme, thereby inhibiting synthesis of norepinephrine. And this drug useful in case of pheochromocytoma, very important. Pheochromocytoma, a tumor of adrenal medulla synthesizing excessive amount of norepinephrine. So, in case of catecholamine tumor, in this tumor, to control the synthesis of norepinephrine, I go for meat tyrosine, point one. Second, the second step is dopa become dopamine by dopa decarboxylase enzyme. This enzyme blocked by our carbidopa and benzerazide. The second step is dopa become dopamine by dopa decarboxylase. This step is arrested by carbidopa and benzerazide. These drugs are useful in Parkinson patients. See, I give one drug called levodopa. Levodopa is a prodrug. It has to become dopamine in the brain. But what happens? When they take little orally, the levodopa in periphery, this before crossing the blood barrier, in periphery, it can become dopamine by dopa decarboxylase. So to prevent this, I am adding with dopa decarboxylase inhibitor like carbidopa and benzerazide. The second step. And then after synthesis of dopamine, the dopamine taken by vesicle, it is done by VMAX, vesicular monoamine transporter. Monoamine transporter. Now look here. The VMAT can be blocked by so many drugs. For example, reserpine. Reserpine, one of the VMAT blocker, vesicular monoamine transport blocker. It was used for hypertension. Reserpine was used for hypertension, but today we are not recommending this because it causes adverse effect of severe depression. So reserpine we don't recommend for hypertension causing severe depression. These two are very important. You should know. You should know. For example, here's something called tetrabenazine and one more thing called valbenazine. See here, tetrabenazine, one more drug called tetrabenazine. Both are B-match blocker useful for treatment as a drug of choice for Huntington chorea. Tetrabenazine and deutetrabenazine are drug of choice for Huntington chorea. And one thing called valbenazine, super important new drug, B-match blocker. It's a FDA approved drug for treatment of tardive dyskinesia. It's one type of EPS, following antipsychotic therapy. So for treating tardive dyskinesia, a FDA approved drug is valbenazine. Very important, very important. Okay. After that, some extra point actually. Once there is a synthesis of norepinephrine, the synthesized norepinephrine now getting released from a vesicle. The release of norepinephrine can be blocked by something going to stimulate. For example, which are the drugs going to stimulate the release of norepinephrine? For example, look at the norepinephrine is stimulated by something called amphetamine, ephedrine, thiramine. I'm going slow. Please watch. Amphetamine acting on vesicle, causing release of norepinephrine. Whenever a drug increases norepinephrine level in the brain becomes stimulated. So called stimulant. So CNS stimulant. Any drug increases norepinephrine level in brain acting as a CNS stimulant. This is going to improve the attention span in ADHD. So one of the stimulant type of drug useful in ADHD, amphetamine, but it causes lot of problem. For example, it causes growth retardation, appetite suppression, cardiotoxicity. So we don't recommend this. Anyway, keep in mind, amphetamine, one of the CNS stimulant. It can be used to for ADHD, but lot of problems are there. So how to treat ADHD? That I discuss tomorrow. In CNS, I'm going to discuss ADHD in detail. Wait for some time. Now, ephedrine. Ephedrine, a drug acting on vesicle and causing release of norepinephrine, and it's also acting on sympathetic receptor directly. It acting on vesicle as well as on receptor. It going to have vasoconstriction. It causing vasoconstriction. Because of this property, sorry, because of this property, it is useful for treatment of nasal congestion and for treatment of hypotension. Remember, ephedrine acting on vesicle, causing release of norepinephrine, useful for treatment of hypotension as well as for nasal congestion. And thiramine. Thiramine acting on vesicle and causing release of norepinephrine. Here, MCQ. There are some food, come on, there are some food item containing thiramine. For example, cheese, wine, bread, all these are thiramine. So when they take thiramine food item, they're acting by releasing norepinephrine. This may cause hypertensive crisis, especially a patient who is on MAO blocker, monoamino oxidase enzyme inhibitor. Look here, the norepinephrine, one of the monoamine. So look here, a patient on MAO blocker, when they take thiramine food item like cheese or wine or bread, they will land on severe hypertensive crisis. It is called a cheese reaction. Now question goes to Ayut Jain and Tanya. Can you please answer? A patient on MAO inhibitor taken thiamine food item landed in hypertensive crisis. We call cheese reaction. Now question, for treating this cheese reaction induced hypertension, what is the best antihypertensive? Yes, good. It is phentolamine. Phentolamine, a non-selective reversible alpha blocker. Very good, ma. Very good. Phentolamine, a non-selective reversible alpha blocker is the choice. Good, fantastic. Okay, good. Now, once there's a release of norepinephrine, the release norepinephrine undergo metabolism by two enzyme. One is called MAO, one more thing, COMT enzyme. Solution, monoamino oxidase and catechol O methyl transferase are enzyme involved in metabolism of norepinephrine. And you should know the MAO blocker names. We having something called sertraline, rasagiline, useful for treatment of Parkinson. This we discuss in CNS class. Wait for one day. And COMT blocker like entacapone, tolcapone, useful for treatment of Parkinson disorder. Okay. Now, MAO blocker, CMT blocker, we will discuss tomorrow in CNS detailing. Now, next very important, you should revise this. The norepinephrine undergo undergo termination. Termination of action of norepinephrine is by reuptake. So question, if you want to have more norepinephrine, you should do inhibition. So what are the norepinephrine reuptake inhibitors? For example, cocaine, majority of antidepressants like SNRI, then NDRI, TCA, all are having norepinephrine reuptake inhibitory property. Okay. For example, one by one, cocaine. Cocaine end the cane. Any drug name end the cane mean they call local anesthetic agent. Now look here. Cocaine, I know a local anesthetic, but inhibiting reuptake of norepinephrine. That means it's going to accumulate norepinephrine in the synapse. That means it's a sympathetic stimulant. Because of this, it may cause adverse effect of hypertension. So question, the one and only local anesthetic agent has the risk of causing hypertension is cocaine. Usually, all the local anesthetic causing only hypotension. The one and only local anesthetic causing hypertension, cocaine. Okay. And then TCA, SNRI, NDRI, this and all antidepressant we discuss tomorrow. All about NDA, NDRI, SNRI, TCA we discuss detailedly tomorrow in science class. All are having reuptake, norepinephrine reuptake inhibitory property. So far in this table we covered drugs affecting synthesis, storage, release, metabolism and reuptake of norepinephrine. Now we want to sympathetic receptor based question. See, we have alpha, beta receptor. In alpha, we have alpha 1, alpha 2. In beta, we have beta 1, beta 2, beta 3 receptor. So one by one, I go for discussion. Very interesting. See, the advantage of discussion. See, actually, in my regular class, GP 4.5 hours, ANS 6 to 7 hours. But within 4 hours, I'm going to cover both. So rapid revision. If you revise comfortably, you can enjoy. Come on, see. We go for alpha 2. Alpha 2 receptor, point 1, seen presynaptically, location presynaptically. It is called autoreceptor. That means controller. Stimulation of alpha 2 will inhibit. Somebody asking, John asking, guanethrin. What is guanethrin? Guanethrin and beryllium are inhibiting release of norepinephrine. Come on. Sudhagar. Guanethrin and reserve and beryllium are sympathetic norepinephrine release inhibitor. Okay. Now concentrate on alpha 2. Alpha 2 is seen presynaptically. It is called autoreceptor. That means stimulation of alpha 2 will inhibit release of norepinephrine. Okay. We start. What are the special example for selective alpha 2 agonist? One by one discuss starts. Look here. Clonidine, a alpha 2 agonist, decreasing the release of norepinephrine, useful for treatment of hypertension. The main point, useful for hypertension. Okay. And it is also useful for Nirvadi pain as a adjuvant, as a supportive drug, can be useful for Nirvadi pain. But again, very important question. Main use for hypertension, other use can be Nirvadi pain, also tried for ADHD and for treatment of opiate withdrawal symptoms. So question, it can be used for ADHD, can be useful for opioid withdrawal symptom management. But again, you should know question for exam purpose. Look here, clonidine danger in the sense sudden withdrawal of clonidine causes rebound hypertension. This is what very important. Sudden stopping of clotting causes severe rebound hypertension. So clotting should never stop abruptly. Now question starts. Look here. Suppose a patient on Claudin one fine day abruptly stop the drug mean he may land on rebound hypertension. Question is for treating clonidine withdrawal induced hypertensive crisis, what is the best antihypertensive? Answer phentolamine. Phentolamine is the drug of choice for treatment of chlorine withdrawal induced hypertensive crisis. Yeah, good, 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 good. Okay. Next, we are having guanafacin. So, alpha agonist useful for ADHD, nothing special, can be supportive therapy for ADHD. And methyl DOPA, very special. So, super drug, alpha agonist useful for hypertension in pregnancy. Safer drug, no teratogenicity, very safer drug. But only one thing, it may rarely causes hemolytic anemia for the mother. So, question, usually it is a very safer drug, nothing harm. But rarely it may cause problem for mother. For the mother, it may cause hemolytic anemia. So, in this case, there's a positive result for Coombs test. So, question can be which is the anti-hypertensive cause positive result for Coombs test mean think of methyl dopa. Okay, once again, methyl is a prodrug. Prodrug, it is become methyl norepinephrine. Methyl norepinephrine. It's an active form. It's active form. So now it's a prodrug. Okay, right. In this junction, my small doubt, look here. I'm telling methyl dopa can be a safer drug for treatment of hypertension in pregnancy. But you should tell currently for treatment of hypertension pregnancy, who is the drug of choice? Currently, drug of choice is labetalol, a beta plus alpha blocker. That is the fantastic drug of choice. Okay. Okay, right. Next question. We are discussing alpha antagonists in that next is pisanidine. Look here. We're discussing alpha agonist. Pisanidine is centrally acting SMR. It's a skeletal muscle relaxant used for muscle spasm. Okay. May cause sedation and dryness of mouth. Main uses muscle action. Next is very famous expected question. Please follow. Dexmedetomidine, a alpha agonist. 3 point you should know. Point 1. It is used for sedating IC patient. Point 2. Used for anesthesia, pre-anesthesia in surgery patient for both the purpose given IV, whereas recently got approval sublingually for treatment of psychosis and for bipolar disorder. This is what important. This given sublingually for treatment of psychosis and for bipolar disorder. Okay. Then we have two special drugs called brimonidine and apraglutide. Both are alpha antagonists useful for glaucoma. These drugs are useful for glaucoma as eye drop. Both are eye drops. And how they controlling pressure? The mechanism action, they decreases aqueous humor production. Apraglutide, brimonidine, both are reducing the aqueous production. By decreasing aqueous production, useful for glaucoma. Both are eye drops, but point is the apraglutide brimonidine causing adverse effect. For example, apraglutide causing adverse from a lid retraction, brimonidine causing uveitis. Important. AD are also important. And then lofexidine, a alpha agonist, recently approved drug, approved for treatment of opioid withdrawal symptom, useful for treatment of opioid withdrawal symptom. And Morphine, a alpha agonist useful for hypertension. Like that, we're discussing so many examples for various alpha 2 agonists. Okay, now for completion purpose, I go for alpha 2 antagonist. Ready? Alpha 2 antagonist. Look here. I have yohimbine and idazoxanide. These are two important alpha 2 blockers. Here, most important is yohimbine. As the alpha-2 blocker, they increases release of norepinephrine. Because of this action, it is useful for treatment of orthostatic hypotension, as well as it can also improve sex feeling, thereby useful as a sexual mood, sex mood stimulant. So mood stimulant, sexual mood stimulant. So question. Yohimbine used as a sexual mood stimulant as well as useful for treatment of hypotension. But today you should know one thing. Look here. We have one thing called mirtazapine. It is an antidepressant. It is also alpha-2 blocker. By blocking alpha-2, increasing release of norepinephrine, this property useful for treating depression. It is one of the atypical antidepressant, mirtazapine, a presynaptic alpha-2 blocker, increases release of norepinephrine, useful for treating depression. And this drug also having, main point, it's a alpha to blocker releasing norepinephrine useful for treating depression. Very important. Extra point we discuss tomorrow in CNS class. Okay. Now we finish alpha 2 agonist, alpha 2 blocker. Next I'm going to alpha 1 chapter. Look here. When I say alpha 1, first I go for alpha 1 stimulant and then alpha blocker. Okay. First alpha 1 stimulant. See, we use alpha 1 receptor in the vascular smooth muscle. Vascular smooth muscle. Based on this location, my first MCQ, look here. I know some selective alpha 1 agonists like methoxamine, mephentermine, midodin. Please watch. These are selective alpha 1 agonists causing vasoconstriction. Vasoconstriction, they increasing blood pressure, they increase BP. So useful for treatment of hypotension. So here methoxamine, mephentermine, midodin. In this, these are injection, midodin oral drug. So orally given drug useful for orthostatic hypotension and dialysis induced hypotension is very important. Name the oral alpha 1 agonist useful for orthostatic hypotension. Answer midodrine. Okay. And then we have something called naproxen, oxymetazoline, and xylometazoline. All are alpha-1 agonists used as a nasal drop. Nasal drop used for treatment of nasal congestion. Useful for treating nasal congestion. But one doubt I have, the question goes to all people. Anybody? If I use this nasal drop, they cause nasal mucosal vasoconstriction, thereby reducing congestion, useful as a nasal decongestant. Okay, but you should tell. If a patient using these drops repeatedly, say 4 times, 5 times per day for more than 7 days or 10 days, repeated frequent administration of these drugs for more than 7 days, causing what? Very good mark, causing adverse effect of rhinitis, rhinitis mentosa or atrophic rhinitis. Good, fantastic. Okay, and then we want to recall phenylephrine. Its alpha 1 agonist can be given intravenously as well as given as eye drop. So, as a IV drug useful for hypotension, as a eye drop useful for metiasis. Remember, Alpha 1 again is causing only mydriasis without cycloplegia. Anticholinergic causing mydriasis with cycloplegia. Whereas alpha 1 is causing only mydriasis without cycloplegia. That you should know. Okay. Now we done alpha 1 agonist. And one important new point I want to tell you, the mind is when you talk about sympathetic system, you should know one thing called orthostatic hypotension. This year, I'm expecting this question. What are all the important drug recommended for treatment of orthostatic hypotension? Remember, for treating orthostatic hypotension, commonly given drugs are one is midodrine, that I discussed is alpha 1 agonist causing vasoconstriction. I told you. Next is droxidopa. Very important, very important. Droxidopa. It's a prodrug of norepinephrine. It's going to become norepinephrine useful for orthostatic hypotension. And one more drug, fludrocortisone, a mineral corticoid going to increase sodium water retention, thereby improving blood pressure. So question, the drugs useful for orthostatic hypotension are mainly midodrine, droxidopa, and one more thing, fludrocortisone. Okay. Next, after finishing alpha 1 agonism, we go for alpha blocker based revision point. When you say alpha 1 blocker, we have a lot of drugs like prazosin, we have prazosin, and we have tamsulosin, like the lot of drugs are there. Here is the question. The most common adverse effect of alpha 1 blocker mean postural hypotension. We call first dose hypotension. Postural hypotension are the common adverse effect of alpha 1 blocker. And in middle-aged male, they may affecting alpha 1 in vas defense, so risk of impairment of ejaculation, or we call retrograde ejaculation. So sexual problem. And then alpha blocker. Alphalocin has the risk of causing QT prolongation. Question: which is the alpha 1 blocker causing QT prolongation? Alphalocin. Okay. And now you should tell me. My first question. I have prazosin, I have tamsulosin. My doubt is, look here. My patient having BPH and hypertension. If both are there, mean for both he want one drug, mean what is the best drug for this case? Option A, prazosin. Option B, tamsulosin. What the answer? BPH and B mean go for first one. Yes, good. Prazosin. Whereas only for BPH alone mean go for tamsulosin. Okay, that you should know. Very good, very good. And see, these are selective alpha 1 blocker, whereas I have something called phentolamine and phenoxybenzamine. These are non-selective alpha blocker. Here, phentolamine, non-selective, reversible alpha blocker. That mean short acting. Non-selective, reversible alpha blocker useful for acute problem. For example, drug is very good. It's very good drug choice for cheese reaction induced hypertension or clonidine withdrawal induced hypertension, like that for acute management. Whereas non-selective alpha blocker, irreversible, non-selective, irreversible alpha blocker name is phenoxybenzamine. It's not an alpha. It's a wrong mistake. It's a non-selective alpha blocker that irreversible called phenoxybenzamine. That's a fantastic drug for treatment of hypertension due to pheochromocytoma. This point important. Look here. Pheochromocytoma, tumor in the adrenal medulla. For this the patient presenting with hypertension. So, for this case, I know it's a tumor in the medulla. So I'm planning for surgery. I can remove. But before surgery, to control BP, the best option phenoxybenzamine. So the best drug of choice for controlling hypertension due to fucosemide. Always think of phenoxybenzamine. Okay. Next. Yeah. Now, after finishing Alpha 1 chapter, Alpha 2 chapter, now we want to Beta chapter. Topic name Beta. What are the important MCQ regarding Beta chapter? When it's a Beta, I got Beta 1, Beta 2, Beta 3. So first we go for stimulants and then we go for blockers. Okay. First I go for stimulants. Ready? Start. Yes, Beta 1 seen in the Beta 1 mainly seen on heart and kidney. First resolution. Name the selective beta 1 agonist. Okay. Dobutamine is the selective beta 1 agonist acting on the heart, improving cardiac force of contraction, thereby improve cardiac output. This property useful for treatment of shock. Okay, very important, very important. Dobutamine, a selective beta 1 agonist acting on the heart, increasing cardiac force of contraction, thereby increasing cardiac output. This property is useful for cardiac failure. And by activating beta 1 in the heart, increasing heart rate, this property useful for stress testing like stress ECG or stress echocardiogram. So question, name the chemical useful for stress testing when think of dobutamine. As a beta 1 agonist causing adverse effect of tachycardia, sometimes arrhythmia. Okay. On high dose, rarely risk of reduction of vasomotor outflow. Don't worry about this. Usually causing tachycardia, arrhythmias. Okay. Next. Beta 2, very special, very special. Beta 2 receptor mainly seen on smooth muscle, vascular and visceral smooth muscle. For example, in a bronchus we have beta 2. So, what are the selective beta 2 agonists? Very important following. We have SABA, LABA, and also VLABA, three class of drug. That is SABA, short-acting beta-2 agonist like salbutamol. Then LABA, longer-acting beta agonist like formoterol and salmeterol. Both are LABA. And we have very long-acting like indacaterol, olodaterol, vilanterol, and abitol or B-LABA, very longer acting beta agonist. Now, revision question. Look here. Short acting beta agonists are useful for acute attack of asthma. Acute. Sabas are fantastic drug for acute. Okay. And the beta 2 also acting on uterine muscle, causing uterus relaxation, we call tocolytic action. So, salbutamol can be used as a tocolytic also. Okay. That's why Shahufda, common points remember. These two are common point. This don't remember. It's confusing. High dose may cause reduction of central vasomotor outflow, thereby very rarely risk of hypotension. Normally they will cause only hypertension. So common things you must know. Rarely on high dose, reducing central vasomotor outflow. That's why, okay. Now focus on this one. We are discussing drug acting on beta 2 on bronchus. Here, salbutamol called SABA, useful for acute asthma as well as useful as a tocolating. LABA useful for maintenance therapy in a case of asthma. Salmeterol, formoterol, both are useful for maintenance. This is what I told. When you're using maintenance therapy, be careful. When you keep on using, they may cause down regulation of beta 2 receptor. That's why LABA always given with steroid to overcome the tolerance. Okay. And then very important, indacaterol, olodaterol, vilanterol, Abidal, all are very long acting, useful for COPD. Here, 2 points you should know. What point? Formoterol, look at spelling. F4, mnemonic. Faster in onset. Faster in onset of action. Thereby, it is also can be useful for acute asthma. It is also can be useful for acute. So normally for acute, you go for SABA, but Formoter also useful for acute. And finally, regarding ADR, beta to agonist causing lot of adverse effect here. Most common is tremor. Tremor is the most common, followed by palpitation, and then they may cause hypokalemia, sometimes causing hyperglycemia. So for MCQ, the most commonest problem, tremor is the most common. Next comes we having uh, tachycardia, and then hyperglycemia, hypokalemia. Okay, and next we want to, there are some beta 2 agonists acting on uterus. For example, terbutaline, one more thing, isoxsuprine, both are, and Rytardine, isoxsuprine, Rytardine, terbutaline, all are acting on uterus, useful as a tocolytic. So beta-2 agonist also used as a tocolytic, that means uterus relaxant. Okay. And next is very important. You should know beta-3 man, very important. We have something called mirabegron and vibegron. Mirabegron, vibegron, both are acting on beta-3. Actually, beta-3 is on bladder. They acting on bladder. By acting on beta-3 and bladder, they cause relaxation of detrusor muscle, causes urine retention. They cause urine retention. This property useful for treatment of overactive bladder. Remember, mirabegron and bibegron both are beta-3 agonists, causes relaxation of detrusor, causing urine retention. This property useful for treatment of overactive bladder, and they may cause hypertension, tachycardia. They may cause action on blood vessel, may cause hypertension, sometimes causing tachycardia, but the main thing, very important point, useful for overactive blood. Okay. Now we done beta 1, beta 2, beta 3 agonists. Finally, what about beta blockers? See, when I say beta blocker, I have cardioselective and non-selective. Cardioselective means those drug blocking beta 1 mainly. Non-selective means blocking both beta 1 and beta 2 equally. Now, lot of old question just for revision. Please go through. Based on the property, I have lot of question. Come on. Beta block having intrinsic sympathomimetic. That is partial agonism property. Partially agonism property. They call pindalol. Next comes acebutolol. So, which is the Tanya asking lipolysis? Yeah, we have one thing. Beta 3 also seen on lipid. I mean the adipose tissue causing lipolysis. We have an old drug called Sibutramine. It's a beta 3 agonist. Beta 3 agonist causing adipolysis. Once upon a time, it was used for treatment of obesity, but today we don't use it. It causes cardiac adverse reaction, so we don't use it. It was sibutramine. It was used for obesity because acting on beta 3 on adipose tissue causing adipolysis, but because of causing cardiotoxicity, we don't use it. That's why I had not showed him. Here useful drugs are mirabegron, vbegron, acting on bladder muscle, causes relaxation of bladder muscle, useful for overactive bladder. Okay. Now concentrate on beta blocker related points. A beta blocker with highly intrinsic sympathomimetic action, pentalol. Then highly lipophilic is propranolol. Very important, very important. See, propranolol lipid soluble. Thus why easily crossing the blood-brain barrier, thereby useful for migraine prophylaxis, useful for performance anxiety, performance anxiety, also useful for akathisia, also useful for managing essential tremors like this. Okay, so question, propranolol having central action, lipophilic, easily crossing the blood-brain barrier, useful for migraine prophylaxis, useful as a drug of choice for performance anxiety, also plays a major role for treatment of akathisia. Then this what very important, beta blocker having additionally alpha blocking property, carvedilol and labetalol, very important. Of course, labetalol a fantastic drug of choice for hypertension in pregnancy and is useful for routinely orally. In emergency can be used IV also. So labetalol, a beta plus alpha blocker, can be used orally as well as intravenously. Carvedilol, a wonderful beta blocker useful for treatment of congestive heart failure. So most important beta blocker useful for treatment of heart failure. Okay, and among the beta blocker, ultra short acting esmolol. Now I'm waiting. Can you please answer? Esmolol is an ultra short acting cardioselective beta blocker acting approximately only for 9 minutes. My question is why? It is having very shortest duration action. The reason for shortest action due to it is rapidly undergo metabolism by pseudocholine esterase. Yeah, good. Okay. Undergo rapid metabolism by pseudocholine esterase. That's why ultra short acting. Yeah. Next, name some beta block having vasodilation. For example, nebivolol, Cipolol, they have nitric oxide releasing property. This property causing vasodilation. Then, say, among the beta blocker useful in glaucoma, which is safe in asthma patient. A beta blocker useful in glaucoma, safe in asthma patient is betaxolol. It's a cardio selective beta blocker. It is relatively safe in asthma patient for treatment of glaucoma. Okay. And next is very important. Beta blocker can be useful for heart failure. That too, they call disease. They call disease modifying drug. Disease modifying drug. That is, they're going to prevent remodeling. So, which are the FDA approved beta blockers as a disease modifying drug in heart failure? One is carvedilol, the most important. Next comes bisoprolol, then metoprolol, finally nebivolol. So question, which are the beta blocker got approval as a disease modifying drug in heart failure? One is our carvedilol, second is bisoprolol, third is metoprolol, finally nebivolol. Suppose in your near coming NEET exam, if I give all the four options, ask him to choose one best answer for heart failure, mean always go for carvedilol. It is the most wonderful beta blocker useful for treatment of heart failure. Okay, next, look. Uh, which is the best beta blocker in case of thyrotoxicosis? Answer propranolol. Remember, doctor, very important point. Propranolol has two important property in thyrotoxicosis. One point, controlling symptoms. Controlling symptom like palpitation or tremor. Second, inhibiting conversion of T4 to T3. Inhibiting peripheral conversion of T4 to T3. Because of these two benefits, propranolol, a beta blocker, wonderful for treatment of thyroid toxic crisis. And among the beta blocker, propranolol is a wonderful drug for migraine prophylaxis. It's the most common drug useful for migraine prophylaxis. A lot of drugs useful for prophylaxis migraine, but the most common drug is propranolol. Next, beta blocker useful in case of portal hypertension. One is propranolol. One more thing, either we go for this or this. Both are good. Okay, look here. There is a alcoholic patient, alcoholic liver disease landing in cirrhosis. In this patient, risk of portal hypertension. So to prevent the portal hypertension, we can go for either propranolol or nadolol. But one doubt I have, my doubt is, suppose, listen to me, suppose a cirrhosis patient developed portal hypertension mean he may go for complication of esophageal varices, thereby risk of bleeding. So please answer, to control the bleeding from varices, who is the drug of choice? If at all they develop varices, chance of bleeding. To control bleeding, yeah, good. Very good. Octreotide. Octreotide is a very good choice for controlling bleeding from varices. Very good. Very good. Okay. Next, the best beta blocker for treatment of anxiety, that performance anxiety, propranolol. And see, usually we have either cardio-selective beta blocker or we have non-selective beta blocker. We don't have selective beta 2 blocker. But remember, this one drug called butoxamine. It's a selective beta 2 blocker useful for research, not for practice, only for research. It's a selective beta 2 blocker. Okay. And then beta blocker having antioxidant property. So mainly carvedilol having good antioxidant property. And very important, a beta blocker most commonly useful for HOCM is propranolol. Now my doubt starts. Hypertrophic obstructive cardiomyopathy. What? Hypertrophic obstructive cardiomyopathy. It is a condition where there is a obstruction, aortic obstruction, and left ventricle under hypertrophy. In this case, I go for propranolol, but it's a non-selective beta blocker, so unsafe in asthmatism. In asthmatic, I can try verapamil also. For choosing, I can go for verapamil also. But one doubt I have. My doubt is anybody. Name one, name one direct, direct myosin inhibitor useful for treatment of HOCM. Anybody? Name one direct myosin inhibitor useful for HOCM. It is mavacamten. Mavacamten. It's a direct myosin inhibitor useful. Yeah, good, good, good. Useful for HOCM. Very good, very good. Now look at this. Beta blocker useful for essential tremor is propranolol useful for managing essential tremor. And beta blocker unsafe in kidney failure patient. Remember, there are some beta blocker undergo renal route of excretion. So unsafe in kidney failure. For example, sotalol, nadolol, atenolol, and acebutolol. They undergo renal route of excretion. So unsafe in kidney failure. And look here. Usually, beta blocker comes under class 2 antiarrhythmic. The only one beta blocker comes under class 3 antiarrhythmic is sotalol. Now you should remember when we talk about antiarrhythmic, we have class 1, class 2, class 3, class 4. Class 1 means sodium channel blocker. Class 2 beta blocker. Class 3 potassium channel blocker. Class 4 calcium blocker. My doubt is beta blocker comes under class 2, whereas sotalol it's a beta blocker having additionally potassium blocking property. That's why it comes under class 3. So now one and only beta blocker comes under class 3 is sotalol. Now one doubt I have. Please answer. The class 3 drug because of having potassium blocking property causing risk of dash in ECG. All the class 3 drug causing what? QT prolongation. All the class 3 drug has the risk of causing QT prolongation. So sotalol, a class 3 drug definitely having risk of QT prolongation and is also unsafe in kidney failure patient. So if we use sotalol in kidney failure patient, high risk of QT prolongation. That's what some important points on beta blocker. That means doctor be done sympathetic system, alpha beta agonism, alpha beta blocker topic. That means sympathetic stimulant as well as sympathetic blocker both are covered. Okay, so two major system was over. One is called general pharmacology, one more thing called ANS. Two main topic over doctor. Okay, now just after finishing this, we now move on to series, no? Okay, yeah. After finishing, yes, 5 minutes break. Okay, okay, okay. Okay, take a break. Satya Prakash. Okay, just 5 minutes break. Okay, I will finish. I do just 5 minutes break and then we start. But lunch break will be by 1:15. Is okay. By one lunch break at 1:30. Okay, ma. Suman, 1:30. Now a short break for 5 minutes and then lunch break will be by 1:30. Okay, agreed, agreed. Now we want to cardiovascular system to start. Okay. In cardiology, we have four chapters. First chapter, anti-angiogenics, and then we have anti-arrhythmic agent, and the heart failure and hypertension. So now we go for first revision of anti-angial agents. So actually, when I say anti-angial, we have nitrates, we have beta blockers, we have CCB, and also we have nicorandil, a potassium opener. Other than this, we have ivabradine, a funny and sodium blocker. Also, we have trimetazidine and ranitidine called antioxidant. These are the available anti-angle. Here, for revision purpose, please look at the carefully. When you say nitrates, nitrates on oral route undergo high first pass metabolism. The question will be, which is the nitrate undergo least first pass metabolism? Answer, isosorbate mononitrate. Okay. And then nitrates are acting by accumulating cyclic GMP. The vasodilata acting by accumulating cyclic GMP. As a drug, accumulating cyclic GMP, they cause vasodilation. That's why one very famous question, look at sildenafil is contraindicated with the nitrates because it's a phosphodiesterase 5 enzyme blocker, PD5 blocker. It is also acting by accumulating cyclic GMP. It's also causing vasodilation. So combination of nitrate plus sildenafil causes severe hypotensive shock and death occur. So very important, very important. Nitrate should never given with sildenafil because of risk of severe hypotensive shock. Very important. Okay. And then beta blocker and non-dihydropyridine CCBs decreasing heart rates and myocardial oxygen consumption. This is important. Look here. Nitrate useful for treatment of angina because of vasodilation, reducing preload and afterload. That means reducing cardiac workload, thereby useful for angina. Whereas the beta blocker and non-DHPs like verapamil and diltiazem, they're all decreasing heart rate. By decreasing heart rate, reducing workload. By decreasing heart rate, reducing cardiac workload, thereby reducing oxygen consumption useful for treatment of angina. Yes. Concurrent is good amrut rates. Sildenafil accumulating cycle GMP, so be careful with the vasodilata, especially the nitrates. Okay, next. Look here. This is again repeat the question. You must revise. Among the CCB, we have one drug called nimodipine. It's a cerebro selective calcium blocker useful for managing SAH. And the purpose is, it is useful for what purpose in this case? Useful to prevent, say, in hemorrhage, what happened? To prevent further hemorrhage, there will be reflex vasospasm. If the vasospasm maintained for a long hour, it may cause ischemic brain damage. So, nimodipine useful to prevent reflex ischemic brain damage. So, the purpose of using nimodipine in SAH is to prevent reflex ischemic brain damage. Okay. Next question, very important. Name the potassium opener useful for treating angina. That is nicotine only one drug. Look here. When you see potassium opener, we have a lot of drug. For example, We have hydrogen, minoxidil, diazoxide. These are mainly useful for hypertension, whereas which is the potassium opponent useful for angina? That is nicotindil. It's a potassium opponent also having nitric oxide releasing property, a vasodilator useful for treatment of angina. And it causes adverse effect after ulcer. This is again important image-based question. They may use after ulcer image asking it is an adverse effect caused by which of the following anti-angiogenic. Yeah, anti-angiogenic causes after ulcer mean think of nucleondil. Then very special you must revise. Look here. Renalizine, one of the PFOS pathway of fatty acid oxidation inhibitor. It is one of the antioxidant. This drug has extra property of late sodium blocking property. So question, name the PFOX blocker or name the antioxidant having additionally late sodium blocking property, ranelazine. And this drug, two important points. The ranelazine has a very good glycemic control. Ranelazine controlling HbA1c level, useful for treatment of angina with diabetes because the advantage of reducing HbA1c. But the problem, it may cause adverse effect of QT prolongation. QT prolongation. Cerealism, a antioxidant having additionally late sodium blocking property. Advantage reduces HbA1c but causing adverse effect of QT prolongation. Okay. Then another important point you should revise, trimethazidine. It is also one of the pathway of fatty acid oxidation inhibitor, PFOS inhibitor, called as antioxidant. It is useful for angina. Here important point. Name the antioxidants useful for treating angina. One is trimethazidine, one more thing, ranelazine. Here extra point that trimethazidine causes adverse effect. It causes adverse effect of increasing movement disorder, increases risk of movement disorder. That's why Goodman-Gilman book mentioning trimethazoline not suitable for treating angina in Parkinson patient. Parkinson disease, one of the movement disorder. So what they say, trimethazine aggravating risk of movement disorder, so unsafe for treating angina in Parkinson. Remember the trimethazine and ranelazine both are undergo renal route of excretion, so both are unsafe in kidney failure. That's why Goodman-Gilman clearly mentioned if we use trimethazine for treating angina in Parkinson, that too with the kidney failure, definitely going to aggravate movement disorder. So be careful, be careful. Okay. And then evaporated, a best MCQ expect a question. Look here. Evaporated, we know funny current sodium blocker. Funny current sodium blocker. This drug, action one, reducing heart rate. Reducing heart rate. They do not affect force of contraction. Remember, it is just it is just affecting heart rate. They do not interfere force of contraction. So it is having negative chronotrophy. That means chronotrophy reducing heart rate, but no effect on inotropic. That means do not disturb force of contraction. So question can be, name the drug having negative chronotrophy without any effect on inotropic, useful for treating angina. Look here. Beta blocker reduces heart rate, reducing force of contraction, and verapamil diltiazem, reducing heart rate, reducing force of contraction, useful angina. Whereas it is reducing only heart rate, they don't disturb force of contraction. That's important. And ivermectin acting on SA node. So funny current sodium blocker acting on SA node, decreasing heart rate. So the main adverse effect, since the reduced heart rate, main adverse effect causing bradycardia. It causing mainly bradycardia. But you should know sometime on chronic therapy, this drug may cause adverse effect of luminous effect. That's called brightness, light, enhanced light. Suddenly it's a glare, it's bright, a light, increase light in the field of vision. It's called enhanced lightness, called luminous, also called phosphene. We call this phosphene. Luminous effect, also called phosphine effect. That's about your evaporated. So you know nitrates, beta blocker, CCB, nicotindil, antioxidant, and then evaporated all are anti-aneurysm. Now my doubt is looking. The Rho kinase enzyme blocker useful for treating angina fasudil. Remember, it's a Rho kinase blocker as vasodilating property. It is useful for number one angina, number two useful for SAH, number three useful for treatment of pulmonary hypertension. Remember, fasudil, a Rho kinase enzyme blocker useful for treating angina, useful for SAH as well as for pulmonary hypertension. In this junction, I have a small doubt. My doubt is extra point. Anybody? This I'll discuss tomorrow. Anyway, out of curiosity, I want to ask one. Name any Rho kinase inhibitor useful for treatment of glaucoma. Can you please answer? Glaucoma. We have something called Nitar, Nitarsudil and Ripasudil. Both are row-kind blocker useful for glaucoma, promoting drainage across via canal Schulman. The increasing drainage across via canal Schulman. This we discuss tomorrow in my miscellaneous topic of third topic. Okay, that's about anti-angel import MCQ. And then anti-arrhythmics, a revision of anti-arrhythmics. Look here. I told in the beginning, and when I say anti-arrhythmic, we have four class. Class 1 mean sodium blocker, class 2 mean beta blocker, class 3 mean potassium blocker, class 4 mean CCB. That you know. Miscellaneous. Miscellaneously, we have adenosine, atropine, digoxin, MGS, so forth. Okay. So now we go one by one, small important points. Look here. The class 1 drug alone further divided into 1A, 1B, 1C, 1A, 1B, 1C. Remember, the class 1 main, we know sodium blocker, no doubts. The B, the C, they stands for what? Look here, 1A, that means the sodium blocker also having potassium blocking property. 1B, sodium blocker plus potassium opener. 1C, mainly sodium channel blocker. That's all. So remember, class 1A mean sodium blocking plus potassium blocking. 1B, sodium blocking, potassium opening. 1C, only sodium blocking. Now the question starts looking. The class 1A drug and class 3 drug, because of having potassium channel blocking property, they cause risk of QT prolongation. Very important. Among the antiarrhythmics, which are the classes of antiarrhythmic going to cause QT prolongation? Class 1A and class 3 drug. Okay. And then the class 1B drug has potential opening. So class 1B drug never causes QT, never causes QT prolongation. Important. Class 1B drug never causes QT prolongation. That is also important. Okay. Now, some special question, old question, you must know question. Look here. We have one drug called amiodarone. One of the class 3 drug, special drug. It is having multiple mechanism action. It's a primarily potassium blocker, also having sodium blocking, calcium blocking, and beta blocking. Multiple mechanism action. It's a broad spectrum drug, and according to ACLS guideline, that is Advanced Cardiac Life Support Guideline, it is the first line antiarrhythmic for treatment of VT and VF. VT and VF are dangerous arrhythmia causing cardiac arrest. So question, what is the best antiarrhythmic for controlling VT or VF mean? Go for amiodarone. Amiodarone, very important first line antiarrhythmic for VT and VF. And the avoided causing lot of adverse effect. In this one thing they cause blue pigmentation, blue color pigmentation. We call this blue man syndrome. They cause in the forehead. They cause blue color pigmentation. They call blue man syndrome. Sometimes causing smurf color pigmentation. Smurf color pigmentation. Okay. And chronic therapy causes pulmonary fibrosis and thyroid problem. Okay. It's a iodine containing antiarrhythmic causing thyroid problem. Yeah, good ma. Sri Krishna ma. Please check PFT, LFT, TFT. Good. Pneumonia. Good. Okay, right. Now, look here. Sometimes they ask me about therapeutic aspirin also. Name the drug of choice for acute SVT. Look here. For a case of acute SVT, the drug of choice is adenosine. Now, a small doubt. My doubt is supraventricular tachycardia. For this, the drug of choice is IV adenosine. It's a very short acting, given rapid bolus injection. But it may cause bronchospasm. So, in asthma patient, I can try verapamil also. Verapamil. So, question for a case of SVT, first line drug of choice always go for adenosine. If the option not given, next we can also try verapamil. Both are good for SVT. And then digoxin, one of the miscellaneous antiarrhythmic agent, it has vagomimetic property, thereby reducing AV conduction. This property useful for treatment of atrial fibrillation. It's an antiarrhythmic. It causes adverse effect of yellow vision defect. So question, name the antiarrhythmic causing yellow vision defect. We call this xanthopsia. Xanthopsia. Yellow vision defect is known as xanthopsia. Okay. And then this I told. It has vagomimetic property, thereby useful in atrial fibrillation. Okay. And then very important question. Quinine, one of the most famous class 1A drug. It is obtained from quinine. So the adverse effect we call chinchonism. Since the quinine obtained from chinchona bark, the adverse effect called chinchonism. So question, chinchonism adverse effect of which drug? Quinine. The symptom will be tinnitus, ringing sound in the ears, sometimes dizziness, called synchronism. Then this is again important you should know. Dronedarone, it's a amiodarone derivative. Amiodarone derivative, but only one thing, it has no iodine. No iodine, so no risk of thyroid dysfunction. That's a great advantage. And it is a class 3 drug advantage, no iodine, so no risk of thyroid dysfunction. Okay. And look at this, very, very important. Expect a question. MgSO4, one of the miscellaneous anti-arrhythmic agent. So wonderful drug for treatment of dorsal deep pointers. There is long QT syndrome, useful for treatment of long QT syndrome. Here you should know. Look here. Actually, MgSO4 useful for long QT, but when you say long QT, there are two things. One is called congenital long QT syndrome. One more thing called acquired long QT syndrome. So, what you should know for treating congenital long QT, better go for beta blocker like propranolol. For acquired longevity, better go for MgSO4. So MgSO4, wonderful drug for managing acquired longevity. When you say acquired, it is caused by class 1A drug or class 3 drug. They cause no. For that type of longevity syndrome, better go for MgSO4. Okay, right. Now, I just asked some extra question. Can you please answer? My first extra question regarding anti-arrhythmic. I given complete notes, but extra question. Come on. Suppose my patient having atrial fibrillation mean, please answer. In this case, name some drug useful for rate controlling in AF case. Or name some drug useful for rhythm reversal. Rhythm reversal. Some drug reverting AF into normal sinus rhythm. Now question. Rate control means simple mnemonic B, C, D. B for beta blocker. C for CCB like verapamil and diltiazem. D for digoxin. All these drugs acting on AV node, reducing AV contraction. Rhythm. Some drug converting AV to NSR. For example, amiodarone, and then ibutylide, vernacalin, dofetilide, all are class 3 drug useful for reverting F into NSO. So remember, for rate control alone go for mnemonic BCD, beta blocker, C for CCB like verapamil, diltiazem, D for digoxin. Rhythm reversal mean best is amiodarone. Other drugs are dofetilide, ibutylide, and vernacalins. Okay. And last, one more important question. Can you try? Suppose there is a case of Wolf Parkinson White syndrome. In this case, what is the drug therapy and what is the best drug mean what you want to use? Permanent mean what is the permanent solution? Drug mean I can go for flecainide from class 1C. Okay. And permanent radio frequency ablation of the abnormal tracts. IV flecainide or even procainamide from class 1A also can be used. And permanent mean radio frequency ablation. Okay, that's about old Parkinson white treatment. So I had done drug therapy for SVT, drug therapy for AF, drug therapy for BTVF, drug therapy for Darcy-Devindus, drug therapy for WPW syndrome. So that finishes some important anti-arrhythmics and the important revision points. Now we want to super important topic you should know. hypertension and heart failure. These are very important. In hypertension, they ask me mainly selection of antihypertensive medication. They will give scenario. For that scenario, choose the drug. No, sotalol not useful. Sotalol a beta can be tried. Sotalol in beta blocking property no can be tried. So any beta block can be tried. Okay. Now look here. Antihypertensive. Look here. How beta blocker useful for treatment of hypertension? They reduces cardiac output, reducing renal. By what mechanism of action? Beta blocker bring down the BP by acting on beta 1 in the heart, reducing cardiac output, by acting on kidney, reducing renin release, thereby inhibiting ROS pathway, thereby controlling BP. Okay. But you should know, even though beta blocker useful for hypertension, can you answer? I am seeing the chat box. Can you please answer? Name the four important first line drugs useful for treatment of hypertension. See, beta blockers are not a first line drug. So I just want to know in the chat box, can you please answer? Name the first line drugs useful for treatment of hypertension. One is ACE inhibitor, second ARB, third CCB, and fourth thiazide diuretic. This is a first line drug. Remember, beta blocker not a first line drug. Remember. Okay. Good. Inhibitor, ARB, CCB, and thiazide. Good. Now, remaining and all, I just given all the old MCQs from hypertension as the revision point. Okay. Hydrolysin, one of the potassium opener. It is useful for hypertension, especially useful for hypertension emergency. It is safe in pregnancy also. So one of the main point useful for hypertension in pregnancy, and it undergo metabolism by acetylation. So risk of SLE. So question can be name the antihypertensive causing SLE. It is hydrolysin undergo acetylation risk of SLE. Again, one point you should know, the hydrolysin can be combined with isosorbate dinitrate useful for treatment of heart failure in African American. In African American population useful for heart failure also. So it can be combined with the isosorbate useful for heart failure. Okay. Next, which is the alpha blocker useful for hypertension with benign prostatic hypertrophy that we discarded prazosin. Prazosin alpha blocker useful for hypertension with BPH. Okay. And Cardin, a alpha 2 agonist, centrally acting drug, reduces release of norepinephrine useful for hypertension. But the problem earlier we discussed already rebound hypertension on sudden withdrawal. When you stop the drug suddenly, it causes severe rebound hypertension. And then very important. Hypertension with the diabetes mean always first line anti-hypertension will be either inhibitor or ARBs. Remember. Hypertension with the diabetes. Choose the best drug mean go for always Ismitar ARB because they control BP as well as control diabetic complication. So hypertension with diabetes mean always first choice will be either Ismitar ARB. But I just want to ask one question. Hypertension with diabetes in this case better avoid what antihypertensive. Better avoid thiazide diuretic and non-selective beta blockers because they will affect glucose metabolism. So, question. So, in case of diabetes patient, avoid thiazide, better avoid non-selective beta blockers. Okay, good. Then, for treatment of isolated systolic hypertension, that too in elderly, what the best drug? The best is CCB. The best antihypertensive for isolated systolic hypertension, that too in elder people, go for CCB. Okay. And very important, any RAS pathway blocker, any RAS pathway blocker will cause adverse effect of hyperkalemia. This point you should know, Your AC meter, that is AC meter, ARB, even although antagonist, spinal atom, all are has the risk of causing hyperkalemia. So, anti-hypertensive agent avoided in hyperkalemic cases are RAS pathway blocker. Any RAS pathway blocker has the risk of causing hyperkalemia. So, be careful. Can you explain why they are? See, actually, the thiazide directly causing adverse effect of hyperglycemia. Hyperglycemia. Beta blood causes hypoglycemia and masking symptoms of hypoglycemia. So they disturbing glucose metabolism. That's why thiazide diuretic and non-selective beta blockers are not good for diabetic patients, Aishwarya. Okay. Next. Uh, resistant hypertension. Revise. Look at. There is a patient on a hypertensive patient on three different drug, A drug, B drug, C drug, three different drug. Even on three different class of drug, still BP not controlled mean that patient is called as resistant hypertension. In this case, the fourth drug we go for spironolactone. So question, it is a aldosterone antagonist, very useful for treatment of resistant hypertension. That is first question. When will we call a person suffering from resistant BP? If the patient on even on three different classes of drug, still the BP not controlled mean we call them resistant. For them, we add fourth drug spironolactone. Okay. Then a post-MI patient with a high BP following coronary artery heart disease and hypertension mean best is go for beta blocker. Post MI and heart hypertension, beta blocker, wonderful choice. And this is very important, very important. It's a beta blocker having additionally alpha blocking property, a wonderful drug for hypertension. Shifa, three different class of anti-hypertensive. One from Asimeter, one from CCB, like that. Three different class, not same class. Okay. And then Levodopa is a beta plus alpha blocker, wonderful drug for hypertension in pregnancy. It can be useful orally, routinely, IV in case of emergency. So, question useful for routine hypertension in pregnancy as well as useful for hypertension emergency in pregnancy. Okay. Now we want to the most important topic in serious heart failure. There are so many new drugs are there. So heart failure, very important topic, very important topic. So before lunch break, let me try to finish heart failure and then we go for blood, kidney like this. So heart failure, look here. When you say heart failure, you know basic acute heart failure, chronic heart failure. Acute heart failure means difficulty in breathing, presentation with pulmonary edema. Chronic failure means the problem of remodeling, all this thing, you know. Now, what is important for exam purpose? Ready? One point. What is RNA? Very special, very special. Angiotensin receptor plus neprilysin inhibitor. Here, AARB, angiotensin receptor blocker plus neprilysin blocker. For example, we have fixed dose combination of valsartan plus sacubitril. Valsartan is the angiotensin receptor blocker. Sacubitril is a neprilysin blocker. This combo is called ORNI, useful for treatment of heart failure with reduced ejection fraction. Heart failure with reduced. So, question being, name the ARB available as a fixed dose combination with the sacubitril. Valsartan. Valsartan is the one available as a fixed dose combination with the sacubitril. Here, sacubitril neprilysin blocker. This itself MCQ. Next, uh, beta blocker useful. I just give some basics. Look here. When it's a heart failure, we want to think of acute failure. Acute, also called as here the main problem, pulmonary edema. So for this case, the treatment should be symptomatic. For example, I want to relieve the symptom. Here 3D, mnemonic 3D. One is diuretic. For example, furosemide, a very wonderful diuretic for rapid relief of breathlessness. Then dilators, vasodilators. Then digoxin or any inotropic like dobutamine or dopamine, like that some drugs all are useful for acute. Okay. Whereas chronic, in case of chronic failure, the problem is ventricular remodeling. So my aim of treatment is I want to prevent remodeling. To prevent remodeling, I need to go for disease modifying drug. When I say disease modifying drug, what are the disease modifying drug useful for heart failure? Here we have ROS pathway blockers like S-beta, ARB, and spinalcom. Also beta blocker. They also called disease modifying drugs. So with this point, look at my question. Beta blocker useful as a disease modifying drug in heart failure. Which are the four drugs? One I told carvedilol, other drugs are bisoprolol, then metoprolol, then nebivolol. All these are beta blocker useful for disease modification in chronic heart failure. Among this, most important, carvedilol, very important. Okay. Next, in case of acute failure, loop diuretic are the one very good choice for rapid relief of symptom in acute heart failure. This is again important. Which is the drug of choice for rapid relief of breathlessness in acute heart failure? Answer, furosemide. Loop diuretic, furosemide, a fast-acting agent. It is the most important drug of choice for rapid relief of breathlessness. Remember, furosemide, a diuretic useful only for symptom relief. It is not useful for modifying disease. Whereas, which are the diuretic useful as a disease modifying drug? They are called spironolactone, a aldosterone antagonist called spironolactone, and Palladium. They are called potassium sparing diuretic. Both are potassium sparing diuretic, and they are the drugs useful as a disease modifying drug, reducing morbidity, reducing mortality. So, question: a diuretic useful only for symptom relief mean furosemide. Diuretic useful for disease modification in heart failure mean think of spironolactone. Okay. Next, evaporated. Remember, it's a funny current sodium blocker. Funny current sodium blocker. We discussed it is useful for angina, but you should know it is also got approval for treatment of heart failure. Very important, very important. Evaporated, a funny current sodium blocker. It's a FDA approved drug for treatment of angina as well as heart failure. Especially, it reduces heart rate. Heart rate, no? Here the point is look here. It is useful for heart failure in a patient whose heart rate very high despite of beta blocker. Even after starting beta blocker, still heart rate in high mean to control them, we can try additionally evaporatin. Then this is what I told already. Hydrolysin, one of the potassium opener, useful for hypertension, but can be given with isosorbate dinitrate for treatment of heart failure in African American population. In African American population, this also should know. African American population. Okay. And look here. Digoxin useful for heart failure. 2 point active. Digoxin, useful for heart failure. Anybody? By what mechanism action? Reason? Inhibiting sodium, potassium, ATPase pump, thereby accumulating intracellular calcium. The calcium going to cause increasing force of contraction, thereby increasing cardiac output. So question, it enhances contraction, increasing cardiac force of contraction, thereby improving cardiac output, useful for heart failure. Remember, it needs monitoring. It has neurotherapeutic index. Neurotherapeutic index. So needs to be monitoring. Okay. Next, anybody? Milrinone is a PD3 blocker. We have amrinone and milrinone. Both are PD3 blocker useful for heart failure. These two drugs are called ionodilator. Iono mean ionotropy, increasing force of contraction. Dilator vasodilating, having both inotropic effect as well as vasodilatation. Okay. Yes, ma. Swapna, wait for 5 minutes. I will finish heart failure and then break. Just 5 minutes alone. Just 5 minutes. Look here. Amrinone, milrinone, both are PD3 blocker. In this junction, if you are too good in subject, can you please answer? Name any. Name any calcium sensitizer also having PDE3 blocking property. Anybody? It is levosimendan. Levosimendan, a calcium sensitizer also having PDE3 blocking property. Okay. And then very important, this we done already. Yes, good man, good, fantastic, very good. Look here. Dobutamine, a selective beta-1 agonist, increasing cardiac force of contraction, useful as an inotropic agent, useful for decompensated heart failure, improving force of contraction, improve cardiac outputs. Okay, and hereafter, very, very important. I go slow. Very, very important. You should know. You should know. Revise. Look here. Necessary, one of the recombinant brain natriuretic peptide analog. Very important. Find out the BNP analog. It's a necessary. Brain natriuretic peptide causing natriuresis, causing diuresis, causing vasodilation, useful for acute heart failure. And remember, doctor, this drug, brain natriuretic peptide, so cannot be taken orally. Given IV infusion, given IV infusion, it is a peptide not taken orally. Okay, repeat up. Okay, yes. Amtul, we are discussing aminin, or PDE3 blocker. Extra point I told, levosimendan, a PDE3 blocking property also is there. Primarily calcium sensitizer, having additionally PDE3 blocker already. Dovitamine, a beta 1 against, you know already. And I'm now just talking necessary. It's a brain natriuretic peptide useful for acute heart failure given IV. Remember, never oral, never oral. It is MCQ because it's a peptide, and it is short acting drug useful for acute heart failure. It is short acting. Why short acting mean? It is rapidly undergo metabolism by neprilysin. Rapidly undergo metabolism by neprilysin. Thus why we have something called neprilysin blocker. Sacubitril. Sacubitril is a neprilysin blocker. Okay. I know data useful for acute man. All about acute heart failure. Now, necessitated useful for acute heart failure. And remember this what most and most important, please what? Sodium glucose transporter 2 blocker. We call AGLT2 blocker. So group of anti-diabetic drug, man. Anti-diabetic drug, but look at mine. Sodium glucose transport blocker. They acting on PCT. By acting on PCT, inhibiting AGLT, by blocking AGLT, they are not allowing the absorption of sodium. That will be causing sodium loss called natriuresis, diuresis. This property useful for treatment of heart failure. Heart failure. Remember, which are the AGLT2 blocker approved for treatment of heart failure? One is EMPA. We have dapagliflozin, then EMPA, and one more thing, sotagliflozin. Three drugs. DAPA, EMPA, and sotagliflozin. These are sodium glucose transporter 2 anti-diabetic drugs got approval for treatment of heart failure. Very important. Okay. Then extra some new drug. Riociguat. Actually, it's a direct guanylyl cyclase activator useful for pulmonary hypertension. Whereas today you should know Vericiguat, it's a new drug. It's a guanylyl cyclase activator useful for treatment of heart failure, chronic heart failure. Remember, Riociguat, one more drug, Chinosiguat. These two drugs are useful for treatment of pulmonary hypertension. Whereas Vericiguat useful for treatment of heart failure. Okay, next. R. Omecamtiv is a new drug, a direct myosin activator. It's a myosin activator, increasing force of contraction, improve cardiac output, useful for treatment of heart failure. Omecamtiv. Then some extra point. SVDR useful for hypertension, heart failure, and the most common side effect because of dryness of, dry cough, rarely angioedema. They may cause dry cough, rarely angioedema. All this because of causing accumulation of bradykinin. They accumulate bradykinin, that property going to cause dry cough as well as angioedema. In this junction, I want to check your level of preparation. Can you please answer? Esmita causing angioedema because of bradykinin. So, for treating this angioedema, I want some bradykinin antagonist. Name any bradykinin antagonist, useful for treatment of angioedema. Anybody? The drug name is icatibant. Banks. It's a bradykinin antagonist. Yes, good. Arsu. Very good. It's icatibant. Bradykinin antagonist useful for angioedema. Okay, good. Then, what about sodium nitroprusside? Look here. It's a vasodilator, useful. It's a short-acting drug, useful for hypertensive emergency, useful for emergency, and it is a cyanide containing drug. So, antihypertensive containing cyanide, sodium nitroprusside. And because of having cyanide, one special point, revise. This having cyanide, no, the cyanide in the body can become thiocyanate. This thiocyanate inhibit iodine uptake. So this drug may cause adverse effect of hypothyroidism. So question can be nitroprusside may cause adverse effect of hypothyroidism because of having cyanide. The cyanide in the body become thiocyanate that going to inhibit iodine uptake thereby causing hypothyroidism. Okay. And this is the last year important old question. Please watch. Look here. Omeprazole and sampratol are newer drug having the property of dual enzyme blocking. They inhibit both angiotensin converting enzyme as well as neprilysin enzyme. Remember, doctor, we have sacubitril. It is a selective neprilysin inhibitor, whereas these two are inhibiting neprilysin as well as angiotensin converting enzyme. Very important. Keep in memory. Then this, sacubitril neprilysin blocker and some extra point. Look here. Here we having anti-platelet property losartan. Losartan having thromboxane A2 receptor blocking property, thereby having anti-platelet action. One more point, it is also having uric action. So preferred for treatment of hypertension in gout patient. It has uric. So preferred for treatment of hypertension in gout patient. And then very special. The ARB having PPAR gamma agonistic action. Tell me, Sartan. Very important. Because in PPAR gamma, it's going to have insulin sensitizing property, thereby control diabetes also. Question, tell me Sartan, a ARB useful for hypertension, heart failure. Beauty is it has PPAR gamma agonistic property. In this junction, can you please answer? Name the original anti-diabetic drug having PPAR gamma agonist action. It is pioglitazone. It is a original PPR gamma against pioglitazone. Okay. So tell me if you're having pioglitazone action. It is pioglitazone like activity. Very good, very good. And I told somewhere sodium nitroprusside a vasodilator. It is highly sensitive to sunlight. It is sensitive to light. So when you use this as an infusion, cover the eye fully with a towel. It should be protected against the light. Okay. And I am nearing the end. The drug sodium nitroprusside containing cyanide. The cyanide becomes thiocyanate, causing hypothyroidism. Now look at this question. The drug useful for treating cyanide toxicity caused by sodium thiocyanate versus sodium thiosulfate. So question, for treatment of cyanide toxicity due to nitroprusside, we go for sodium thiosulfate. Here I want to check. Pratibha Chauvik, can you please answer? In case of, generally, in case of cyanide poisoning, for treating cyanide poisoning, I have antidote kit. The antidote kit containing what? In general, for treatment of cyanide poisoning, we go for either amyl nitrites, or sodium nitrites with thiosulfate, thiosulfates, thiosulfates. Okay, amyl nitrate or sodium nitrate with thiosulfate. Or we can go for B12 hydroxycobalamin. Hydroxycobalamin. Question: amyl nitrate, sodium nitrate, thiosulfate. It is the kit. Or else we can try hydroxycobalamin. Okay, good man. All are doing good job. Good. Then this we done already. Digoxin increases cardiac force of contraction by what mechanism? It is by inhibiting sodium potassium ATPase pump, thereby increases intracellular calcium level. This is going to improve cardiac force of contraction. Okay. And a small word about extra 3 points on digoxin. Look here. Digoxin, one of the powerful inotropic drug, it causes cardiac problem like arrhythmia. The most common arrhythmia caused by digoxin is ventricular bigamy. It can cause variety of arrhythmia, but the most common cardiac arrhythmia caused by digoxin, ventricular bigamy, or sometimes causing premature ventricular contraction. Okay, and the specific antidote for digoxin poisoning, we have Digiban. Digiban is the antidote for digoxin poisoning. Okay, and very important, very important. Digoxin toxicity usually aggravated in the presence of some electrolyte imbalance. What are the electrolyte imbalances? They're going to aggravate digoxin toxicity, like hypokalemia, hypomagnesemia, and hypercalcemia. Very important, very important. Which are the electrolyte disturbance? They're going to aggravate digoxin toxicity. Okay. Whenever there is hypokalemia, or whenever there is hypomagnesemia, or whenever there is a hypercalcemia, that will aggravate digoxin toxicity. That's why for treating digoxin toxicity, we can go for potassium chloride. We can go for MgSO4 because digoxin toxicity can be due to hypomagnesemia. So give MgSO4 like this. So you should know which are all the electrolyte problem going to aggravate digoxin toxicity. Very important. Okay, so in cardiology, I think we covered all the important aspect of angina, arrhythmia, hypertension, heart failure. Now time is almost 1:48. Now it's time for lunch break. Now you tell. Time is around 1:50 now. Now by 2:30 we are starting at. I think 40 minutes enough. By 2:30 we starting. 2:30 to 4:30 I have to finish blood and kidney at least at by 4:50. Then 5 to 7 I have to finish GAT RS autopilot. That's the plan. Okay. So by 2:30 we're starting. It's now time for lunch break. Okay. Okay, doctor. We start. Yes. To start after finishing CVS, now we move to blood chapter. Okay. In the blood chapter, we have two main topics. One is uh, anticoagulant, antiplatelet, thrombolytic agents, and then drugs useful for lowering lipids, cholesterol lowering drugs. Like that, we're going to discuss. Just once again. Yes. To start, blood chapter, thrombolytic. Puja Singh, today Telegram channel. Today I have to align my PDF and Word file for tomorrow class. So today night I just want to break. Okay. Tomorrow I will post some question. Okay. So today night I will conduct Puja Singh. Definitely I will conduct quiz program. But today not possible. From tomorrow once we can say. Okay. Okay, we start. Bell chapter. First chapter, thrombolytic agent. Ready? Thrombolytic agent, also known as fibrinolytic agent. Fibrinolytic. They're going to lyse the clots. We having streptokinase, urokinase, altiplase, tenetiplase. Here, first question. Name the thrombolytic agent which is given as a single I bolus. I think in your workbook it's mentioned wrongly altiplase. You just correct tenetiplase. Single IV bolus mean go for tenetiplase. So question, among the thrombolytic agent which is given as a single IV bolus mean tenetiplase. And then, right, next question, thrombolytic agents causing bleeding, no? To control that, what are the antidote? This question repeated so many times in NEET paper. So you should know the antidote for thrombolytic drugs main is specific is epsilon aminocapric acid. Epsilon, epsilon aminocapric acid we call EACA. That is specific antidote. But we also have something called tranexamic acid, tranexamic acid and aprotannin also. But the specific antidote is epsilon aminocapric acid. Another repeated need question. What is the main mechanism action of thrombolytic agent? The mechanism action of thrombolytic is of the plasminogen activator. We call TPA, tissue plasminogen activator. Plasminogen is called as fibrinolysin that is converted into fibrinolysin. So they're converting plasminogen into plasmin. That's the mechanism action of thrombolytic. So here Drug name important, mechanism action important, antidote important. And of course, the thrombolytic drugs are very useful for treatment of acute ST elevation MI. They are not useful for non-STMI. Useful only for acute ST elevation MI. Also useful for acute pulmonary embolism. Also useful for treatment of acute ischemic stroke. Ischemic stroke. For this case and all we can try. But the main indication acute ST elevation MI. That's about important questions on thrombolytic. Now anticoagulant. A lot and lot of questions are there. Just following. When I say anticoagulant, we have oral drug, injection drug. Oral we have warfarin and two new class of drug. Oral 2A blocker, oral 10A blocker. Injection wave heparin and LMWH and new drugs called direct 2A blocker. So now I revise all the most important points. So one, Dr. LJ, we are discussing thrombolytic agent, three important questions. Thrombolytic drugs. A drug given single I bolus currently placed. Thrombolytic drugs mechanism action activating plastinogen into plasmin. The specific antidote is epsilon aminocapric acid. Okay, Dr. LG. Now listen. Anticoagulant. Okay. This question came last year in NEET PG examination. Which is the safest anticoagulant for treating thrombosis in pregnancy? Answer LMWH. Look here. First to 12 weeks, that is first trimester mean always go for low molecular weight heparin. 12 to 36 weeks, here also better go for LMWH, or else we can also try warfarin. Warfarin can be used only in second trimester. After 37 weeks mean better go for LMWH solution. The most safest anticoagulant for treating deep vein thrombosis in pregnancy or LMWH. Okay. And then this again very important. See, we have warfarin, oral drug. Warfarin, a vitamin K antagonist, going to inhibit 2, 7, 9, and 10. And 10. Okay, so warfarin, a oral anticoagulant called vitamin K antagonist, inhibiting vitamin K dependent clotting factor like 2, 7, 9, 10. But my question, name the direct oral thrombin blocker. Thrombin means 2A. Name the direct thrombin blocker. Oral drug mean answer dabigatran. Very important, very important. Oral drugs, two new drugs. One is oral 2A blocker, one thing oral 10A blocker. The oral 2A blocker is called dabigatran. Remember, the dabigatran undergo renal route of excretion, so unsafe in kidney failure. They undergo renal route, so unsafe in kidney failure. And again, important expected question. Any anticoagulant side effect is bleeding. So question, dabigatran causing bleeding. To control the bleeding due to dabigatran, what is the specific antidote? It is idarucizumab, a monoclonal antibody. It is the specific antidote for dabigatran. In this junction, can anybody answer? For dabigatran antidote is idarucizumab. Anybody? For warfarin, what is the specific antidote? I'm just waiting. Can you please answer? What is the specific antidote for warfarin? Here answer vitamin K1, so-called phytonadione. Phytonadione is the specific antidote for warfarin K1. Whereas for dabigatran, answer idarucizumab. Okay. Next, 10. Yeah, good. Hey, protamine for heparin. Here, vitamin K. Okay, look here. And specific antidote for direct 10A blocker. Direct oral 10A blocker means those drugs name ending with the XABAN. For example, apixaban, rivaroxaban, edoxaban. Like that, those drug name ending with the XABN. They are called direct 10A blocker. For this case, antidote is antizenate alpha. It's a recombinant 10A preparation. It is the antidote for oral direct 10A blocker. 10A blocker examples are apixaban, rivaroxaban, edoxaban, pictrixaban. There is those drugs name ending with the suffix called XABN. Okay. And look here. Hidaruzumab antidote for 2A blocker. It is and for 10A blocker. Whereas for 2A and for 10A, for both, we have one common antidote. That is called siraparentak. Siraparentak is a common antidote for both 2A and 10A blocker. It is most expected for this year NEET PG. Remember, very important. It's a most expected. Find out the common antidote for both 2A and 10A blocker. Answer name siraparentak. Okay. Next, this is what. Look here. Somebody mentioned chat box wrongly. Look here. For heparin antidote is protamine. See, I told in the beginning today's session, heparin a strongest organic acidic drug. Protamine strongest alkali drug. So remember, a alkali antagonizing acid is called chemical antagonist. So remember, protamine is the chemical antagonist of heparin. Chemical antagonist of heparin. So alkali drug antagonizing heparin called chemical antidote. Okay. And then look here. Heparin causes lot of adverse effect. For understanding adverse effect heparin, we used to have mnemonic called about A, B, O, U, T. A for alopecia. B for bleeding. O for osteoporosis. U for urticaria. T for thrombocytopenia. Now you should remember heparin causing thrombocytopenia. We call this HIT, heparin induced thrombocytopenia. Now listen here. A patient having a deep vein thrombosis. For treating this, imagine I'm starting heparin. After starting heparin, he developed the adverse effect of heparin-induced thrombocytopenia. But he still need anticoagulation. In this case, what is safest? Solution: the drug of choice for treating thrombosis in patient with HIT is we go for injectable direct 2A blocker. Injectable like herodine or bivaluridine or lepuridine. All these are injectable direct thrombin inhibitor. Solution for treatment of thrombosis in patient with heparin-induced thrombocytopenia. We go for injectable direct thrombin blocker like herodine, bivalirudine, lepiridine, sometimes argatroban. All are injectable direct thrombin blocker. Now, one important question. Hey, Pooja's injection dabigatran oral. Don't confuse. It's oral. Dabigatran oral drug. It's oral drug. It's not injection. Dabigatran say oral direct thrombin blocker. for this case, come on, for sorry. For this case, I go for injectable direct thrombin blocker like argatroban, or bivarodin or leprodin. Okay. Yeah, argatroban. Yes, good. Aishwarya, argatroban is good. Is good. Okay. So for patient with the heparin-induced thrombocytopenia, uh, we go for injectable direct thrombin blocker. Somebody asking about what you? U for urticaria. U stands for urticaria. That is skin allergy. Urticaria. Okay. Urticaria. Now look at this. Among the injectable direct thrombin inhibitor, a safe drug in kidney failure is argatroban. Remember, it goes through bile. Among the injectable direct thrombin inhibitor, only one drug safe in kidney failure. That is called argatroban. Argatroban goes through bile, so safe in kidney failure. Okay. Next. Ah, warfarin having narrow therapeutic index. So it should be assessed. So we should do therapeutic drug monitoring, that is by doing INR. So the normal range of INR should be 2 to 3. Normally, ideally, INR should be 2 to 3. That too, in a chronic patient, lifelong patient is on warfarin, mean better keep the INR less than 2. Whereas in prosthetic valve patient, we can go for up to 3. Usually 2 to 3. But in chronic patient, lifelong patient, better keep the INR less than 2. Because more the INR, more the risk of bleeding. So be careful. Okay. Next. Okay. Among the direct 10A inhibitor, among the oral 10A blocker, a drug with longest acting is edoxon. Edoxon, longest acting oral 10A blocker. Next question, famous question, repeated question. Look here. Warfarin, a oral anticoagulant, may cause adverse effect of something called hypercoagulation. Hypercoagulation. Sometimes dermal necrosis. Question starts. Warfarin anticoagulant, how can they cause hypercoagulation? This is what important. Look here. Warfarin, a anticoagulant, it's a vitamin K antagonist. That means inhibiting vitamin K dependent clotting factors. You know 2, 7, 9, 10 also all are between K dependent factors. But you should know protein C. Protein C also vitamin K dependent clotting factor. Normally, the function of proteins is inhibiting factor 5 and 8. Normally, protein C inhibiting factor 5 and 8. Now, coming to mind, warfarin, a anticoagulant, inhibiting all the vitamin K dependent clotting factors. That means the inhibiting protein C also. By inhibiting protein C, the increases factor 5 and 8 level, it causes hypercoagulation and dermal skin necrosis. So this question very important. Warfarin may cause hypercoagulation and dermal necrosis because of inhibiting protein C that causes elevation of factor 5 and 8 resulting in hypercoagulation. One more point. Warfarin may also cause purple toe syndrome. Purple toe syndrome. It is because of release of cholesterol emboli from atheromatous plaque. It may cause purple toe syndrome. That is because of release of cholesterol emboli from atherosclerotic plaque. So all these are important points regarding anticoagulant. Anyway, you should know we having injection heparin, injection LMWH, and then oral drug like warfarin, oral 2A TNA blocker. All the points given in this workbooks are very, very important. Everything old question. Okay. And small revision of antiplatelet. Okay. When you say antiplatelet, what are the most important points? Of course, Sri is telling, Sri Krishnamandi telling warfarin, unsafe in pregnancy, causing Conradi syndrome, called fatal chondrodysplasia punctata. All these things we discussed already in morning, GP class, warfarin, a teratogen. Okay. Yes. Now look at this. Regarding antiplatelet, you must revise something called we having aspirin, we having P2 Y12 inhibitors. Look, aspirin, we know a antiplatelet inhibiting COX-1 enzyme irreversibly, thereby inhibiting synthesis of thromboxane A2. This I will tell later. Okay, this will, but before that, I just go for one by one. In between, uh, look here. P2 Y12 blocker. We having ticlopidin, clopidogrel, prasugrel, ticagrelor, cangrelor, like the lot of drugs are there. In this, go one by one MCQ. Name the P2 Y12 blocker that is given with the combination with aspirin. Usual value aspirin with clopidogrel, most famous combination. We can use anyone, but most common is we using with the clopidogrel. Again, you should know it's a prodrug. It's a prodrug. This drug for its action needs activation. It is activated by the help of CYP2C19 enzyme. Very important, very important. And aspirin used as antiplatelet, low dose. We use low dose aspirin. When I say low dose, it vary from 50 mg to 150 mg per day. Usually we use 70 mg per day. So low dose aspirin meaning 750 mg to 150 mg. Usually we use 70 mg per day. And low dose aspirin selectively inhibiting COX-1 enzyme, selectively blocking COX-1 enzyme irreversibly. Okay. Next. This again very important. Name the monoclonal antibody having antiplatelet action. Okay? Abciximab is an antiplatelet. Now I want to check your level of preparation. Can you please answer anybody? Abciximab, a monoclonal antibody having antiplatelet action. Now you should tell as an antiplatelet, it is acting against what? I want target. It is acting against what targets? Answer. It's a glycoprotein 2B3A blocker. It is acting against glycoprotein 2B3A receptor. We have abciximab, then FT-fibatide and tirofiban. All these are glycoprotein 2B3A blocker. All these are injectable intravenous antiplatelet. Okay. And then this I told already. Aspirin is the irreversible COX-1 blocker and inhibiting synthesis of thromboxane A2 that we having antiplatelet activity. Okay. An antiplatelet contraindication in patient history of thrombocytopenia purpura. Ticlopidin causes thrombocytopenia, also causing neutropenia. So It is not safe in patients with thrombocytopenic purpura and also causing neutropenia. Okay, next. Very important. Expect the question for this year. We have two important new oral antiplatelet called PAR1 blocker. PAR stands for protease. Protease activated receptor 1. APAR1 blocker. Both are orally given antiplatelet. Drug name Oropaxar and Etopaxar. Very important. Oropaxar and Etopaxar are oral antiplatelet targeting against PAR, platelet active protease activating receptor. Okay. And very important. Among the P2 white blocker, most of drugs are blocking P2 white irreversibly. Which are the reversible P2 white inhibitor? That include ticagrelor and cangrelor. Ticagrelor and cangrelor are reversibly inhibiting P2 white web, whereas eclopidin, clopidogrel, prasugrel irreversibly blocking P2 white web. And one more thing, among the P2 white blocker, cangrelor alone given intravenous, remaining drugs are oral. The one and only intravenous P2 white blocker name is Cangrelor. Cangrelor. No, 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 no. Soumya Ranjan, it is not fixed. We can use aspirin with the prasugrel. We can use aspirin with the tigla. Anything can be given. Nowadays we go for prasugrel. It's not fixed. I'm just telling the commonly given drug is aspirin with the clopidogrel. It's not this only one. We can combine with the prasugrel or we can combine with the TLR. That's also true. Okay. Right. Now, this point we discussed already in GP class. Omeprazole is a CYP2C19 inhibitor. So it's going to interfere the activation of clopidogrel. So question will be, which is the proton pump blocker should not or better avoid with clopidogrel? Mean think of proton pump blocker omeprazole. Best is go for pantoprazole that has no drug interaction with clopidogrel. Okay. Next, after finishing this, we now go for lipid lowering. Before that, a small doubt, man. What is there in your book? I explain, but a small doubt. My doubt. Can I answer? Doubt number one. Doubt number one. How are you going to monitor safety of anticoagulants? For example, for aspirin, for antiplatelet, we should monitor what? For antiplatelet, monitor bleeding time. Whereas for anticoagulant, in case of heparin, for heparin, we assess activated partial thromboplastin APTT. Whereas for warfarin, we assess INR. And remember, usually LMWH are safer drug, so no need for monitoring. But they undergo renal route of excretion. Remember, LMWH undergo renal route of excretion, so unsafe in kidney failure. So when you're using LMWH in kidney failure, they need monitoring. In your case, monitor anti-factor 10A, anti-factor 10A. So usually for LMWH, we don't do monitoring, but in case of kidney failure, they need monitoring by assessing anti-factor 10A level. This is also very important, very important. Okay. Another question, just for since you are all very close to my heart, one extra point. Look here. Which are the anticoagulant needs a problem in kidney failure? Anticoagulant and kidney. For example, look here. Heparin very safe in kidney failure. Heparin safe in kidney failure because it undergo metabolism in reticuloendothelial system, so safe. Next, warfarin safe in kidney failure. Then argatroban safe because it goes through bile, safe. So these are safer drug. Okay. And regarding antiplatelet, apzigzimab, apzigzimab safe in kidney failure, safe. All these are safe in kidney failure. Whereas most of the other drugs are undergo renal route. So be careful, be careful. Okay. So anticoagulant and route of excretion, anticoagulant and therapeutic drug monitoring are very important area. So listen. Okay. After finishing with anticoagulant therapeutic, we now move on to cholesterol lowering agent. Very simple topic, but very important topic. Cholesterol lowering, very, very important. Look here. When I say cholesterol drug, the most super group of choices Statins are the wonderful group of drug useful for lowering lipids. And statin are doing two jobs. One is they inhibit HMG CoA reductase, one point. Second point, because upregulation of LDL receptor on liver cell, thereby reducing LDL cholesterol. So inhibiting HMG coatase also causing upregulation of LDL receptor. Now the question starts. Among the statin, which is most important, we have pitavastatin. Pitavastatin, most potent. Next is rosuvastatin. So, among the statin, the most potent mean pitavastatin. If this option not given, next is rosuvastatin. Rosuvastatin, most commonly used, is highly potent. Okay. Next question. Lipid lowering drug increases HDL cholesterol. Which is the cholesterol lowering agent maximally increasing HDL? It is niacin. Niacin, vitamin B3, it has cholesterol lowering property. Especially it lowers LDL cholesterol, lowering LPA cholesterol. See, these two are atherogenic lipoprotein and it also increases HDL. It's a good cholesterol anti-atherogenic. Such a super drug, the niacin, among the cholesterol lowering drug, which drug maximally increasing HDL mean? Answer niacin. Important. And then regarding adverse effect, I discuss later on. Anyway, keep in mind, niacin causing adverse effect of severe photosensitivity. We discuss later on. Wait for some time. Next, very special question, repeated question. Come on. Name the PCSK9 inhibitor useful for managing hypercholesterolemia. Protein convertase subclissin kexin. PCSK9 blockers are evolocumab and alirocumab. Both are monoclonal antibody given subcutaneously, useful for reducing LDL cholesterol. This question came repeatedly. You should know. Okay. It's a alirocumab and evolocumab. Okay. And then Most of the statin are having half-life of only 3 to 4 hours only. But my question, name the statin having very long half-life. We having rosuvastatin and atorvastatin. Rosuva half-life is almost 19 hours. Atrava about 14 hours. So remember, among the statin, the longer acting statins are rosuvastatin and atorvastatin. Rosua acting for about 19 hours, longest acting statin. Okay. This is another very important question. Very important. Look here. We know niacin, one of the wonderful drug, reducing LDL, LPA, increasing HDL cholesterol, but causing adverse effect of flushing. One of the most common adverse reaction of niacin is flushing. Protein is flushing. It is due to release of vasodilatory prostaglandin. So question, one of the common side effects in flushing due to prostaglandin. That's why MCQ. The niacin-induced flushing can be controlled by adding with aspirin. Remember, aspirin inhibiting prostaglandin synthesis, thereby useful to control niacin-induced flushing. So, aspirin. Now, I just want to tell some newer drug, very useful for you. Look here. Ezetimibe. It's a cholesterol-lowering drug acting by inhibiting cholesterol absorption from GIT. Actually, imagine it's the intestine. From the intestine, cholesterol getting absorption. The absorption of cholesterol done by one transporter called as NPC1L1. Niemann-Pick C1L1 like transporter. Through the transporter, cholesterol getting absorption. Ezetimibe inhibiting this transporter, thereby inhibiting cholesterol absorption next. Now I'm waiting. Can you please answer? Ezetimibe inhibiting dietary cholesterol absorption mean what will be the adverse effects? Come on. The unabsorbed cholesterol passes through feces, resulting in steatorrhea. Steatorrhea is the most important adverse effect of ezetimibe, inhibiting cholesterol absorption, causing steatorrhea. Very good, ma. Very good, very good, very good. Okay. Next, look here. Statin. Statins are a wonderful drug for lowering cholesterol, but they cause adverse effect. The most important adverse prostatin, muscle weakness, myopathy, sometimes severe muscle lysis, rhabdomyolysis. Remember, statin causing adverse effect of mainly muscle pain, sometimes causing myalgia, sometimes muscle weakness called myopathy, and rarely rhabdomyolysis. Other adverse effects, they may also cause hepatotoxicity. Hepatotoxicity also there, be careful. And statins are unsafe in pregnancy. Statins are contraindicated in pregnancy. Okay. Next, new drug, 3 to 4 new drug, please watch. Mipomersen. It is an antisense antisense oligonucleotide inhibitor, inhibiting ApoB100, given with inhibiting ApoB100 and useful for reducing LDL cholesterol. Mipomersen given injection subcutaneously once in a week. Useful for lowering VLDL, useful for lowering LDL and VLDL, called mipomersen inhibiting ApoB100. And then pemdi, pembidic acid, is inhibiting ATP citrate lyase, ACL, ATP citrate lyase blocker. Then we have one new drug called evinacumab, a latest MAB, mechanism action, angiopoietin-like 3, angiopoietin-like 3 inhibitor called evinacumab. And then one more point, just one more point. Cholesavalum. It's a bile acid sequestration. Bile acid sequestration. It's a cholesterol drug. Got approval for diabetes. Important. Name the cholesterol drug. Got approval for treatment of type 2 diabetes. It is cholesavalum. Cholesavalum. Okay. Now in your workbook, you just add one point item. We have evolocumab, alirocumab, both are PCSK9 blocker, no? So just to one new point, add this point, very useful for you. The point is, look here, look here. We have, please watch. We have alirocumab, evolocumab, both are PCSK9 blocker, useful for lowering LDL. That you know. But today you should know, we have something called inclisiran. Please note, inclisiran. It is the PCSK9 synthesis inhibitor. We call this SI. Small interfering RNA, siRNA synthesis inhibitor. We call inclisiran. It's a drug inhibiting synthesis of PCSK9. We call this siRNA. So small interfering RNA inhibiting synthesis of PCSK9, drug name inclisiran. It is also important. And just two more points you add, I missed in your book. Just add some new drugs. One new drug, inclisiran. Other new drug, look at this. We have something called dorcetrabib, dolcetrabib, anacetrabib. Look at drug name ending with the cetrabib, cetrabib. Look here. That is, they call CETP blocker. What is CETP? That is cholesterol ester transport protein inhibitor. Cholesterol ester transport protein blocker. So we are having dorcetrabib, dolcetrabib. All the drug name ending with cetrabib, cetrabib. Similarly, one more new drug, MTP blocker, called MT mean microsomal triglyceride transport protein blocker, drug name lomitapide. Microsomal triglyceride transport protein blocker, drug name lomitapide. And just last, avacimib. Avacimib, it's a ACAT inhibitor, inhibiting conversion of cholesterol to cholesterol ester. That's all. So I think in cholesterol chapter, I given all the old cholesterol lowering drug, including newer drug. In my opinion, you should very good in PCSK9 blocker, alirocumab, evolocumab, and PCSK9 synthesis blocker, inclisiran, very important. And but about mipomersen, you should know. And then torcetrabib, a cholesterol ester transport protein blocker, and finally lomitapide. It's a microsomal triglyceride transport protein blocker. Okay, that finishes something about cholesterol lowering agents. Okay, right, man. So what we done so far? Blood chapter. Two important topics: thrombolytic agent, anticoagulant, antiplatelets, and then cholesterol. One very important topic over. Now we move to the next most important topic called renal. Renal. Shahdeep Singh. Tea break question mark. The tea break will be given only by 4:40 from my side. If you want to break for tea, please go and rejoin doctor because I want to help you. Within 2 days, I want to give maximum points for you. So try to understand. So next, we have to finish before the next week. We have to finish diuretic and anti-diuretic chapter. Okay. So we now start with the diuretics. We done serious blood. Now related to serious next topic, kidney chapter. Very important topic. Very important. If you are sincerely listening my discussion, you can enjoy. For example, look at how to enjoy my discussion. See, wait, I'm going to show directly in PDF. Wait. Yes, look it. Diuretic and anti-diuretic chapter I'm going to discuss. Listen. Right. To start, see, what are the important points in diuretic? Based on the site of action, we have different classes of diuretic. I go one by one. Everything very important. Listen. First, we go for loop diuretic. What are the important points in diuretic? On the site of action. Okay. To start, loop diuretic. As the name indicates, these drugs are acting on thick ascending limb of loop of Henle. Acting on thick ascending limb of loop of Henle. And here we have we have one important symptotom called sodium. Okay, yeah, small error vector. Yeah, hanging. I know. Rejoin. A small issue. Rejoin. Yeah. I'm repeating. Copy name, directory. I'm repeating. Depending upon the site of action, we are having so many classes of directory. The first directory taken for discussion, loop directory. As the name indicate, reacting on the ascending limb of loop of Henle. Thus we call loop diuretic. Here MCQ, in the ascending thick loop of Henle, we have one thing called sodium potassium 2 chloride symportar. We are having sodium potassium 2 calcium potar. So question, all the loop diuretic like furosemide acting by inhibiting sodium potassium 2 calcium potar, thereby causing loss of sodium potassium chloride. Okay. Now, all the loop diuretics are very much useful for edema and are a wonderful drug for rapid symptom relief in case of edema. For rapid relief, the best. Okay. Now, look here. In case of congestive heart failure, for rapid relief of breathlessness in heart failure, I can go for furosemide. 1 point. And they can also useful for edema due to cirrhosis or edema due to nephrotic syndrome, any type of edema. But very important, useful for pulmonary edema due to heart failure. And the furosemide is a faster in onset of action and shorter in duration action. So because of fast in onset, short in duration, it can be useful for hypertensive emergency. This one important. Because of faster in onset and shorter in duration, useful for hypertensive emergency. And it is also having non-direct use. For example, useful for hypercalcemia. Remember, loop diuretic loses calcium in urine. That means they promoting calcium excretion. Because of promoting calcium excretion, useful for treatment of hypercalcemia. But at the same time, you should know because of losing calcium in urine, they cause adverse effect of kidney stones, calcium stones. So question, which is the group of diuretic causing kidney stone? Mean answer loop diuretic. They causes calciuria that causing kidney stone formation. That's what important therapeutic uses based on. Revise adverse effect. While talking about adverse effect, they are the potent diuretic causing too much of water loss. Also, they cause so many electrolyte problem in that very important loss of sodium, calcium, chloride. Very important potassium loss. They cause hypokalemia. Hypokalemia loop directly causing hypokalemia, and they also causing loss of H plus. By loss of H plus ion causing metabolic alkalosis. They cause alkalosis, and then all the loop diuretic may cause ototoxicity, especially ethacrenic acid causes maximum ototoxicity. Remember, all the loop diuretic may cause ototoxicity. It is maximum with ethacrenic acid. That is what causing maximum risk of ototoxicity. Okay, of course, I told already loop diuretic because losing calcium risk of causing kidney stone formation. All these are important action based use, action based adverse effect. That's what loop diuretic. The main drug is furosemide. Okay, coming to second, very important, thiazide diuretic. For example, we are having chlorthalidone, chlorthalidone, metalazone, hydrochlorothiazide, like that lot of drug, no, what they do. The thiazide drugs are acting on distal convertible. Here, they inhibiting sodium chloride symporter. In the DCT, we having sodium chloride symporter. They acting by blocking sodium chloride symporter, thereby causing sodium loss, chloride loss. Of course, similar to loop diuretic, they also causing potassium loss and H plus loss. So they also causing hypokalemia and metabolic alkalosis. So loop diuretic and thiazide both are causing hypokalemia and metabolic alkalosis. But the only super important point is thiazides regarding uses very important. 3 point, 3 point. Adverse effect come later. First use as a use thiazide as a diuretic useful for mild edema. Thiazide as a diuretic useful for mild edema as well as they having vasodilatory property useful for hypertension. See, they have vasodilation plus sodium loss. Because of these two property useful for hypertension. In fact, we discussed already thiazides are first line drug for hypertension. Now question goes to Prachi, Satya, Sri, Harshman. Can I answer? See, thiazide diuretics are routinely useful for hypertension. Whereas, look here, your loop diuretics are useful only for hypertension emergency. Why? Come on. Among the diuretic, thiazides are routinely useful as a first-line drug for hypertension, whereas loop diuretic like furosemide useful only for hypertension emergency. Why? The point is furosemide faster in onset but shorter in duration action. Fast acting, short acting useful only for emergency, not for routine purpose. Okay. Whereas thiazides are slow in onset and longer in duration action. Because of that, useful routinely for hypertension. In this case, my question goes to all people. Can you please answer? Name the diuretic we discussed already useful for resistant hypertension. I'm waiting, man. I'm waiting. Please answer. Routinely for hypertension, I go for thiazide. In case of emergency, I go for furosemide. But name the diuretic useful for treatment of resistant hypertension. I'm waiting. Please answer. Name the diuretic useful for treatment of resistant hypertension. One. I'm audible or not? The answer is spironolactone. Spironolactone. Okay. So routinely for hypertension, we go for thiazide. In emergency, we go for furosemide. In case of resistant hypertension, we go for spironolactone. Everything discussed, you have to revise. You have to revise. Okay. Now, I just want to tell extra points also. Look here. The thiazide diuretic causing extra use. One use for hypertension, one more thing, mild edema. Other use, the thiazide having anti-diuretic property also useful for nephrogenic diabetes insipidus. Useful for nephrogenic diabetes insipidus. And since thiazide, one important point, thiazide causing calcium reabsorption. Because of this property, useful for preventing kidney stone formation. Remember, loop diuretic causing kidney stone formation, whereas thiazide prevents kidney stone formation. One more thing, since thiazide causing calcium reabsorption, they can also tried for treatment of osteoporosis. So name the diuretic that can be useful in osteoporosis. Main answer, thiazide. Okay. Next, regarding adverse effect, keep the MCQs. First question. Thiazide causing adverse effect of hypokalemia, alkalosis, very important point, they cause hypercalcemia, hyperglycemia, and hyperuricemia. Very important, very important. Okay. They cause hypercalcemia, hyperuricemia, and also hyperglycemia. Okay, that's what adverse effect. Right. Next comes the third important group is called potassium sparing diuretic. Come on, potassium sparing. The potassium diuretic acting on collecting duct. But the point is, I am dividing them into two categories. One group is aldosterone antagonist. Other group is we have something called ENaC, epithelial sodium channel blocker. Two category. We now go one by one. Ready? First, I go for aldosterone receptor antagonist. Those drugs are having spironolactone. And anybody, I'm waiting one simple question. Here you should answer. You should type one. It is an active drug. It's an active drug. But this drug produces still more active metabolites. Metabolites. Anybody? What is the most active metabolite of spinal? Anybody? What is the most active metabolite of spinal? It is candrenin. It is an active metabolite. So we having spinal it becomes candrenin. That's the most active metabolite of spinal. Am I audible? Your chat is not. No, okay. Okay. It's not man. What man? What? Oh, fine. I just repeat from potassium sparing diuretic. I will repeat. Okay. Come on, come on, come on. Yeah. Right. We start. Potassium sparing diuretic. Almond join LRR PYQ enough. More than enough. Okay. Because in my point of view, I'm talking in myself again. From pharmacology point of view, if you are very good at LRR plus PYQ and DVT, it is more than sufficient because I am genuinely prepared every topic based important points to be studied. For example, LLR, that is good, very interesting preparation. I covered all the points. So if you really study LRR and your PYQ, DVT more than sufficient. Okay, we start. Potash diuretic. The potash diuretics of acting on collecting ducts, and here there are two type of ducts are there. One group is called aldosterone antagonist. Other group is called as ENaC, epithelial sodium channel blockers. Now my question starts. Look here. Aldo antagonists we having spiral lactum. But one doubt. My question. Yes, Nishat Ali. Today I am going to finish AutoCAD GATRS. After finishing directing, my next thing is discuss about GATRS AutoCAD. Okay, that's the plan. We start. Look here. Now you please answer my question alone. Look here. Spironolactone, one of the active drug. Now my doubt is this drug itself active, but this drug produces still more active metabolites. Anybody? What is the active metabolite of spironolactone? Any answer? It is candrenin. Very important, very important. Candrenin is an active metabolite of spironolactone. You must know, must know, must know. Okay, good. And spironolactone, yeah, antagonist aldosterone. So useful for treatment of hyperaldosteronism. For example, in case of Conn syndrome is a primary hyperaldosteronism. For that, we can use this and useful for secondary hyperaldosteronism. For example, in case of heart failure. In heart failure, there's a reactivation of ROS, renin angiotensin aldose system. So, in heart failure, aldosterone antagonist acting as a disease modifying drug. Very important, very important. And it's also useful for resistant hypertension. So, in cardiology, spironolactone useful for treatment of heart failure as a disease modifying drug preventing remodeling. Also useful for resistant hypertension. Okay. And of course, we call this potash sparing. That means going to increase the loss of potassium. So it can be combined with loop or thiazide to compensate hypokalemia. Thiazide directing, loop directing may cause hypokalemia, provided that we can combine with spironolactone. Okay, so use one for heart failure, second for resistant hypertension, and some more uses useful for Conn syndrome and also useful for polycystic ovary. It has anti-androgenic property useful for treatment of PCOD. That's also important. Okay. And spironolactone, a wonderful diuretic for treatment of edema due to liver cirrhosis. In case of ascites, liver cirrhosis, for that case, the fantastic drug is spironolactone. Very important. Yes, good. Badmini, very important. Is a very fantastic drug for treatment of ascites due to liver cirrhosis. Okay. And it causes adverse effect of hyperkalemia and metabolic acidosis, and because of anti-androgenic risk of gynecomastia. Okay, that is important. And then ENaC blocker, we having amiloride and trimethoprim. Here most famous is amiloride, acting from lumen, acting against ENaC. Useful for treatment of hypokalemia because causing hyperkalemia, and it is useful for LIDDLE, Lille syndrome. It's a congenital overaction of ENaC. For treat, in this case, we can try this. Also, very good choice. So, drug of choice for treatment of lithium-induced diabetes insipidus. Useful for treatment of lithium-induced diabetes insipidus, and also can be useful for cystic fibrosis. That's about amiloride. So, we done potassium sparing diuretic. Next comes very simple topic called carbonic anhydrase enzyme inhibitors. Okay. When I say this, the best example, acetazolamide acting on PCT. Here, look at the point. The mechanism action, it is acting on PCT, inhibiting carbonic anhydrase enzyme and reduces absorption of bicarbonate. Very important, very important. In the PCT, it inhibiting absorption of bicarbonate. And one more thing, it is also going to cause retention of H plus ion. That means it will cause metabolic acidosis, but causing massive loss of potassium. So the adverse effect, metabolic acidosis with hypokalemia. Remember, spironolactone causes spironolactone causes acidosis and increased potassium, whereas acetazolamide causes hypokalemia with metabolic acidosis. And very special point. Look here, acetazolamide useful for glaucoma, used orally, the one and only orally given drug for treating glaucoma, acetazolamide. And it is also useful for alkalosis, mountain sickness, very important. Name the diuretic useful for treatment of mountain sickness mean acetazolamide. It controlling intracranial pressure, so useful for ICT, and it has anti-epileptic property useful for treatment of absent seizure and for catamenial seizure, useful for absent seizure and for catamenial. Now one doubt I have, my doubt is, look here, when you talk about carbonic anhydrase enzyme blocker, I told only acetazolamide because it is the one acting on kidney and having diuretic property. Whereas you have to answer me one. Name some carbonic anhydrase enzyme blocker acting on eyes. In the eye, there are some drugs, carbonic anhydrase enzyme blocker given topically in the eye, the inhibiting carbonic anhydrase and reduces aqueous production. What are they? One is called dorzolamide. Dorsolamide, dorsolamide, dorsolamide. One more drug called brinzolamide. Both the drugs are given as eye drop, given as eye drop useful for treatment of glaucoma. They decreases aqueous production. Dorsolamide and brinzolamide. Okay. Now coming to next one is osmotic diuretic. Very special. Listen carefully. Osmotic, the increases plasma osmolarity, thereby extracting fluid from the cell into vascular compartment. Look here. We have one thing called mannitol, very famous example for osmotic diuretic. The name osmosis indicate increasing the plasma osmolarity, thereby extracting fluid from tissue into vascular compartment. They call osmotic. They are acting on entire portion from mainly acting on PCT and early portion of Lupa Henley. Main site action PCT, also early portion of Lupa Henley. Okay. And the main action extracting water from cell, thereby useful for treatment of cellular edema. That means useful for treatment of cerebral edema. And very important, they have diuretic property. This property useful for managing edema as well as useful for glaucoma. For glaucoma IV drug, important. The one and only drug given intravenously for treating glaucoma, mannitol. Oral drug is acetazolamide. All other drugs are eye drops. Okay. Mannitol can also useful for treatment of dialysis disequilibrium syndrome. That is, following dialysis, too much of loss of uh, urea, they may cause some cranial neurology problem that is going to control by using mannitol. Mannitol useful for severe edema, useful for glaucoma, useful for managing dialysis-induced disequilibrium syndrome. And the main adverse effect causing severe electrolyte problem, severe loss of sodium, hyponatremia, also causing headache problem. And very important for exam purpose, you should know these drugs are, that is mannitol, contraindicated in pulmonary edema, contraindicated in cerebral hemorrhage. In these two cases, they are contraindicated. Very important. Mannitol is not good in patient with pulmonary edema, not good in patient with cerebral hemorrhage. This is very important, very important. Okay. So we done diuretic. Acting on PCT mean carbonic anhydrase enzyme inhibitor. Acting on PCT on early portion of Lupa-Henle mean osmotic diuretic. Acting on thick ascending limb of Lupa-Henle mean loop diuretic. Acting on DCT mean thiazide diuretic. Acting on collecting that mean potassium sparing diuretic. I think all the important diuretics are over. Now I just go for extra points. Okay. We have one thing called sodium glucose transporter to blocker. Actually, they are anti-diabetic drug, but they also acting on PCT. Huh? Sakshi asking why contraindicated. Okay, look here. This portion, this portion is asked. Okay, look here. Why metal contraindicated in pulmonary edema? Why unsafe in cerebral hemorrhage? Just to watch. Just to watch. Look here. When you talk about, just once again, just watch. Look here. Why mannitol unsafe in cerebral hemorrhage? Watch me. See, I told mannitol a drug osmotic, that is extracting fluid from cell into vascular compartment. Okay, my drug extracting fluid from cell into vascular compartment. Okay. Now look here. If the drug extracting fluid into vascular compartment, intravascular volume increases, it may cause further hemorrhage. Further hemorrhage, it may worsen the hematoma. Hematoma. 1 point. Second point, in case of hemorrhage, my mannitol may get out of plasma. Mannitol may go out of plasma. When goes out of plasma, going to cause reverse. That means extracting fluid from blood into cell. That will increases cell edema. Two things. One reason is they may increases intravascular volume. This may further aggravate the hemorrhage. Second reason, mannitol may get out of plasma through hemorrhage. When get out, it causes reversal. What? Extracting fluid from vascular compartment into cell. That means cell edema get increases. By the two way, it is unsafe. Why in heart failure? Same thing. My mannitol extracting fluid from cell and from interstitium into vascular compartment. When there is an increased fluid load in plasma, it causes alveoli congestion. The alveoli flooded with the fluid, causing problem of oxygen exchange and respiratory difficulty. So, for exam purpose, just remember mannitol contraindicates in edema and also in case of cerebral hemorrhage. These 2 points you should know important. Okay. Now we are discussing extra. What extra? Sodium glucose transporter 2, SGLT2 blocker. They are actually anti-diabetic, but they are acting on kidney in the PCT. By inhibiting sodium transporter, they cause loss of sodium and water, so they also acting like a say practically in case of edema we are using mannitol, but theoretically for MCQ remember mannitol unsafe in civil hemorrhage, unsafe in acute heart failure. Okay, now come to the mind. SGLT2 blocker causing sodium loss, water loss, and they are useful for diabetes purpose as well as heart failure. Can you repeat my easy question? Which are the SGLT2 blocker useful for or approved for treatment of heart failure? Can you repeat? Which are the SGLT2 blocker got approval for treatment of heart failure? Three drugs: dapagliflozin, empagliflozin, and sotagliflozin. Very important. Empa, sota, and dapagliflozin. Of course, this we are going to discuss tomorrow in diabetes chapter. They cause glucose loss. So the most common adverse effect, urinary tract infection, especially causing fungal infection. Fungal infection. Anyway, tomorrow we discuss detailedly what are the important adverse effects. They cause UTI, they cause Fournier's gangrene, they cause ketoacidosis, lot of problem. This we will discuss in diabetes chapter tomorrow. Okay. Now, I am going to ask three interesting clinical case, doctor. Very interesting, very important. Look here. When you talk about diabetic, three cases you should know. Liver cirrhosis, patient presenting with ascites. For this edema, what is the best choice? The best drug choice is spironolactone. Okay. In liver failure, aldosterone is not getting proper metabolism. It causes severe hyperlipidemia. aldosteronism. So I go for aldosterone antagonist spironolactone. Whereas in liver failure, acetazolamide contraindicated. This is also important. Acetazolamide unsafe in liver failure. Okay. And next, regarding heart failure. What is the role of diuretic in heart failure? Look here. In heart failure, for rapid symptom relief of breathlessness, the best drug of choice furosemide. Remember, furosemide having diuretic property as well as vasodilating property, but very fast acting and short acting. It is the dietary choice for rapid relief of breathlessness in acute heart failure. Remember, it is useful only for symptom relief, whereas disease modification is spinal atom. It is going to modify disease. Okay, and then mannitol is contraindicated in heart failure. Okay, then kidney stones. Remember, diuretic causing calcium reabsorption, thereby preventing stones, useful for treating stones, whereas loop diuretic loses calcium in urine, causing calciuria. The calciuria going to cause stones. So, which is the diuretic causing stone mean loop, which is useful for treating stones mean thiazide. All these are very important, very important. Okay. Dr. SCB, acetazolamide, in case of liver failure, going to accumulate further ammonium may precipitate hepatic encephalopathy. Thus why acetazolamide contraindicated. They accumulate ammonium. In liver failure, already there's ammonia accumulation. So my acetazolamide going to cause severe hepatic encephalopathy. Thus why it is contraindicated. Okay. And two more important points you should know. Look here. We have one drug called phenyrenin. What is this? It is the non-steroidal mineralocorticoid receptor antagonist. Look here. We have spironolactone. The spironolactone is the steroidal mineralocorticoid antagonist, whereas it is non-steroidal mineralocorticoid antagonist, and the phenytoin useful approved for CKD, diabetic patient CKD. In this patient, preventing heart failure. So, question useful for diabetic CKD patient. Phenytoin, a non-steroidal mineralocorticoid antagonist useful for treatment of diabetes patient with the CKD to prevent heart failure. It improving kidney function as well as improving heart function, useful to reduce the risk of hospitalization in diabetic CKD patient and also preventing heart failure. Such a wonderful drug called phenytoin. And another important MCQ you should know regarding diuretic and drug interaction, very, very important. Please follow. When I say interaction, look here. First, I discuss about loop diuretic. Look here. We have one famous drug called furosemide. Here, three MCQ you should know. One, furosemide. All the loop diuretic may cause ototoxicity. So, when they give with other ototoxic drug like aminoglycoside, or when they give with the cisplatin, or with the vancomycin, or with the erythromycin, there's a high risk of ototoxicity. All loop diuretic are ototoxic, so be careful. Next, furosemide and digoxin drug interaction you must know. Look here. Furosemide causing adverse effect of hypokalemia. Hypokalemia. Now you should tell. For treating heart failure, if you give furosemide with the digoxin, what happened? We studied already. Digoxin toxicity will be aggravated in the presence of hypokalemia. So, question: if we give digoxin with the furosemide, the furosemide will increases risk of digoxin toxicity because furosemide causing hypokalemia. In the presence of hypokalemia, digoxin toxicity get worse. Last point. See, furosemide and lithium drug interaction. Very important, very important. Furosemide interfere lithium excretion through kidney. Furosemide decreases renal excretion lithium, thereby increasing plasma lithium level. That means going to worsen lithium toxicity. Diuretic, especially loop diuretic, going to especially thiazide and loop, they're going to aggravate lithium toxicity. Thiazide diuretic and loop diuretic will increases plasma level lithium, going to cause lithium toxicity. Okay. And finally, one super question. Look here. Potassium sparing diuretic. They cause hyperkalemia. So be careful while using this along with the ROS pathway blocker. Any ROS pathway blocker like Isivitar, ARB, or even ENAC blocker. All these are causing hyperkalemia. So when you give spironolactone with ROS pathway blocker like Ismetop, ARB, they will cause severe hyperkalemia. So message: any drug blocking ROS pathway has the risk of causing hyperkalemia. And what's this? Syed is asking antidote for lithium toxicity. See, man, lithium causing problem of cardiotoxicity and then congenital anomaly, lot of things. What they say for treatment of nephrotoxicity, like lithium-induced diabetes insipidus, we can try amiloride. Amiloride, one of the ENaC blocker, useful for treatment of lithium-induced diabetes insipidus. Okay, Sayed? Okay. Now, one more question you should know. Diuretic and kidney failure. This is also important clinical point. Okay. Imagine a patient is having kidney failure plus edema. My question is, what is the safest diuretic for treating edema in kidney failure? So please note, loop diuretic are the best drugs for treatment of edema in kidney failure. So question, whenever there's edema and kidney problem, the best is go for loop diuretic. Loop like furosemide, tarsemide, all these are preferred diuretic in the presence of kidney failure. So the best diuretic for treating edema in the presence of kidney failure means always go for loop diuretics. Okay. Second point. What about thiazides? Thiazides are ineffective in the presence of kidney failure. See, for producing diuretic action, thiazide need good kidney. Only in the presence of good functioning kidney, thiazide will give action. That means they have reduced efficacy in the presence of low GFR. But you should know, we have a drug called metalazone. Very important, very important. Among the thiazide, metalazone useful even in the presence of severe kidney failure. So usually thiazides are not effective in the presence of kidney failure. For thiazide to act, the patient should have proper functioning kidney, whereas metalzone, even thiazide, it is acting even in the presence of kidney failure. So 2 points. Usually kidney failure, and I mean best is go for loop. Among the thiazide, metalozone can be safe drug. Okay. Potash by diuretics are usually not used. If at all used, used cautiously, and they are contraindicated in advanced kidney failure due to risk of hyperkalemia. So we don't go for that. Even carbonic anhydrase enzyme blockers also rarely used, and they are also unsafe in severe kidney failure. So the best is loop diuretic or else thiazide. Among thiazide, best is metolazone. What about mannitol? Mannitol actually useful in acute condition, useful in acute kidney injury, but mannitol contraindicated in established kidney failure. Mannitol can be useful in acute kidney injury, but unsafe or contraindicated in case of established kidney failure. Okay. And finally, SGLT2 blocker, they are reducing kidney uh, problems. Actually, in diabetic patient, they have renoprotective property. Okay. SGLT2 blockers we are using in diabetic patient, they have renal protecting property. But what they say, they're not recommended in advanced kidney failure. Already in established kidney failure mean we don't use. It useful in diabetic patient to prevent kidney dysfunction. But in advanced kidney failure, they are not useful. Okay, that's about diuretic and kidney failure. Message very simple. The best diuretic for treating edema in the presence of kidney failure, go for loop diuretic. Or else go for thiazide. Among thiazide, go for metolazone. That's all. Okay. Now we done almost all the most important aspect of diuretic, namely uh, all class of drug, carbonic anhydrase enzyme blocker, loop diuretic, thiazide, potassium diuretic, osmotic, all class of diuretic. Now finally, finishing question, antidiuretics. That is, we have antidiuretic hormone is also known as vasopressin. So next 5 minutes I'm going to discuss what are the important actions of vasopressin and what are the vasopressin antidote. Like that, one by one I'm going to discuss. Ready? Start. Very important, very important. Look here. Vasopressin, a posterior pituitary hormone, it is going to act on V1 and V2 receptor. So we now go for one by one discussion. Okay. What's Amtul? Can I see now? Ready, Amtul? We start. Vasopressin, also known as anti-diuretic hormone, acting on V1 and V2 receptor. One by one we start. Okay. First question. Name the vasopressin analog acting on B2 receptor. Please watch. We have one drug called desmopressin. It's a vasopressin analog selectively acting on B2 receptor. Now you should think the B2 seen on collecting duct as well as on vascular endothelium. Endothelium. Now I have to go to clinical point. Vasopressin acting on B2 on collecting ducts. By acting on collecting duct, what it does? It's a anti-diuretic hormone. No? So it causes water retention. Based on that, useful for treatment of it's a drug of choice for cranial diabetes insipidus as well as drug of choice for nocturnal aneurysms. So By acting on collecting duct of kidney, it causes water retention. This property useful as a drug of choice for cranial diabetes insipidus as well as drug of choice for your nocturnosis. Okay, but it is also acting on V2 on endothelium. By acting on vascular endothelium, releases factor number 8 and von Willebrand factor. Because of this property, it is useful for treatment of bleeding due to von Willebrand factor deficiency, bleeding due to factor 8 deficiency called hemophilia. So useful in hematology also. 2 point. Next question. Name some synthetic analog of vasopressin acting on V1. Here, desmopressin, a V2 and agonist, whereas we have something called felipressin, lipressin. They call V1 agonist. The V1 say not vascular smooth muscle. Now question starts. Terlipressin as a V1 agonist acting on vascular smooth muscle causing vasoconstriction. This property useful as a best drug for treatment of bleeding from varices. So terlipressin useful for controlling bleeding from varices as well as useful in renal syndrome. Anyway, the main point is a vasoconstrictor useful for managing bleeding from varices along with the octreotide. See, octreotide is the best drug of choice. Along with the octreotide, we can supplement terlipressin for controlling bleeding from varices. Okay. So we done V1 and V2 agonist. Now we go for V1, V2 antagonist. Simple. Look here. You know V1 seen on vascular smooth muscle, V2 seen on collecting ducts. Now question starts. Look here. I have one drug called Vaptane, namely Conivaptane. It is a V1 and V2 blocker. Non selective V1 and V2 antagonist, but maximally blocking V2. It's maximally blocking V2. By blocking V2, useful for SADH. See, it's a S vasopressin mean ADH. Blocker mean useful for treatment of SADH. Okay, useful for treatment of syndrome of inappropriate education. And another point, we use something called selective beta blocker like tolvaptan, lixivaptan, mosavaptan, cetabaptan. All are selective B2 blocker and they are the very fantastic drug of choice for treatment of SIADH. So today, the best drug of choice for managing SIADH is Vaptan. Vaptan is a group of drug acting against V2 receptor. So Vaptan, like Lexivaptan, Mosavaptan, Tolvaptan, Cetabaptans, all are drug acting against V2. They are drug of choice for SIADH. The so-called dilutional hyponatremia useful for managing hy- dilution, useful for managing dilutional hyponatremia. Okay, and finally the tolvaptan special also useful for treatment of autosomal dominant polycystic kidney, useful for polycystic kidney also. Polycystic kidney also. Okay. So we know B2 blocker are called baptines. Okay. And then we have V1 selective antagonist called relcavaptan. Since V1 seen on vascular muscle, V1 blocker causing vasodilation. This property useful for treatment of peripheral vascular disease like Raynaud's phenomenon. Yes, One, these are oral, whereas conivaptan IV drug. Conivaptan IV drug, remaining vaptans are oral drug. The only one vaptan IV is conivaptan, others are oral drug. Okay. Now we done V1, V2 location, V1, V2 function, agonist, antagonist. So vasopressin antagonist also over. Next question, very simple. You must know question. Look here. That is when you talk about diabetes insipidus, what are the drugs useful for diabetes insipidus? For example, for cranial, the so-called central, for cranial diabetes insipidus, the drug choice is desmopressin. It's a V2 analog. It is the drug choice for cranial diabetes insipidus, and it has no role in nephrogenic diabetes insipidus. So drug choice for cranial diabetes insipidus. And then for treatment of lithium-induced diabetes insipidus, the drug choice is amiloride. It's one of the ENaC, epithelial sodium channel blocker, and it is the drug of choice for treatment of lithium-induced diabetes insipidus. And finally, for managing nephrogenic diabetes insipidus, we can try thiazide. One, thiazide can be useful for treatment of nephrogenic diabetes insipidus. Okay, so we discussed drug therapy useful for SIADH and drug therapy useful for diabetes insipidus also. So many things over. I have small doubt. If you answer my doubt, you are great. My first question, look here. For treating SIADH, we used to go for Vaptan. Vaptan. Okay. See, Vaptans are wonderful drug useful for SIADH. Okay. Now my doubt is gone. Name some drug causing that to name some drug that to name any antibiotic causing adverse effect of diabetes insipidus thereby useful for treatment of SIADH. Anybody? Name any antibiotic causing diabetes insipidus thereby can be tried for. Yes, good. Demaclo, very good. Demaclocycline, very good. It is an antibiotic causing diabetes insipidus, so it can be tried for SIADH. Good, ma, fantastic. Similarly, lithium, a drug useful for bipolar, it is causing diabetes insipidus, so it is also can be tried for SIADH. But Vaptans are the drug of choice for SIADH. Okay, that's important. Okay, and thiazide having anti-diuretic property also by unknown mechanism. That's why they useful for nephrogenic diabetes insipidus. Okay, I think we finish one super important topic called diuretic. But out of interest, I just want us one or two extra question. If you answer this extra question, you are too good in medicine. I'm just deviating out of interest. Can you please answer? The question is look here. Question is look here. Imagine it is a PCT. It is extra out of interest. Here PCT. Here Lupa Henley. And here DCT. And here collecting ducts. My question starts. My question is name the group of drug causing proximal tubal injury thereby causing Fanconi syndrome. Fanconi syndrome. Name any antibiotic or name any antivirus causing Fanconi syndrome, causing proximal tubular changes. For example, outdated tetracycline causing Fanconi syndrome. Similarly, in antivirus, we have one drug called uh, tenofovir. a drug for HIV. It also causing Fanconi syndrome. Okay. Next question. Ready? Easy question for a medicine paper. Come on, actor. In the ascending limb of loop for Henry, we have sodium, potassium, two plus import. Your loop directly inhibiting this import. This will be symptom like what syndrome? What syndrome? Name one syndrome that having the symptom that of loop diuretic. That's called Bartter syndrome. Bartter syndrome. Okay. And then in the DCT, we having sodium chloride symporter. Sodium chloride symporter. Thiazide inhibiting this import. Now tell me, name the syndrome having symptom like thiazide. Name the syndrome. They're having symptom like thiazide called as Gittleman syndrome. Gittleman syndrome. In this syndrome, symptom similar to thiazide diabetic. Gittleman syndrome. Very good. And finally, look here. In the collecting that we have epithelial sodium channel. Overaction of this channel causes Little syndrome. Little syndrome. Now question starts. For treating this syndrome, we go for amiloride. Amiloride, a ENAC blocker useful for treatment of Little syndrome. Okay, this is about medicine, nephrology, and syndrome. And finally, message very simple. Look here. When we talk about diuretic and metabolic problem, look here. Those directing acting on PCT, and those acting on collecting that they are causing metabolic acidosis, extremely acting drug like carbonic anhydrase enzyme inhibitor and potassium sparing diuretic causing metabolic acidosis, whereas the loop diuretic and loop and thiazide causing metabolic alkalosis. It is also important. Loop diuretic and thiazide causing metabolic alkalosis, whereas carbonic anhydrase enzyme blocker and potassium sparing diuretic causes metabolic acidosis. That finishes one very important mega topic called diuretic and antidiuretic. Okay, so far we done CVS renal blood. So from the morning up to this time we finished general pharmacology, ANS, CVS, blood and kidney. So more than 5 systems are over. Okay, system over. Ready? Now the next system we move on to GIT, gastrointestinal system. Okay. Giant pod here. You want this one? This one? This one? This one? Huh? Okay. Now you just take a break. Now time is almost 4:30. Take a break for 10 minutes and then we go for GAT, RS, AutoCAD. Okay. Take small break. No, take a 10 minutes break. No problem. Take a small tea break. Somebody asked no tea break. No, can take a tea break now. Okay. So, so time for a break. We go for break. Take a break for 10 to 12 minutes. Finish your coffee and then we start. The next system we're going to cover GAT. Here, three important things you should remember. Drugs useful for acid peptic disorder, and then drugs useful for treatment of vomiting, drugs useful for treating diarrhea, drugs useful for inflammatory bowel disorder, and drug therapy for IBS. irritable bowel syndrome, like that. Okay. So one by one we start discussion. Wait. Yes. Topic starts. 1 second. Right, doctor. First, important revision points from acid peptide disorder. For treating acid peptide disorder, revise one group of drugs acting by decreasing acid secretion. In this category, we have proton pump inhibitor, H2 blocker, and M1 blocker called anti-muscarinic like pyrenzepine, tenzepine. The second group of drugs useful for treating APD are called antacids. And the third group of drugs are called ulcer protective. Ulcer protective. Here we have prostaglandin analog PGE1, prostaglandin PGE1 analog like misoprostol, and then we have colloidal bismuth substrate, and then we have sucralfate. And finally, we have ulcer healing agent like carbendazole. Like that, we have ulcer healing. Also, we are having anti-H. pylori drugs useful for H. pylori like this. So now a small revision, please watch. Proton pump blockers are a group of drugs acting by inhibiting H plus K plus ATPase pump. See, when I say proton pump, the proton pump is made up of H plus K plus ATPase. So, all the proton pump blocker acting by inhibiting H plus K plus ATPase. And very important question, all the proton pump inhibitors are prodrug. Prodrug. So for their action, they need activation. Where they get activated, they are activated in the acidic canaliculi of the fatty cells. They are activated in the acidic canaliculi, that is acidic medium. And the active form is sulfonamide. Sulfonamide. So first point, proton pump blockers of prodrug. For its action, they need activation, and they activated by the in acidic medium, and the active form is sulfonamide compounds. Now, one question all must answer. The proton pump blocker inhibiting is pump option A reversibly or irreversibly. Proton pump blocker inhibiting the pump irreversibly. Irreversibly. This point is important. All the proton pump blockers are irreversibly blocking H plus K plus. It is because of this irreversible blocker. What is the advantage? The advantage is once the pump is blocked, there is no chance for further acid secretion. Once a pump is blocked, no chance for further acid secretion. That means for further acid secretion, we need to go for new pump. New pump. That means once a pump is inhibited, until the new pump formed, there is no acid secretion. And the new pump will found only after 24 hours. That means a proton pump blocker will have action for about 24 hours. Because of irreversibly inhibiting pump, single dose will have effect for 24 hours. See, actually the half-life of proton pump blocker is only 3 to 4 hours half-life, but action, the acting for 24 hours. So, half-life is very short, but the duration is long. It is called as hit and run effect, hit and run action. So, question. Proton pump blockers are generally having short half-life but having action for 24 hours. It is known as hit and run It is because of irreversibly blocking proton pump. All these are very important, very important. The question will be, even though omeprazole have a half-life of 3 hours, how it is able to decrease acid secretion for whole day? It is because of irreversibly inhibiting proton pump. Okay. And then look here. The proton pump blockers are drug of choice for so many conditions like drug of choice for NSAID induced ulcer, drug of choice for GERD, drug of choice for stress ulcer, drug of choice for Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. Like that, so many conditions. So, proton pump blockers are drug of choice for NSAID-induced ulcer. Drug of choice for GRD. All this you should know. And one another important question. Usually, proton pump blocker do not cause much adverse effect, but they may cause some adverse effect like chronic therapy causes problem of absorption of nutrient like calcium and magnesium. This is expected MCQ. Please note proton pump block causing what type of electrolyte abnormality. They cause adverse effect of hypomagnesemia, hypocalcemia, because they interfere absorption of calcium, magnesium. It's very important. Other common thing, they may cause adverse effect of B12 deficiency, anemia, and sometimes causing bone weakness, causing fracture, hip fracture. Sometimes they reduces acid secretion, so risk of infection, GI infection. All these are other thing. Chronic therapy may cause dementia, all this. But expected question, remember, they cause what type of electrolyte problem? They cause hypomagnesemia and hypocalcemia. This is important. Okay. And then this question I'm repeating so many times, very, very, very important. Clopidogrel, omeprazole, drug interaction important. I just like that. Can you please answer? Or omeprazole, clopidogrel, drug interaction. That is, omeprazole interfere the activation of clopidogrel based on dash enzyme. Anybody? It is based on which microsomal enzyme? Clopidogrel is a prodrug activated by help of CYP2C19. Okay, good, good, good. Next. And then coming to other question, we have one thing called H2 blocker. Very important, very important. Simitin, one of the H2 blocker causes adverse effect of gynecomastia. Remember, name the drug useful for treatment of gastritis having risk of causing male infertility and also risk of gynecomastia. Mean think of smearing. And we have one thing called prostaglandin E1 analog called misoprostol. It's an ulcer productive agent. It can be useful for treatment of NSAID induced ulcer, NSAID induced gastritis, and it is a teratogen, causes movie syndrome. Very important, very important. Name the drug useful for gastritis unsafe in pregnancy. It is misoprostol because it causes teratogenicity. So contraindicated for treating gastritis in pregnancy. This is very, very, very important. In this junction, can you please answer? Black screen. Why, man? In this junction, can you please answer? In this syndrome, dash and dash cranial nerve abnormality are seen. Can I answer? In this syndrome, there's a problem of dash and dash. Okay, there's a sixth and seventh nerve abnormality. Sixth and seventh, very good, very good. So, name the drug useful in gastritis, contraindicated in pregnancy means the person because of risk causing teratogenicity called Wilson syndrome. In this syndrome, problem in sixth and seventh nerve. Okay. Next question. Come on. The drug most commonly associated with gastritis and having risk of gynecomastia, think of smittrin. Smittrin having anti-androgenic property, thereby causing risk of gynecomastia. So very important, very important. And it is the most powerful microsomal enzyme inhibitor. So microsomal enzyme inhibitor. So lot and lot of drug interactions also there. That is also important. Of course, anticholinergic M1 blocker useful for treatment of gastritis or pyrenzepine. One more drug called telencepine. Telencepine. Pyrenzepine, telencepine are anti-muscarinic useful for treatment of gastritis. Okay. So now you know drugs useful for gastritis. Important old questions. Now for H. pylori, one of the bacterial problem causing gastritis. For that, we have triple and quadruple therapy. Here, proton pump blockers must. They are the drug of choice. Along with that, we need antibiotic support. So, which are the antimicrobial useful for H. pylori gastritis? In triple drug therapy, one definitely proton pump blocker. Second will be clarithromycin, and third will be either amoxicillin or metronidazole. Metronidazole solution. In triple drug therapy, one definitely proton pump blocker. Second will be clarithromycin, and third will be either metronidazole or amoxicillin. And all are given for 14 days. 14 days therapy, 2 weeks therapy. In quadruple therapy, in the four drug, one is definitely proton pump blocker. Second can be bismuth. Third is metronidazole. And fourth is tetracycline. So question, in quadruple therapy, proton pump blocker plus bismuth plus metronidazole plus tetra. Solution. See, tetracycline is a group of antibiotic. In that we have a lot of drug. We have tetracycline, oxytetracycline, dimethylocycline, T-cycline, like that lot. But question, we have one drug called tetracycline. Group name is tetracycline. In that one drug name also tetracycline. So name the tetracycline useful for gastritis. Mean answer tetracycline. Drug name also tetracycline. Group name also tetracycline. So name the tetracycline useful for gastritis. Mean answer tetracycline. Okay. Next. Okay. Very, very special. Everything old MCQs. Just revise. Very useful old question. Please revise. 5-HT3 antagonist are very fantastic first line drug of choice for treatment of cancer chemotherapy drug-induced vomiting. We are having so-called Sertan, ondansetron, granisetron, Pelenoceton, like that, those drug name ending with ceton, they call 5-HT3 antagonists, and they are the first line drug of choice for treatment of vomiting due to cancer chemotherapy. Very important, very important. Okay, and here Pelenoceton is the highly highly selective 5-HT3 blocker, as well as having longer duration action, acting for more than 40 hours. So a longest acting 5-HT3 blocker is Pelenoceton. Okay. Now, for treatment of vomiting due to cancer chemotherapy, choice will be 5-HT3 blocker, no doubt. But today you should know we have another group of drug called neurokinin 1 antagonist, simply called NK1 blocker. Here we have apripatent. Those drug name ending with the patent like apripatent, or one more drug called apprehensions, need to, need to, sorry, need to patent, like that, something called patents. So question, we having apprepatent, fast apprepatent, like this. So all these are very, very, very longer acting, long acting. The long acting, no, they are useful for treatment of late phase, useful for treatment of late phase vomiting. Late phase means vomiting after 2 days. Today I'm using chemotherapy. 2 days, that is 48 hours later, vomiting occur. After giving chemo, 2 days later, vomiting occur. No, that's called late phase vomiting. For this case, the best group of antiemetics are NK1 blocker like fast aprepitant, Newtopatent, Rolapatent, Apripatents, all are very fantastic drug. Okay. And then when about antiemetic, you should know for motion sickness, best is we go for scope and patch. This we discuss in ANS class. It is given as a patch applied behind the pinna 5 hours before journey. Now I have small doubt. Can you fill my three questions? When I talk about sickness, come on, rapid fire round, cancer. For motion sickness, we know scopolamine. But can you answer rapidly? For sea sickness, what is choice? For sea sickness, we go for meclizine. Meclizine, a first generation antihistamine. Antihistamine. Okay. And can you please answer? For mountain sickness, what the best? For mountain sickness, best is go for acetazolamide. Okay. And finally, one simple, easy question, please answer. What is the safest drug for treatment of morning sickness? For morning sickness, safest will be go for doxylamine. Doxylamine, a first generation antihistamine given with vitamin B6, pyridoxine. So question, doxylamine plus B6 is the best drug for managing morning sickness. Okay. Now, small revision about laxatives. Look here. Name the laxative useful for managing hepatic encephalopathy. It is lactulose. Look up. Lactulose, a laxative useful for managing hepatic encephalopathy. In this junction, can you please answer me? Priya Mishra. B6, it is also having anti-emetic property. So, for better efficacy, doxylamine, a antihistamine having anti-emetic property. For better efficacy, we add with B6. B6 also having anti-emetic property. That's all. Okay. Now, look here. Lactulose, a laxative useful for treatment of hepatic encephalopathy. In this junction, can you please answer? Name some antibiotic. Name some antibiotic acting as a gut sterilizer, sterilizer useful in hepatic encephalopathy. Anybody? Name some antibiotic. Mean, think of one is your neomycin. Neomycin. One more drug called rifaximin. Rifaximin. So, antibiotic used as a gut sterilizer, useful to control ammonia production, or one is neomycin, one more drug called rifaximin. Both of them are decreasing intestinal ammonia production, that be useful for hepatic encephalopathy. Okay. And one more old question. Melanosis coli. Melanin pigmentation, pigmentation of colon is caused by senna. Senna is the herbal medicine useful for treatment of constipation. It causes adverse effect of melanosis coli. In this junction, can you please answer? Anybody? Which is the drug useful in gastritis? Useful in gastritis, causing adverse effect of black color tongue, black color tongue, and black color stool. It is bismuth. Bismuth causing black colored tongue and black colored stool. Okay. So question, a drug useful in gastritis causing adverse effect of black colored tongue or stools, bismuth. Very good, very good, very good. Bismuth. Okay. Now look at the next point. Diarrhea. For treating diarrhea, what are the options are there? Look here. Very important. Antimicrobial useful for treatment of travelers diarrhea is azithromycin. Now, I want to check your level of preparation from medicine, microbiology, and pharmacology. First question to all people, extra point, please answer. Travelers diarrhea caused by enterotoxigenic E. coli. E. coli. Okay. Sometimes some other organism also causing. Now you should tell. Usually for treating travel diarrhea, I go for azithromycin. But you should tell what are the other antimicrobial that can be useful for travelers diarrhea. Either we can use ciprofloxacin, we can use, or we can also go for rifaximin. Rifaximin also can be tried. If it's a protozoal, if it's a IB dysentery, we can also try metronidazole. But for MCQ, single best answer means today, the best drug for treatment of travel diarrhea is azithromycin, having broad spectrum coverage, useful for ETC, E. coli, and other organisms also. So, question, a broader spectrum antibiotic useful for travelers there is azithromycin. And one more thing, remember, for this diarrhea, we can also try supplement loperamide. Now, one question. Loperamide, a opioid, it's useful for non-specific diarrhea. For example, for non-infective diarrhea. Sometimes adjointly for traveler diarrhea. Now, I have a small doubt. My doubt is, look here, super good. Listen. We have two important drugs. One is called loperamide. One more drug called difenoxylate. Both the drugs are opioids. Opioids useful for treatment of diarrhea. Now all must answer. Loperamide, difenoxylate, both are opioid. Both are useful for diarrhea. In this, which one has the risk of causing addiction? Which one causing risk of drug addiction? Anybody? Here, difenoxylate able to cross blood-brain barrier. It is the one having risk of causing addiction. So question, difenoxylate able to cross blood-brain barrier. It has the risk of causing addiction. That's why to control the addiction, we adding with atropine. Important. So remember, atropine added with the difenoxylate for what purpose? To prevent addiction, because it will able to cross blood-brain barrier, risk of addiction. This can be minimized by adding with atropine. Whereas look here, loperamide is substrate. It is substrate for P-glycoprotein. Through the PGP, the drug get rapidly effluxed out of brain. So it not getting stored in the brain. So no risk. Has no risk of addiction. No risk of addiction. So question, it is a substrate for P-glycoprotein rapidly effluxed out of the brain. So no risk of addiction. That's about important points. Okay. Next question. Look here. Yeah. Loperamide, we know opioid, but the advantage it is not going to cause addiction, but it may cause adverse effect of QT prolongation, may cause risk of cardiotoxicity in the form of QT prolongation. So opioid causing QT prolongation. And then very important, cholestyramine. It's a bile acid sequestrant. It's a bile acid sequestrant. It can be useful for treatment of diarrhea. No, no. Tanya, PDF was already prepared for students. It is I am creating to explain. For me also, look at me, Tanya. For me also, the IT people gave this type of PDF only. This PDF only. Okay. So to explain this, I have doing extra work. I am going to Google and converting this into Word file and making a space for explaining. So what I can do for better performance, for better teaching, I can struggle, but already given PDF. Okay. So if you study PDF, it's more than sufficient. It is just for explanation. I am creating space. Okay. So look here. Cholesterol, a bile acid sequestrant useful for treatment of diarrhea due to bile acid malabsorption. Now, one special question you must know. The question is look here. The drug useful for secretory diarrhea in caution diarrhea is octreotide. Now, just take 1 minute time. Not 1 minute, but 30-second time. Very important. Look here. Carcinoid diarrhea. Look here. In carcinoid tumor, there is overproduction of serotonin. Serotonin. This serotonin acting on 5:4 receptor and causing diarrhea. Diarrhea. So now question starts. Usually, for treating a secretory diarrhea, the drug of choice is octreotide. No doubt, no doubt. But one point today you should know, very important. In carcinoid tumor, there is a synthesis of serotonin. The serotonin synthesis done by serotonin synthesized from tryptophan. Tryptophan. Now my question starts. Serotonin synthesized from tryptophan by the help of tryptophan. Tryptophan hydroxylase. Hydroxylase. Now I want to check your level of attention, level of preparation. Can you please answer? In carcinoid diarrhea, to control the synthesis of serotonin, I can go for tryptophan hydroxylase inhibitor. Anybody? Name the drug called tryptophan hydroxylase blocker. I have one drug called TELO. Telotristat. It is the tryptophan hydroxylase. Tryptophan hydroxylase inhibitor. This I will discuss when I come into serotonin. When I come into serotonin, I will discuss this. Anyway, keep this mind. Telotristat is the tryptophan hydroxylase inhibitor useful for treatment of carcinoid, but drug of choice is octreotide. Okay. Now we want to another special topic we call inflammatory bowel disease. That means we having Crohn's disease, one more thing, ulcerative colitis. They call IBD, inflammatory bowel disease. What are the important points to be revised? For treating IBD, we can go for sulfonamides. Some sulfur drug can be useful. For example, we have one thing called mesalamine. Mesalamine. It's a simply 5 amino salicylic acid, 5-ACE. aminosalicylic acid. But one doubt I have. For treating IBD, I have one thing called sulfasalazine. Sulfasalazine. Now question starts. The sulfasalazine is a combination of sulfa pyridine plus 5-aminosalicylic acid. Now, please watch. Sulfasalazine is the is the combination of sulfapyridine plus 5-aminosalicylic acid. Here, the 5-ASA useful for treatment of IBD, whereas sulfapyridine, it is useful for treatment of rheumatoid arthritis. Important. Sulfapyridine useful for rheumatoid. Again, one point keep in mind. The sulfasalazine may cause adverse effect of oligospermia. It may cause risk of oligospermia. So risk of male infertility. That you should keep in mind. It may cause male infertility. Okay. Now, coming to other points. For treating IBD, I can go for steroids. For inflammatory bowel disease, I go for anti-inflammatory agent. The most important is steroid. In this, a drug acting just in the intestine. Just in the intestine. That is useful. Topically mean only locally in the intestine. Having less systemic problem is budesonide, which is the safest steroid for treatment of IBD. Budesonide, acting locally in the intestine, having less risk of systemic side effect. A wonderful steroid for treatment of IBD. Okay, and IBD, one of the autoimmune. It is an autoimmune disorder. Whenever you talk about autoimmune disorder, for treating this, we can go for immunosuppression. So next is, what are the important immunosuppressants useful for IBD? We have one thing called azathioprine. It's a purine anti metabolites useful for IBD. And then very special, you must know. Here's something called integrin antagonist. Just take 30-second time, doctor. Super question. Here's something called integrin antagonist. There are two type of drug. One is called vedolizumab. One more drug called natalizumab. Both are integrin antagonists. Now question starts. Here, natalizumab is alpha 4 beta 1. Vedolizumab alpha 4 beta 7 blocker. So question, vedolizumab alpha 4 beta 7 blocker. Natalizumab alpha 4 beta 1 blocker. Very important. Now I want to check your level of preparation. Can you please answer? Natalizumab alpha 4 beta 1 integrin antagonist, but causes adverse effect of one dangerous ADR causing PML, progressive multifocal leukoencephalopathy. So question, one of the dangerous problem causing PML, progressive multifocal leukoencephalopathy. And in this case, risk of, anybody? Risk of dash infection. Anybody? In PML, risk of what? JC virus infection. Jan Cunningham virus infection. So it may cause PML, where risk of JC virus infection. Very good, Geeti Money. Very fantastic. Mawani, very good. JC virus. Look. And then for treating IBD, we have something called interleukin modifier like ustekinumab, interleukin antibody, a antibody targeting against IL-12 and 23. Interleukin 12 and 23 blocker name is ustekinumab, useful for managing inflammatory bowel disorder. So we discussed so many new drugs useful for IBD. Another very important topic, irritable bowel syndrome. It is also very important topic. When we talk about IBS, we have something called DIBS and we also having CIBS. That is diarrheal dominant IBS. One more thing, constipation dominant IBS. So we go one by one. Okay. First, special point. Look here. For treatment of constipation type of IBS, we can go for something called prokinetic agent. Prokinetic. For example, there are some 5-HT4 agonists. 5-HT4 are seen on intestine. Stimulation of this causing prokinetic. For example, old drug like cisapride, mosapride, but these drugs are causing adverse effect of QT prolongation. QT prolongation. That's why we have some new drug called pruglapride, etopride. All these are 5-HT4 agonists. Okay. Prokinetic action. And then, okay. Now, the other drugs are we having something called linaclotide and pleconatide. Very special following. Linaclotide and pleconatide. Both are CFTR activator. That is cystic fibrosis transmembrane regulator activator. They're going to cause guanylyl cyclase stimulation and they increases chloride rich secretion, thereby promoting motility, useful for treatment of constipation type of IBS. Very important. Linaclotide and pliconatides are CFTR activator. They're going to improve guanylyl cyclase activity. They are going to increase chloride rich secretion, useful for treatment of constipation type of IBS. Okay. And then this is another very important expected question. We have a new drug called lubiprostone. Prostone, that means it is binding with prostaglandin E2 receptor in the intestine. The mechanism action, it's a chloride channel activator. It is the mechanism of action. So question, lubiprostone is a chloride channel activator. It's a direct chloride activator, increasing chloride secretion, increasing bowel motility, useful for treatment of constipation type of IBS. So please remember, doctor, linaclotide, pliconatide, CFT activator, and lubiprostone, direct chloride channel activator. Both are very important. Expect the question. Okay, and then one new drug. Very expected latest point. We have one new drug called tenapanor. Tenapanor. It is the sodium hydrogen exchanger inhibitor. Sodium hydrogen exchanger inhibitor. It reduces sodium absorption, increasing intestine water content, increasing bowel motility, useful for treatment of constipation type of IBS. So one new point, tenapanor. It's a sodium hydrogen exchanger inhibitor, tenapanor. Okay. So far we discussed so many newer drugs useful for treatment of constipation dominant IBS. Now a small word about diarrhea. Very special. We have one drug called alloceton. Alloceton. It's a 5-HT3 antagonist useful for treatment of diarrheal domin IBS. Please watch. Alloceton, a 5-HT3 antagonist useful for treatment of diarrheal type of IBS, but causing adverse effect of ischemic colitis. This point is very important. Danger. A drug causing serious emergency ischemic colitis. That's why one point. If you're practicing in United States, America, if you prescribe this drug, you should inform everything about this drug to patient. And you should get consent. You should get informed consent. Informed consent. After getting consent only, you can allow to prescribe this drug because causing serious problem called ischemic colitis. And one more point, it is got approval only for women with IBS, not for male. Useful only for female with diarrheal type of IBS because only females are responding for this drug. Males are not responding for this drug. So question, Alloceton, a 5-HT3 antagonist approved for female with the diarrheal type of IBS, but risk is causing ischemic colitis. Okay. Next, we have Ilixodolin. It is one of the opioid useful for treatment of DIBS. Ilixodolin. It's a opioid. We have one more new drug called acimedolin. So question, Ilixodolin and acimedolin are opioid useful for treatment of DIBS. This we discuss in CNS class tomorrow. Okay. Next. Yeah. What are the miscellaneous MCQ in GI system? In power failure doctor, power failure kind of okay. Some new for some miscellaneous point. Okay. Also deoxycholic acid useful for dissolving cholesterol containing gallstone. So question, name the drug useful for managing gallstone. It is also deoxycholic acid useful for managing gallstones. In this junction, remember one point. We have a new drug called, it's not there in our book. I'm going slow. Please write this. Seladelpar. It's a latest drug, newer drug called as PPAR delta agonist got approval for treatment of primary biliary cholangitis. So question, Seladelpar is a PPAR delta agonist useful for treatment of primary biliary cholangitis. New point. Okay. And next point, very simple. We have a drug called crofelemer. Notes. It is a CFTR inhibitor useful for treatment of HIV drug-induced diarrhea. So question, crofelemer, a CFTR inhibitor useful for treatment of HIV drug-induced diarrhea. This I told already. Lubrosur is a drug going to bind the PGE2 receptor. It's a direct chloride channel activator useful for treatment of constipation type IBS. We discussed already. It's a repetition. So sorry. Okay, so far we didn't so anything. And one more point should know. Very special today. Very special. We have one drug called glutide. What is this? It is the GLP-2 analog. It's a GLP-2 analog useful for managing short bowel syndrome. See, when you do some surgery in the intestine, when you cut the intestine and put anastomosis, bowel length become decreased. It may cause malabsorption. In this case, to promote absorption of nutrient and fluid, we can try teduglutide, useful to improve fluid and nutrient absorption. but causing adverse effect of a bowel cancer, risk of bowel cancer problem. This important idiom. Okay, up mean this one. Please watch. Sudhakar. We having ursodeoxycholic acid, one new drug called Siladelper. Siladelper, a PPA delta agonist useful for primary biliary cholangitis. Of course, crofelemer useful for treatment of HIV drug-induced diarrhea. Luiprostone discussed already. And last is very important. Teduglutide, a GLP-2 analog useful for managing short bowel syndrome, but risk of bowel cancer. That finishes some important MCQs I revised from gastrointestinal system. Okay, but one special point I want to ask you. Look here, when you talk about GAT, we have something called prokinetic. Can you answer prokinetic? When I say prokinetic, okay, this portion missing in your book, just revise prokinetic. For example, we have something called D2 blocker. One is called dombedoid. Dombedoid. One more is called metoclopramide. Bromide. Both are D2 blocking anti-emetic. Okay. In this, I discussed already the metaclopramide able to cross blood-brain barrier. Plus, Dumbledore does not cross blood-brain barrier. That you know already. And then, when talking about prokinetic, we have something called 5-HT4 agonist. 5-HT4 agonist. That was discussed already. Something called cisapride. Cisapride. Mosapride, and then Pegasyrod, all these things. Okay, but I have one interesting question. Anybody want to answer? Name the motilin receptor stimulant acting as a prokinetic agent. Especially, name the antibiotic acting as a motilin receptor stimulant useful as a prokinetic. For example, macrolide, macrolide antibiotic, especially erythromycin, a powerful prokinetic agent. So, powerful prokinetic promoting motility that be useful for treatment of diabetic patient with gastroparesis, useful in diabetic gastroparesis. So question, macrolides are prokinetic motilin receptor activator useful in managing diabetic gastroparesis. That finishes something about prokinetic agents. Okay. Of course, not M2. We have something called M3. M3 agonist. M3 agonist like bethanacol. Bethanacol. A cholinergic drug. It's also prokinetic agent. Okay. So, all this is prokinetic. Okay. I think all the most important points covered from gastroenterology. Now we move on to next topic called respiratory system. Respiratory. It's a very simple topic. Please follow me. One is the respiration, two important. One is bronchial asthma, one more thing cough. So first I will revise important points drug useful in asthma. Okay. For example, look here. For managing asthma, the first group of drugs are called bronchodilator. When I say bronchodilator, we have three classes of drug. One group will be beta-2 agonist, beta-2 agonist. Second group is M3 antagonist, M3 antagonist. And third group is phosphodiesterase enzyme inhibitor, the so-called methylxanthine, like theophylline. Now we go one by one. My first topic is beta 2 agonist. Today morning in ANS class we covered some beta 2 agonists. Please watch. We have short acting beta 2 agonists like salbutamol, one more drug, terbutaline. The salbutamol and terbutaline all are called as beta, short acting beta agonists, and they useful for relief, especially useful for acute attack asthma, for rapid relief of symptom of breathlessness. Okay. And then LABA, longer acting beta agonist having formoterol and salmeterol. Since long acting, they are often useful for maintenance, useful as a maintenance therapy in case of chronic asthma. But the point you should revise, when using this maintenance therapy chronically, risk of development of risk of tolerance. To avoid this problem, we giving with this steroid. Remember, LABA always given with LABA always given with inhalational corticosteroid, because steroid increases sensitivity of beta receptor, preventing tolerance, preventing down regulation of beta 2 receptor. And once again important, formoterol having faster in onset of action. So it can also useful for acute asthma. So name the LABA which is also useful for acute asthma. I mean, think of formoterol. Okay. Of course, we have something called VLABA, very longer acting beta 2 agonist. Drug name important. Old question. All of the following are VLABA except, like the question came. So you should know example for VLABA. One is indacaterol, then olodaterol, then vilanterol, then abitadinol. All are VLABA mainly useful for treatment of COPD. All are VLABA useful mainly for COPD. Okay. Now, when you talk about beta 2 agonist, my first question before going to this point, first question goes to all people. Anybody? Beta 2 receptor is of what type of receptor? Remember, we have beta 1, beta 2, beta 3. All are GPCR. That to GS. Re-stimulatory. That means when a beta 2 agonist acting on beta 2 receptor, they activating GS pathway, thereby accumulating cyclic AMP. It causing smooth muscle relaxation, thereby causing bronchodilation. So GS pathway accumulating cyclic AMP causes muscle relaxation. Okay. Now coming to this point, the most common adverse effect of beta agonist, tremor. Next comes palpitation. Next comes hypokalemia. Next comes hyperglycemia. So anyway, the most common is tremor. Okay. Next, coming to muscarinic antagonist as a bronchodilator. We have ipratropium and tiotropium. Both are muscarinic antagonists useful for COPD. Here, ipratropium is a short-acting muscarinic antagonist. Tiotropium, longer-acting muscarinic antagonist. So, the two most famous muscarinic antagonists used as a bronchodilators are, one is called ipratropium, one more drug called tiotropium. Okay. And the most common adverse effect of muscarinic antagonist are dryness of mouth, either Sama or Lama. Both of them causing mainly dryness, especially when used as an inhalation. When using this as an inhalation, definitely risk of dryness of mouth. Remember, the most common adverse effect of beta to agonist trimmer, whereas most common adverse effect of muscarinic blocker is dryness of mouth. Okay, and this point, okay. So the trimmer hyperglycemia not understandable. Okay, look it. See, beta to agonist causing adverse problem trimmer. Why? Why? Actually, in the hand, we have muscle spindle. In the muscle spindle, in the spindle, we have beta 2 receptor. So, beta 2 agonist acting on beta 2 in muscle spindle, causing contraction. They're causing tremor. Okay. And point number two, beta 2 actually, beta 2 causing glycogenolysis. That means causing hyperglycemia. Normally, stimulation of beta 2 causing glycogenolysis. That way causing hyperglycemia. So, come on, 2 point. Beta 2 agonist causing tremor because of activating beta 2 or muscle spindle. Point 2. Beta causing glycogenolysis, that way causing hyperglycemia. Now it is understandable. Okay. The order most commonly tremor, next only palpitation. Okay. Mainly tremor. Okay. Now come to next. Okay. When we talk about muscarinic antagonists, you should know they cause which is the muscarinic antagonist has the risk of paradoxical bronchospasm in hypertrophium. I told morning itself it is because of the preservative called benzalkonium chloride. So question, it has the preservative called benzalkonium. It may be causing reflux bronchospasm. Okay. And then methylxanthine, Weiden beta antagonist, Weiden muscarinic antagonist. Next is methylxanthine. The most commonly used methylxanthine in the treatment of asthma is theophylline. Theophylline. What is the mechanism action of theophylline? Please watch. Theophylline mechanism action. It's a non-selective phosphodiesterase enzyme blocker. It's a non-selective phosphodiesterase enzyme blocker, thereby accumulating cyclic AMP, thereby causing bronchodilation. One more point, it is also having adenosine. Come on. It is also causing adenosine receptor blocking property. Theophylline, in addition to inhibiting PDE, has adenosine receptor blocking property. Actually, in the bronchus, we have adenosine receptor, even adenosine receptor. When adenosine acting on here, it causing bronchospasm. So, my drug theophylline is a adenosine receptor inhibitor, thereby causing bronchodilation. So there are two ways. One way, theophylline, One way, it's a non-selective phosphodiesterase enzyme blocking, thereby increasing cyclic AMP level, causing bronchodilation. One more way, by blocking adenosine also causing bronchodilation. Okay. Now, MCQ number 2. Theophylline undergo metabolism by CYP1A2. Very important. Name the microsomal enzyme that involved in metabolism of theophylline CYP1A2. See, since undergo metabolism by this enzyme, It is susceptible for drug interaction. Drug interaction. When you give with the microsomal enzyme inducer or enzyme inhibitor, lot and lot of drug interactions are there. Okay. Okay. Next, Theophylline having narrow therapeutic index. So it needs therapeutic drug monitoring and the normal level should be 5 to 15 microgram per ml. So theophylline plasma level should be 5 to 15 microgram per ml. So because having narrow therapeutic index. Okay. Now, next important question regarding adverse effect. Just to note this one, theophylline causes two MCQ, causing seizure and diuresis. It is because of adenosine receptor blocking property. Important. Theophylline may cause seizure and diuresis because of blocking adenosine receptor. It is old MCQ. Remember, one of the adverse effects, it causes seizure, sometimes causing diuresis. It is because of blocking adenosine receptor. Okay. Now, we done methylxanthine beta antagonist MG blocker. Next, we have something called selective PDE4 blocker as a bronchodilator. Drug name Silomilast and Roflumilast. Remember, Silomilast and Roflumilast are selective PDE4 blocker useful for managing COPD. COPD. Okay. Next, we have MgSO4. It is also having bronchodilatory property useful for acute attack of asthma. Remember, MgSO4 lot of points. It has anti-epileptic property. Drug of choice is a drug of choice for eclampsia. Eclampsia. It having anti-arrhythmic property. Anti-arrhythmic drug of choice for treatment of Dorset D pointus, and it is also having bronchodilatory property useful for treatment of acute asthma. Yes, laxative property useful for treatment of constipation. Like that, lot of uses are there with the MgSO4. Okay, but one doubt I have. Anybody? What is the antidote for MgSO4? Any idea? What is the antidote for managing MgSO4 toxicity? It is calcium gluconate. Calcium gluconate is an antidote for MgSO4. Yes, very good. It is also having tocolytic property. Good, good, good. Yeah, good. It's calcium gluconate antidote. Okay. Now, we done something about bronchodilator in asthma. Now we go for anti-inflammatory points. Look here. In asthma patient, to control the airway inflammation, we go for anti-inflammatory, especially steroid. Steroids are the most powerful anti-inflammatory. We use steroid mainly as a inhalation. There are a lot of drugs are there. Here we have budesonide, fluticasone, mometasone, cyclizonide, like that. Lot of inhalational corticosteroids. Now look here. Budesonide, one of the ICS, one of the inhaled corticosteroid. We have budesonide, cyclizonide, fluticasone, like the lot of drugs are there. Okay, all the steroid having anti-inflammatory action by what mechanism? The mechanism action steroid acting by inhibiting phospholipase A2. Very important, very important. Steroid having anti-inflammatory action because of inhibiting phospholipase A2. And this question very important. You should know, you should know. Among the steroid, we have what they call cyclisonide. Actually, it's a prodrug. It's a prodrug. The drug activated and inactivated in the airway itself. It is activated and inactivated in the airway itself. It never goes to systemic circulation. So it never causes systemic side effect. No systemic side effect. Since it's a harmless, it is called soft steroid. Very important, very important. It is harmless, harmless, no serious adverse effect. Since harmless, it called as soft steroid. Cyclisonide, a inhalation steroid, it's a prodrug. It has no systemic problem at all. It is known as soft steroid. Okay. Then, when we give steroid inhalationally, the advantage, ICS advantage of giving steroid inhalationally, less systemic side effect. But when I give inhalation locally it causes candidiasis. Sometimes voice change occur and mainly oral thrush candidiasis. Now you should know the local adverse effect. We know candidiasis, no candidiasis. Now question, for treating this candidiasis topically I can go for some antifungal. What? Usually, to prevent the infection, proper oral hygiene should be maintained. If fatal fungal infection occurs, for treating this topical antifungal regimen, go for topical chlorotrimazole or go for nystatin. So, question, for treatment of candidiasis, either go for topical nystatin or topical chlorotrimazole. Okay, and this we did already. LABA tolerance can be overcome by adding with the steroid. LABA developing tolerance, this can be overcome by adding with the steroid because steroid increases sensitivity of beta receptor. Okay. Next, after finishing this much, now we want a super important group of drug in asthma called as leukotriene modifiers. Very special. You must know topic. Leukotriene modifiers. For example, look here. Arachidonic acid undergo phospholipase A2 mediated action and going to form sorry, wait, membrane phospholipid by help of phospholipase A2 from arachidonic acid. This arachidonic acid undergo COX pathway and LOX pathway. By LOX pathway, they're going to form leukotriene. So, LOX enzyme are involved in synthesis of leukotriene. Now, one question. Look here. We have one drug called montelukast. It's a leukotriene receptor antagonist. Leukotriene receptor antagonist useful as an ardent therapy for asthma. Montelukast, so leukotriene receptor antagonist. When I say receptor blocker, the receptor name is cysteine leukotriene receptor. So question, leukotriene receptor, cysteine leukotriene receptor. Now doubt starts. Look here. Leukotriene synthesis done by LOX enzyme. So the synthesis of leukotriene blocked by one drug called xylitol. It is the 5-lipoxygenase enzyme inhibitor, LOX enzyme blocker. So xylitol is the LOX enzyme inhibitor. It's going to inhibit synthesis. Yeah, just 2 minutes. Sorry, just 2 minutes. I'll give small break. Wait. So question: xylitol is the lipooxygenase enzyme inhibitor inhibiting synthesis of leukotriene. But this drug we don't use in practice because it causes adverse effect of severe hepatotoxicity. So remember, Montelukast point, nothing but Montelukast, one of the leukotriene receptor antagonist. Look here. When you see leukotriene modifier, I have two drugs. One is called leukotriene synthesis inhibitor. One more thing called leukotriene receptor blocker. Here point is Montelukast is a leukotriene receptor antagonist, whereas Xylitol is a leukotriene synthesis blocker. Xylitol we don't use in practice because causing adverse effect of severe hepatotoxicity. Okay. Now question to Arpita Roy. Can you please remember? Montelukast, one of the leukotriene receptor antagonists useful for asthma as a prophylactic therapy. But when using this prophylactically on chronic therapy, it causes adverse effect of Chakra syndrome. Remember, Chakra syndrome is an adverse effect of Montelukast. Now, question from medicine paper. Look here. When I say syndrome means complex of symptom. In this syndrome, anybody, what are the symptoms? Here they go vasculitis, headache, and eosinophilia. Eosinophilia. So question here they get vasculitis, headache, and eosinophilia. So Montelukast causing adverse effect of Chakra syndrome. Okay. Next question. Look here. For treating, please note, for treating this syndrome, we can try steroid or we can try one thing called mepolizumab. Mepolizumab. It's a interleukin 5 blocker can be useful for treatment of Chakra syndrome. Remember, Chakra syndrome, one of the adverse effect of Montelukast. Here the symptoms are headache, eosinophilia, and vasculitis. For treating this syndrome, we can try steroid or we can try one thing called mepolizumab. It's an interleukin 5 antagonist. Okay. Then one more important point today you should know. See, I am telling Montelukast causing adverse effect of Chakra syndrome, but you should know Montelukast also causing adverse effect of neuropsychiatry problem, mainly causing depression problem. So, it given black box warning. FDA given notice. They given warning. This drug causing depression. Be careful like that. So, it causes neuropsychiatric problem in the form of severe depression. Okay. Next, look here. For managing asthma, we have some biological agents. That is, we have some monoclonal antibodies. This is again expected tough level MCQ. Very important, very important. So we go for still tough level. What are all the antibodies useful for asthma? One common drug, easy drug, we know omalizumab. When you talk about antibody, targets are very important target. For example, omalizumab targeting against IgE. It's an IgE antagonist. IgE antagonist called omalizumab. One point easy, but you should know. We have something called interleukin 5 blocker, IL-5 blocker. What is this meaning? For example, look at me. I just explained. Listen. Interleukin 5 is one of the cytokine. It going to attaches on the eosinophil. Imagine it's a eosinophil. Here is the interleukin 5 receptor is there. So when interleukin binding with the IL-5 receptor, it will cause activation eosinophil that causing allergy and asthma. So for controlling the allergy, for controlling asthma, I have two options. What? One group of drug called IL-5 blocker. These drugs are binding with interleukin 5, not allowing the interleukin to bind with the IL-5 receptor. Other drugs, I have something called IL-5 receptor blocker. So today I have two classes of drug. One group is called interleukin 5 antagonist. For example, mepolizumab, restylizumab, these two drugs are binding with IL-5, thereby not allowing the IL-5 to bind on eosinophil. It's called anti-IL-5 blocker. Okay. Then we have one thing called benralizumab. It is interleukin 5 receptor blocker. Here, blocking the binding of IL-5 with the receptor. So, mepolizumab, restylizumab, interleukin-5 blocker, benralizumab IL-5 receptor antagonist. This difference you should know. Okay. And finally, we have two more new drugs called one is called dupilumab. It's IL-4 plus IL-13 blocker. Solution dupilumab is IL-4 plus IL-13 blocker useful for asthma, and it is also got approval for treatment of atopic dermatitis. So dupilumab IL-4 plus IL-13 blocker useful for asthma as well as useful for treatment of atopic dermatitis. And today you should know one more latest drug called thymic stromal lymphopoietin blocker called TCP-lumab. TCP-lumab. It's another latest drug called thymic stromal lymphopoietin blocker. It's the latest drug got approval for treatment of severe asthma. Okay, so we done there are so many antibodies. And last, finally, just one more thing. Tralokinumab and lebrikizumab are IL-13 blocker useful for asthma. Interleukin 13 blocker. Tralokinumab and lebrikizumab are interleukin 13 blocker. So we done biological agents useful for asthma. And just 2 minutes and then small break. That is okay. When we talk about asthma chapter, you should know one thing called mast cell stabilizers. There are some drugs stabilizing mast cell, preventing mast cell degranulation, preventing allergy. Example for mast cell stabilizers are we having sodium chromoglycate, nidoquramil, and ketotifen. Solution examples for mast cell stabilizers are sodium chromoglycate, nidoquramil, and ketotifen. Okay, in this just one point, remember TSLP involved in aggravation of allergy, aggravating eosinophil and non-eosinophil mediated allergy response. They're going to aggravate asthma. So TSLP blocker controlling eosinophilic and non-eosinophilic asthma problem. Okay. Next. Look here. The ketotifen extra point has additionally antihistamine property also. It has additionally antihistamine action also. So question, a mast cell stabilizer having additionally antihistamine action is ketotifen. Okay. And then this I do already MgSO4, a miscellaneous drugs having muscle relaxing property useful for acute asthma. It is going to cause muscle relaxation useful for acute attack of asthma. Okay, that finishes something about drug therapy useful for asthma. I covered all the drug man, bronchodilator, steroid, muscle stabilizer, glucosamine antagonist, and MEBs. All the drugs for asthma I covered. Okay, now the last one question, drug therapy useful for cough. There are so many drug therapy for cough. Listen, this also old MCQ. Listen, for dry cough, that is for non-protective dry cough. Here I just want to control cough. We go for antitussive. They call cough suppressant. Cough suppressants. For example, codeine. Codeine, dextromethorphan, and folcodeine. All these are opiates. The opiates are called cough suppressant, useful for managing dry cough. Here, dextromethorphan has additionally NMDA blocking property. Yes, NMDA blocking property. Okay. And sometimes we can try benzononates. The benzononates acting on periphery, it just anesthetizing the stretch reflexes, controlling cough. All this opiate causing sedative property, but it has no sedation. This advantage. It's a peripheral acting on stretch receptor, bringing benzononate. It has local anesthetic property, controlling cough stretch reflexes. Okay. Then protective cough. For example, a thick spotting, pernicious spotting. For this case, I go for expectorant like guanfacine or mucolytic. Very important, very important. For a thick sputum cases, I want mucolytics. For example, carbocysteine, methylcysteine, N-acetylcysteine, ambroxol, erdostein, bromhexin, darnase alpha all are mucolytic agents. Here, 2 point you should know, please note. N-acetylcysteine, a mucolytic, also drug of choice for treating paracetamol poisoning. That's important. And bromhexin, a mucolytic, it's a metabolite of ambroxol. It's a metabolite of ambroxol. Okay. And what are the other drugs useful for cough? For example, in case of allergic cough, we can try antihistamine like diphenhydramine or chlorpheniramine like this antihistamine, or we can try leukotriene modifiers like montelukast for allergic cases. And for post-nasal drip, we can go for nasal decongestion like ephedrine, sulfephedrine, oxymetazoline, and sometimes locally nasal steroid like fluticasone, budesonide, inhalational steroids, nasal spray. Nasal spray forms are there for treatment of uh, post-nasal drip cases. And GRD. GRD may cause cough. For that, we can go for proton pump blocker like omeprazole, pantoprazole, and then chronic cough. Reason not known. For chronic cough, we can try steroids or we can say gabapentin pregabalin. Look here, actually, gabapentin prevents CNS drug. A very good choice for diabetic neuropathy, but they also nowadays tried for chronic cough. This question mechanism not clear. Gabapentin pregabalin is a very good choice for neuropathy pain, but they also tried for cough. Okay, come on. For allergic cough, we can go for antihistamine. Come on, Sakshi. For allergic cough, we go for antihistamine, or we can go for Montelukast. Montelukast. Or for uh, post-nasal drip, we can go for decongestant. And for GRD cough, we can go for proton pump blocker. And for chronic cough, we can go for steroid or neuromodulator like gabardine or pregabalin. Okay, but you should know this point. The mucolytic agents, this is very important, and cough suppressants are very important. So that's about cough therapy. Anyway, in respiratory system, we discussed drugs useful for treatment of asthma and drugs useful for managing various type of cough. Okay. So once again, I'm showing mucolytic, very important, very important. Here, N-acetylcysteine, a very good cough suppress, mucolytic, also useful for treatment of paracetamol poisoning, and bromhexin is a metabolite of uh, Ambraxel. All these are important. Okay. Now time is almost to 6:10. A small break for 10 minutes, small break. And then to the final topic, we go for autocoids. If we finish autocoid, so the target is going to be achieved. So take a small break for 10 minutes and then I continue something. Okay. Okay. Thank you. Thank you. Now we just go for a small break. After finishing GAT and RS. Today in the climax scene, we are going to discuss today the last chapter will be discussion about autocoids. Okay. So tomorrow plan will be discussion remaining things like CNS, endo, antimicrobial, anti-cancer, immunology, miscellaneous. Okay. So today massive portions are covered. So all for the pharmacology going to go. Okay. So to start autocoid. Look. In autocoid, first we go for histamine and antihistamine revision question. Okay, look here. First question, histamine synthesized from histidine by the help of histidine decarboxylase. So the enzyme involved in synthesis of histamine is histidine decarboxylase. And histamine acting on histamine receptors. When I say histamine receptors, we have H1, H2, H3 like this. When I say antihistamine, I mean mainly H1 blocker. See the H2 receptor involved in acid secretion. So the H2 blockers are called as drugs useful for treatment of gastritis. Whereas the when I say histamine receptor, for example, bronchospasm or allergy, all are due to H1 receptor. So when I say antihistamine, I mean mainly H1 blocker. Now, just for revision purpose, can you please answer? Today morning, somewhere we discussed. Name one inverse. Name one inverse agonist of H3 receptor. Name the inverse agonist of H3 receptor. We have one drug called pitolisant. Pitolisant, also called as Pipralisant. Pipralisant. It is the inverse agonist useful for treatment of narcolepsy. Useful for treatment of narcolepsy. Discuss morning. Yeah, good, good. Pipralisant, also called pitolisant. Good, very fantastic. Look, now, okay. We discuss in respiratory chapter something called mast cell stabilizer. Okay, we are having sodium chromoglycate, nidocaramyl, ketotifen, all called mast cell stabilizer. Here, ketotifen extra point has additionally antihistamine property. So question will be name the master cell stabilizer having additionally anti-histamine property mean think of ketotifen. That is also important. Okay, right. Next, This point you must know. Such important point. For example, we have one drug called cyproheptadine. It is actually a first generation antihistamine, also having uh, also having 5HT blocking property, also having anticholinergic property. So wonderful drug useful for treatment of serotonin syndrome. Cyproheptadine, a first generation antihistamine, also having anti-serotonin activity, also having anticholinergic. It is useful to improve appetite. Appetite also useful for treatment of serotonin syndrome. This is last year NEET PG question. Name the drug useful for symptom relief in serotonin syndrome. Answer is cyproheptadine. It is useful for serotonin syndrome. It is also useful as a appetite stimulant. Okay. And then first generation antihistamine. For example, promethazine, very good drug for motion sickness. We discussed already. For motion sickness, best drug of choice scopolamine. Scopolamine, a anticholinergic. The second choice can be promethazine. Okay. Next, we have loratadine. It is one of the second generation antihistamine. It has antihistamine property plus anti-inflammatory property. So name the antihistamine has additionally anti-inflammatory property. Loratadine useful for allergy as well as for chronic urticaria. Useful for chronic urticaria. And then doxylamine, a first generation antihistamine, it's wonderful anti-emetic, useful for treatment of vomiting in pregnancy, for treatment of morning sickness, and given with vitamin B6. It is also having anti-emetic property. So combination of doxylamine plus B6, wonderful combination for controlling morning sickness. Then, this I told. Cyproheptadine useful for managing cytokine syndrome, discussed already. And very special. What? We have one drug called hydroxyzine. It is actually a first generation antihistamine. This drug has additionally anti-anxiety property. So question, name the antihistamine has additionally anti-anxiety property mean hydroxyzine. In this junction, I want to check how far you are preparing. Come on, how good in your preparation. For example, hydroxyzine, I'm telling first generation drug. This drug produces one metabolite. Thus, metabolites available as a second generation drug. Name the metabolite of hydroxin. That is cetirizine. Cetirizine is the metabolite of hydroxin. Yeah, very good, ma. Very good. Anila, very good. And it is comes under second generation antihistamine. But it's a metabolite of hydroxin. Okay. And this question, last year NEET PG question, you should know. There are some antihistamine has the risk of causing QT prolongation. For example, terfenadine, astimazole, one more drug, Ebastin. These three drugs are causing QT prolongation. So, which are the antihistamine has the risk of causing QT prolongation? One is terfenadine, then astimazole, one more drug, Ebastin. And among this, terfenadine and Naxolol, these two drugs were withdrawn from market because of causing QT prolongation. Hebastin still available, still available. So question, see, Aishwarya, it's not the rule, ma. Generally, antihistamines are causing sedation. That's all. First generation causing high sedation, second generation less sedation, sometimes no sedation. Okay. Since segregation should not like this. In general, antihistamine will cause sedation because histamine is the CNS stimulant. When they block the histamine, it going to cause sedation only. First is causing high amount of sedation. Second is having less amount of sedation. That's all the concept. Okay. Now look here. Terfenadine, Astimazole, Vidaravan because of causing QT prolongation. Avastin still available. Again, one question. Look here. Fexofenadine is the metabolite of terfenadine, but it is not causing QT prolongation. Fexofenadine is one of the second generation antihistamine. It is available. It's a metabolite of terfenadine. It is safe. It is not causing cardiotoxicity. That's about important question. Okay. After finishing this much, now we go for uh, two interesting questions. Look here. This is what I already asked you. Pitolisant, a inverse agonist of H3, useful for treating narcolepsy. The other name is Tipralisant. Tipralisant. That's all. Okay. And then H2 blocker mean drugs useful for treatment of gastritis. Gastritis. For example, ranitidine. We having ranitidine, cimetidine, and famotidine. Famotidine fastest in onset of action. Cimetidine causing adverse effect of gynecomastia. All these things done already. Then name one antihistamine having platelet activating factor antagonism property. It is rupatrin. Rupatrin having platelet activating factor antagonism property. Okay. Another special you should know. Look here. There are some antihistamine useful for special use. For example, cinnarizine, a very fantastic drug useful for vertigo. Meclizine useful for vertigo as well as useful for seasickness. Seasickness. Then meclizine useful for seasickness. Even dimenhydrin also useful for seasickness. Then acylastine olopatine useful as eye drops. Eye drops. Topical antihistamine useful for eye drop for eye allergy, itching in eye. And then the acylastine olopatine also available as the nasal spray, eye drop form as well as spray form. Spray form. Solution acylastine and olopatadine available as eye drop as well as nasal spray form. Extra one point you should know. The point is look here. Olopatadine. Look, the olopatadine has additionally anti I mean, additionally having mast cell stabilizing property. Stabilizing property. So question, name the antihistamine having additionally mast cell stabilizing property mean olopatadine. Okay, that finishes something about antihistamine related MCQ. The next autocoid I move on to serotonin. Serotonin and serotonin related drug 5-HT modulators. Very special, very useful. Listen carefully. Point 1. Serotonin synthesized from tryptophan and the enzyme involved in synthesis of serotonin is tryptophan hydroxylase. So, tryptophan is the source. It is the source. From the tryptophan, by the help of tryptophan hydroxylase, there will be synthesis of serotonin. So, the rate limiting enzyme in the synthesis of serotonin is tryptophan hydroxylase. Now, in case of carcinoid tumor, in case carcinoid tumor, there is a too much of synthesis of serotonin. That's why I discussed already. We have one drug called Telotristat is the tryptophan hydroxylase inhibitor useful as a supportive therapy for treatment of carcinoid. Originally, the drug of choice is octreotide. It's a drug of choice. Along with that, supportive drug is telotristat is the tryptophan hydroxylase inhibitor. Okay. And then we now move on to serotonin receptor modulators. For example, totally we have seven subtype of serotonin receptors are there. Come on, morning question. Can you please answer? All the serotonin receptors are G protein. All are G protein coupled sort of exception. Can you please answer? All the serotonin receptors are GPCR exception. Come on, I want answer. Alert man, come on, alert. Answer is 5ST3. Very good. It is the ligand gated receptor gating sodium ionization. Very good, very fantastic one. Good, good, good. Now, look here. We discuss ondansetron, granisetron, all are 5-HT3 antagonists useful as a drug of choice for cancer chemotherapy vomiting. The first line drug for treatment of vomiting due to anti-cancer drug means 5-HT3 blocker like pernocetron, ondansetron. Okay, next. 5-HT1BD receptor stimulants causing vasoconstriction. Stimulation of 5-HT1BD causing vasoconstriction and triptans. Triptans are the 5-HT1BD stimulant and triptans causing vasoconstriction. Thus why they are very good drug for treatment of acute attack of migraine. So question currently triptans like sumatriptan, rizatriptan. The triptans are the first line drug of choice for acute migraine because they are causing vasoconstriction. Oh, then the 5-HT4 receptor seen on small intestine, it is having prokinetic property. Stimulation of 5-HT4 causing prokinetic property. And we have so many examples for 5-HT4 agonists. For example, we have cisapride, mosapride, etopride. All these are prokinetic agents. And remember, the cisapride, mosapride causing adverse effect of QT prolongation, causing QT prolongation. Okay. Then, very important, very important. We have one drug called alloceton. It's a 5-HT3 antagonist useful for treatment of diarrheal dominant IBS. Now I'm checking your memory level. Can you please answer? Alloceton, a wonderful drug for treatment of diarrheal type IBS in women, female. But you should know it causes one dangerous adverse effect called dash. What is the dangerous adverse effect? It causes ischemic colitis. Ischemic colitis. Danger, danger, be careful. Yeah, very good, very good. Okay. Then 5-HT1A agonist. Stimulation of 5-HT1A having anti-anxiety property. For example, buspirone. Those drug name end with pirone. Buspirone, ipsapirone, ipsapirone, gpirone. All are useful as anti-anxiety, useful for chronic anxiety. They takes about 3 to 4 weeks for the benefit to occur. They have delay in the onset of action. takes about 3 to 4 weeks for the benefit occur. So they're never useful for acute anxiety, useful only for chronic anxiety. Drug name buspirone, ipsabilone, gpirone, 5-HT1A agonist. Okay, then serotonin undergo metabolism by it's one of the monoamine. Monoamine undergo metabolism by monoamino oxidase enzyme. So, what I want to say, we have something called SSRI, selective serotonin reuptake blocker. They inhibiting reuptake of serotonin, thereby going to accumulate serotonin in synapse. So, if a patient taking SSRI along with MAVO inhibitor, there will be too much of accumulation serotonin causing serotonin syndrome. Question: SSRI, when taken with the MAVO blocker, risk of serotonin syndrome. For this syndrome, symptomatic therapy cyproheptadine. It's a serotonin antagonist, antihistaminic plus anticholinergic, useful for relieving symptoms of serotonin syndrome. Then, very special, very special. We have one drug called flibanserin. It's a serotonin modulator. It is approved for treatment of female with hypoactive sexual desire disorder. There are some female having poor interest on sex. For them to create sex interest, we have something called flibanserin. It is also called female Viagra. Female Viagra, also called female sexual stimulant. It's a serotonin modulator useful for female with hypoactive sexual desire disorder. In this junction, I want to check your level of knowledge in medicine. Can you please answer? Name any melatonin, melatonin, melatonin receptor modulator. Sorry, not modulator, melanocortin. Name any melano, melanocortin modulator useful for HSDD. We have one thing called set melanotide. Melanotide. It is a melanocortin. Yeah, good man. Bre melanotide. Yeah, good. Krishna. Yeah. It is for obesity. Okay. Sorry. I'm mistake. You are good. You are good man. Krishna, you are good. Bre melanotide. It's a melanocortin stimulant useful as an injection, subcutaneous injection given half an hour before sex. They're going to improve sex interest. Okay, and it is the oral drug. It's a oral drug given as a sexual stim. So question, Amrut asking what are the topics after break? After break, we are discussing autocorrect. Okay, so we given anti-histamine over. We are discussing serotonin modulator. Flibanserin, a oral drug called serotonin modulator, useful for female with HSDD. Bremelanotide, it's a melanocortin agonist, useful for female with HSDD. Okay, and then look here. This we discussed. 5-HT4 stimulants are called prokinetic, like Pezirol. It's a prokinetic useful for treatment of constipation type of IBS. And then, very important, we have one drug called Larcaserin. Larcaserin is the 5-HT2C receptor agonist. Now I am going to ask one question. Who is going to tell the answer? Larcaserin, a 5-HT2C agonist, It is actually used for what? It is useful for treatment of obesity. Useful for treatment of obesity. It causes appetite suppression. Useful. It going to decreases appetite. Thereby useful for treatment of obesity. But causing adverse effect of gastric cancer. Because of causing gastric cancer, the drug was withdrawn from market. Lorcaserin was withdrawn because of causing gastric cancer. Okay, that's what Lorcaserin. Yeah, 5-HT2C agonist. This is what I told. Lorcaserin was withdrawn because of causing GI cancer, especially causing stomach cancer. So it was withdrawn from market. Okay, and then this is very important. The one and only serotonin receptor ligand get phase 3. All serotonin receptors are G protein coupled. Exception phase 3, this ligand gets up. Okay. And what is vilazodone? Remember, it is one of the antidepressant, one of the new drug called antidepressant. It is a selective serotonin reuptake inhibitor plus partial agonist. It's a serotonin partial agonist and reuptake blocker called sparing. Vilazodone, serotonin partial agonist and reuptake inhibitor called sparing. Vilazodone useful for treatment of depression. Okay. Next, one new point. Edalopridine. It's a new drug called 5-HT6 stimulant under trial for improving cognitive function in and also useful for managing narcolepsy. It's under trial. Drug name Edalopridine. 5-HT6 agonist under investigation for cognitive disorder and for narcolepsy. Okay, this new drug under trial. Okay, and when we talk about autocuts, I think this was discussed already. Anyway, repetition, make it fast. Zoltan, a drug inhibiting 5-lipoxygenase enzyme, that means inhibiting synthesis of leukotriene, but we don't. Class till 7 doctors, till 7. Actual time, the given time is 9 to 7, 9 to 7. I have to finish only three things. NSAID, rheumatoid gout. I think my class will wind up by 7:20 because after finishing this one, I have to cover NSAID and rheumatoid gout. By 7:15 or 7:20, we wind up. Okay. And after that, I am going to study for next day class. I have to prepare so many points for CNS, endo, anti-cancer, and antimicrobial. So to make interest, even though we taking daily, weekly 4 days pharmacology from page 1 to last, still for next day class, I have to prepare and come. Then only it's interesting. So class till 7:20 or maximum 7:20. By 7 time, I try to finish. Okay. Now look here. Zoltan, a drug useful for asthma, but we don't use because of causing risk of hepatotoxicity. Okay. Causing hepatotoxicity. Right. And then Montelukast, we know leukotriene receptor antagonist. Okay, and we know it causes adverse effect of Church syndrome and also risk of depression. All these things done already in asthma chapter. So, montelukast is a leukotriene receptor antagonist and it causes adverse effect of depression. It's the latest point. Montelukast given black box warning. It causes neuropsychiatric problem, mainly depression problem. So be careful, be careful. Okay. And this is I told already. Montelukast may cause Church syndrome. For treating this syndrome, we can try either steroid or we can try mepolizumab. Mepolizumab. It's IL-5 antagonist, IL-5 blocker. All these things discussed already in asthma chapter. Okay. Now, this one. Mepolizumab, a IL-5 blocker, can be useful for Chakra syndrome. And this is what very important morning when discussing hypertension, heart failure. I asked you, ACE inhibitor causes dry cough, sometimes causing rarely angioedema. It is all because of accumulation of bradykinin. So, for treating angioedema due to asymmeter, we can go for bradykinin antagonist, drug name icatibant. It's a bradykinin antagonist useful for treatment of ACE inhibitor induced angioedema. One, Sakshi asking just up. See, this I rushed because this we done already in asthma chapter. Okay, leukotriene antagonist was discussed already. That's why again, suction, xylitol, a 5-lipoxygenase enzyme blocker, causing adverse effect of liver toxicity. We don't use it. And leukotriene receptor blocker, montelukast, it causes Chakra syndrome. For treating that syndrome, we can try mepolizumab or steroid and brady blockers, icatibant. Kallikrein blocker, we have ecallantide. Ecallantide is a kallikrein blocker. Kallikrein blocker. Okay. And we have Ruconest. Ruconest. What is this? It is the C1 esterase inhibitor analog. See, C1 esterase inhibitor deficiency causing hereditary angioedema. So for treating that case, we can go for C1 esterase inhibitor analog like Ruconest. Okay. Anyway, calicium ecallantide. Okay. Now we move to prostaglandin and their modulators. Very important, very important. Please watch. Yeah. Misoprostol, a PGA1 analog, useful for treatment of NSAID-induced gastritis. But remember, for treating this gastritis, originally drug of choice is proton pump inhibitor. So originally, for treatment of NSAID-induced ulcer, drug of choice is proton pump blocker. But adjuvantly, we can try misoprostol. And misoprostol also useful for MTP, medical termination of pregnancy. That's why important question. Since it causing abortion, this drug is contraindicated for treating gastritis in pregnancy. Once again, it is useful to make abortion, no? But it may cause teratogenicity called movie syndrome. It's a teratogenicity caused by misoprostol, where the problem will be sixth and seventh nerve defect. Sixth and seventh nerve defect. All these things you know. Okay. Now, next, carboprast. Please follow. It's a PGE2. PG, PGF2 alpha, carboprast. It is very good drug for controlling postpartum hemorrhage. Orbopras, a PGF2 alpha, causing uterine contraction, useful for controlling postpartum hemorrhage. But remember, the carbopras may cause bronchospasm. It causing bronchospasm, so unsafe in bronchial asthma patient. So name the prostaglandin analog, not safe in asthma patient. Carbopras causing bronchospasm. Okay. Then dinoproston is a PGE2. PGE2 given as a vaginal gel or pessary as a pessary. It's we give it in the vagina, it causes cervical ripening, cervical dilatation, we call ripening. This property useful for labor. It is going to cause cervix relaxation, useful for labor. Actually, labor induction by oxytocin. But before going for oxytocin, we can try dinoproston. It going to cause cervical ripening. This also going to induce labor. So we can try this. Okay. And then hypoprostinol, very important. It's a PGI2. That is prostacyclin analog. PGI2. It has vasodilatory property, useful for treatment of pulmonary hypertension. Remember, PGI2 analogs are vasodilator plus antiplatelet, and they useful for treatment of pulmonary hypertension. Okay. Then alprocel is a PGE1. PGE1 analog. It is useful for two purposes. One, it is given intravenous infusion, IV infusion for managing to maintain the patency of ductus arteriosus in a baby with uh, transpositional great vessel. In that case, I want to maintain the patency of ductus arteriosus. For that, I can go for IV infusion of alprostil, and it can be used as a intracavernous injection into penis, causing penis vasodilation. It is useful for treatment of erectile dysfunction. So, alprostadil to use based on two routes. In children, in newborn baby, for maintaining patent ductus arteriosus, we give IV infusion of alprostadil. Whereas in a male, for treating ED, I can inject Alprostadil as an intracavernous injection therapy, pipe therapy, good. Pharmacologically induced penis erection, pipe therapy, good. Intracavernous injection. Okay. Next. Look. PGF2 alpha agonist like latanoprost, bimatoprost are wonderful drug for glaucoma. PGF2 alpha like latanoprost, bimatoprost useful for glaucoma, and they useful for glaucoma by what way? They increasing drainage of aqueous via UVO scleral route. So prostaglandin analogs of promoting drainage of aqueous via UVO scleral route useful for glaucoma. Okay. And this portion we discuss tomorrow in ophthalmology class. I will discuss. Okay. Now, Selexipag, a new drug, very special, very special. Please note, it's a prostacyclin receptor, PGI2 receptor, uh, sorry, not antagonist, PGI2 receptor stimulant. Small correction, it is not antagonist, it is stimulant causing vasodilation, useful for treatment of pulmonary hypertension. PGI2 receptor stimulant. Okay. And then super important new point actually, Iloprost. It's a PGI2 analog. It's a vasodilator. Got approval for treatment of frostbite. So Iloprost, a PGI2 analog, got approval for treatment of frostbite. Okay. And then Epoprostinol, a PGI2 analog, useful for pulmonary hypertension, but important extra point, useful to prevent platelet aggregation and platelet damage during dialysis. So useful for preventing platelet adhesion and platelet damage during hemodialysis. So what epoprastinol? Okay. So many important points we discuss about prostaglandin and the analogs. And the last part of today's discussion, we go for a discussion of NSAIDs. Very simple topic. Non-steroidal anti-inflammatory drugs. Okay. No. See, doctor, I take such a pain for you. Okay. It's a very tedious job. See, discussion of whole pharmacology within 2 days, very tedious. But you people are very great. You are understanding the concept very nicely. That's why I'm able to do this job. Okay. See, we covered 50% pharmacology. Unimaginable. Okay. But you are really great. You are understanding the concept. That's why it is possible to make. Okay. Anyway, if you read well means tomorrow still more interesting. Come on. NSA, non-steroidal anti-inflammatory agents. Here they are all acting mechanism action all are COX enzyme blocker. COX enzyme blocker. But based on the selectivity, we have three things. One thing called non-selective COX blocker, and then preferential COX-2 blocker, and then highly selective COX-2 blocker, like the three category. Okay. So see, we have three class of drug. One is non-selective COX enzyme blocker. Second, preferential COX-2 blocker, and highly selective COX-2 blocker. Now I go one by one revision of all the points. Look here. Aspirin, a main drug, it's a captain of NSAID. It is the one irreversibly blocking COX. It's a non-selective, irreversible COX enzyme blocker. It's a prototype of NSAID. Okay. And here, very special. Among the NSAID, look here, we have one drug called indomethacin. Very special. It is the non-selective, reversible COX enzyme blocker. The special point is it is the most most potent anti-inflammatory, also having uricose property. Thus why among the NSAID, the most super drug for treatment of gout is indomethacin. So most potent NSAID, also having uric property. So among the NSAID, the most wonderful NSAID for treating acute gout is indomethacin. Okay. Now next question. Okay. Aspirin, we know a anti-inflammatory, but it is contraindicated for treatment of viral fever in a less than 12-year-old child. When using aspirin for treatment of viral infection like chickenpox, mumps, measles, for this fever in child of less than 12 years, if used, it causes adverse effect of Ray's syndrome. Here, the child will develop severe kidney problem, sorry, first liver problem and encephalopathy problem. So remember, it causes hepatic encephalopathy, Ray's syndrome. Be careful. Okay, and then the highly selective COX-2 blocker has risk causing cardiovascular problem like MI, sometimes causing heart failure, sometimes causing hypertension. Now I want to check your level of preparation. Can you please answer? Name some highly selective COX-2 blocker. Name some highly selective COX-2 blocker withdrawn. Withdrawn. because of causing cardiotoxicity. Can you give example? For example, Rofecoxib and Valdecoxib. These two drugs are withdrawn. No. Etaricoxib still available. Remember. Etaricoxib still available. So, which are the coxib withdrawn because of cardiotoxin? One is Rofecoxib and Valdecoxib. And one more thing, we have one thing called lumiracoxib. It is withdrawn because of hepatotoxicity. And it is also causing heart problem, but main reason is hepatotoxicity. Remember, etarecoxib still available. Itaricoxib still available. It's the most highly selective COX-2 blocker still available. So the coxib withdrawn because of cardiac problems are roficoxib and valdecoxib. Okay, next. This is very important. NSAID like indomethacin causes problem of lithium toxicity. Among the NSAID, indomethacin inhibit renal excretion of lithium, thereby aggravating lithium toxicity. Remember, doctor, morning I told you what? Thiazide and now I'm telling indomethacin. These two class of drugs are decreasing renal excretion of lithium. Thereby, they're going to aggravate lithium toxicity. Among the NSAID indomethacin, among the diuretic thiazide are more important, going to aggravate lithium toxicity. Okay, and the NSAID preferred for managing dysmenorrhea mefenamic acid. For treatment of dysmenorrhea pain, we can go for mefenamide. Okay, and then look here. Aspirin having antiplatelet property. Low dose aspirin. When it's a low dose, I mean 50 mg to 150 mg. It's a dose range. But we give normally 75 mg per day. The low dose aspirin selectively inhibiting COX-1 enzyme, thereby inhibiting synthesis of thromboxane A2, thereby having antiplatelet activity. Morning, when discussing antiplatelet, we discuss all the points. So remember, aspirin, a drug inhibiting COX-1 enzyme in the platelet irreversibly, thereby having antiplatelet property. Okay, next. This is what I told. Aspirin inhibiting irreversibly COX-1 enzyme in the platelet, thereby having antiplatelet activity. Okay. And remember, aspirin undergo zero order kinetic. Morning discuss no. Zero kinetic. 0 watt. 0 watt power. Warfarin, A for aspirin, A for alcohol. So, we having tolbutamide, theophylline, phenytoin, undergo zero order kinetic. Okay. And then look here. And then etarecoxib is the most highly selective COX-2 blocker. It is available in the market. Remember, etarecoxib is the most highly selective COX-2 blocker. It is available. And look here, nimesulide. It is one of the preferential COX-2 blocker, but highly hepatotoxic. That too in children, very highly hepatotoxic. So it was withdrawn in many countries. So nimesulide is not available because of risk causing severe hepatotoxicity. Okay. And next important point, look here. Among the NSAID, pyroxicum is the longest acting. Remember, it undergo enterohepatic cycle. Enterohepatic cycle. So, if a drug undergo enterohepatic cycle, it will have longer duration action. So, among the NSAID, a drug having longest duration action is your pyroxicum. Okay, and paracetamol, NSAID safe in pregnancy because most of the NSAID when using in pregnancy risk of premature premature closure of ductus arteriosus. For example, indomethacin, ibuprofen, risk of premature closure. But paracetamol relatively safe in pregnancy. Okay, and look at this, very important, very important. Paracetamol mechanism action, it's a COX-3 blocker in the brain. It's a COX-3 blocker in the brain. It's going to make a uh, temperature regulation. It is resetting the thermostat. It's a COX-3 enzyme blocker acting on hypothalamus. Actually, it having only anti-pyretic action plus analgesic action, and it has no significant anti-inflammatory activity. Remember, it is mainly having analgesic action plus antipyretic, no anti-inflammatory action. Why? This is what MCQ. Remember. Why paracetamol has no anti-inflammatory action? Look here. Actually, our paracetamol acting on COX-3 in the brain, it is not going to act on inflammatory sites. One point. Second point, at the site of inflammation is one thing called enzyme peroxidase enzyme. See, in the inflammatory condition, there's a high level of peroxidase enzyme. This enzyme interferes the paracetamol activity, inhibiting paracetamol activity. Thereby, it has no anti-inflammatory action. So, at the site of inflammation, there's one thing called peroxidase enzyme is there. That enzyme interfering the performance of paracetamol, thereby has no significant anti-inflammatory action. Okay, and the maximum dose of paracetamol per day only 4 gram. Up to 4 gram we can go. That's all. Maximum dose 4 gram. Normally we use Calpol. Calpol 500 mg 3 times a day. Or we go for Dolo 650 3 times a day. Or we can go for paracetamol 1 gram tablet 1 or 2 times per day. But maximally we can go for 4 gram per day. That's all. More than this mean risk of hepatotoxicity. So remember, paracetamol overdose can lead to hepatotoxicity. Now one question. Paracetamol causing hepatotoxicity because of producing one metabolite. Name the metabolite responsible for liver problem. The metabolite of paracetamol called NAPQI, N-acetyl para-benzoquinonimine. So question, which is the toxic metabolite of paracetamol causing liver damage? It is N-acetyl para-benzoquinonimine. Now you should tell, come on. What is the antidote? Can you please answer? What is the antidote for managing paracetamol toxicity? Come on. The antidote for paracetamol is, we have one thing called N-acetylcysteine. Very important. It's an antidote. Okay. Along with, we can also try methionine. Methionine also can be useful for treatment of poisoning. And remember, the N-acetylcysteine replaces glutathione by making more availability of glutathione. It overcomes the toxicity. It's a glutathione replacer or regenerator. So question, N-acetylcysteine is the specific antidote for paracetamol. It's going to reactivate glutathione, thereby overcoming toxicity. Look at it. The time window for effective administration of N-cysteine is within 8 hours. Within 8 hours or maximum 10 hours, if we give, we can maximally preventing liver damage. So, if we suspect paracetamol poisoning within 8 hours, try to give antidote. This will maximally giving benefit of reducing hepatotoxicity. That's about NSAIDs. We discuss all about aspirin, all about non-selective COX blocker and selective COX-2 blocker like COX-6, and then what about paracetamol. And finally, we are now going for discussion of two topic, very simple topic called rheumatoid arthritis and gout. Just 10 minutes, doctor, just 10 minutes, okay. And in between, just look at this. They asked to have feedback. I give some this one. You make a photocopy and you just give feedback. So regarding my discussion, my timing, and covering the subject, how making interesting or boring. So when I give feedback, I can modify my discussion. See, in my point of view, I struggle. I want to concise everything. See, as you know, all these are 3 days topic. GP ANS one day, CVS unit blood second day. Third day we go for autocad. So 3 day topic. I want you one day. That means very difficult job. You know, I also know. But if we are too good, already done 2 to 3 time revision main, now we can easily manage. So just have a photocopy on this and give feedback, and then it's over. Shall I move? Shall I move? Take a photocopy. Yeah. Okay. So now I am moving to the remaining portion. The remaining portion is look here. Okay. Rheumatoid arthritis. Look here. Rheumatoid. Now look here. For managing rheumatoid arthritis, we have symptomatic therapy. Symptomatic therapy and definitive therapy called disease modifying anti-rheumatoid drug. Two category of drugs are there. Okay. Now the point is, when it says symptomatic, what do you mean? I mean to control only symptom. For example, the pain swelling can be controlled by using painkiller like NSAID or by using steroid. They're all anti-inflammatory agents controlling pain, swelling. That's all. Whereas today we have something called disease-modifying anti-rheumatoid drug. It is what MCQ for you. So I go super MCQ. Please follow me. Okay. When you say DMOD, we have two things. One is called biological, conventional, synthetic. Conventional, synthetic DMOD. One more category, biological DMOD. Now, interesting question. When you say conventional synthetic, one is methotrexate. It is the most commonly used DMARD. One of the first line DMARD is methotrexate. It is the most common drug useful for rheumatoid. And for treating rheumatoid arthritis, methotrexate given low dose therapy. We use low dose therapy. For example, 7.5 mg per week. Low dose therapy, but giving chronically. Giving chronically. Low dose therapy on chronic therapy. See, Aishwarya, methionine also on a supplement. The main choice is N-acetylcysteine. Methionine can be supplemented to improve glutathione production, thereby overcoming toxicity. Supplement only. Now, methotrexate, low dose therapy, chronic therapy, useful as a wonderful DMARD. Okay. But MCQ, chronic therapy causes risk of hepatotoxicity. Very important. Methotrexate as a chronic therapy causing risk of hepatotoxicity. Remember, today in rheumatology, I'm discussing methotrexate useful for rheumatoid. But tomorrow in oncology, we're going to discuss methotrexate, one of the anti-folate category. So very important anti-cancer drug, especially the drug of choice for choriocarcinoma. Okay, for treating cancer, we give high dose therapy, but short-term therapy, short-term therapy. So look in rheumatology, we using low dose therapy chronically. In oncology, high dose, short-term. Low dose therapy, chronic therapy causing hepatotoxicity. In high dose therapy causing bone marrow suppression, alopecia, GI toxicity like diarrhea, vomiting. All these are anti-cancer problem. Okay. Dose Dr. SCB. The dose is 7.5 mg per week. Methotrexate given 7.5 mg per week. Low dose therapy, but chronic therapy. But on chronic therapy, risk of hepatotoxicity. The antidote. The antidote for methotrexate, actually we have one thing called folinic acid. See, folinic acid is the antidote. But in rheumatology, we can supplement with the folic acid. Okay. In case of poisoning, we can go for folinic acid. Okay. Next question, you should know, we have one drug called leflunomide. It is one of the DMARD. Here, old question. Mechanism of action was old question. Please note, acting by inhibiting dihydroaurated dehydration. Leflunomide acting by inhibiting dihydroaurated dehydration. It's a pyrimide. It acting by inhibiting pyrimidine synthesis. And remember, it is also causing adverse effect of hepatotoxicity. So, methotrexate also causing hepatotoxicity and leflunomide also causing risk of hepatotoxicity. Okay. Next. We have chloroquine. That too hydroxychloroquine, it is also having anti-rheumatoid activity. On chronic therapy causes retinal damage. We call bullseye retinopathy or bullseye maculopathy. So name the DMARD causes eye problem or retinal damage means think of hydroxychloroquine. Okay. Next question. What about biological DMARDs? In biological DMARD, the most and most important group of drugs is TNF alpha blocker, tumor necrotic factor, TNF alpha blocker. A lot of drugs are there like infliximab. Then here adalimumab, golimumab, cetrolizumab, even etanercept. Like that, we have 5 drugs. Remember. Here, adalimumab is a dash. Old question. Adalimumab is a monoclonal antibody targeting against TNF alpha. And remember, all the TNF alpha blockers are immunosuppression, very important, immunosuppression. So they will cause adverse effect of infection, also going to cause reactivation of old latent infection. Here, remember, TNF alpha blocker will have the risk of causing a reactivation of latent TB. Latent TB. That's why I want to check your level of knowledge in microbiology. Can you please answer? I know TNF alpha blocker carrying the risk of reactivation of latent TB. That means before injecting this drug, I want to rule out latent TB. My question starts. Anybody? Name one test useful for diagnosis of latent TB. Anybody? Name one test useful for diagnosis of latent TB. It is called interferon gamma. What called? We can use one thing called PPD, purified protein derivatives, or interferon gamma release assay. All these are useful for diagnosis of latent TB. So we PPD, Manto test, that is purified protein derivative, or one more test called interferon gamma release assay, useful for diagnosis. So before starting TNF alpha blocker, check for latent TB, and they also causing problem of activation of hepatitis B virus infection. So check for hepatitis B. Before injecting TNF alpha blocker, check for TB, check for hepatitis B. Very important, very important. Okay. And the TNF alpha blocker also causing dangerously adverse effect of heart failure. So they are contraindicated in patient with a severe heart failure. This was old question. TNF alpha blocker contraindicated in three cases. One, T patient, then hepatitis B patient, and in heart failure. In these three cases, TNF alpha blockers are contraindicated. Remember. And then, very special, very special. We have one drug called tocilizumab. Very, very special. It's a IL-6 antagonist. Actually, we have sarilumab. One more drug, tocilizumab. Here, tocilizumab is very, very important. Both are IL-6 antagonists. Here, one special point. The tocilizumab, in addition to rheumatoid, it is also got approval for treatment of cytokine storm syndrome in COVID-19. Tocilizumab, a drug antagonizing IL-6 receptor, useful for rheumatoid as well as useful for managing cytokine release syndrome in COVID-19 patient. And then we have rituximab. It's an antibody targeting against CD20 on B cell, inhibiting B cell activation. Rituximab, and this drug causing adverse effect of PML, given as a IV infusion, causing infusion reaction. One more point, causing progressive multifocal leukoencephalopathy. Just for relaxation, can you please answer? Name the two drugs today we discuss causing adverse effect of PML. One is rituximab. One more drug, natalizumab. Natalizumab. That is alpha 4 beta 1 integrin blocker, useful for IBD. It is also causing PML. Very good, man. Very fantastic. Very fantastic. Good. Now, look here. We have something called abatacept and batacept. These two drugs are CD8086 inhibitor. The CD8086 are co-stimulative factor. They're going to stimulate the T cell activity. So these drugs are going to interfere T cell activation, inhibiting T cell activation, thereby useful for rheumatoid. So question, abatacept and batacepts are co-stimulation inhibitor targeting against CD8086. Okay. Then for treatment of rheumatoid, we have IL-1, interleukin-1 antagonist, for example, anakinra. Anakinra, one of the interleukin-1 antagonists useful for rheumatoid. It is also useful for gout. Useful for gout. So actually IL-1 blockers we have one drug anakinra. Second rilonacept. One more thing called canakinumab. All are IL-1 blocker useful for both rheumatoid and gout. Famous drug is anakinra. Okay. And then we can also have Janus kinase blocker like baricitinib. One more drug called tofacitinib. Both are Janus kinase enzyme blocker useful for rheumatoid arthritis. Then sulfasalazine. I told already sulfasalazine, one of the DMARD. Actually, the drug has two components. One is sulfapyridine, one more thing called 5-amino salicylic acid. Here, sulfapyridine, that compound useful for rheumatoid. 5-ASC useful for treatment of inflammatory bowel disorder. So, sulfasalazine useful for rheumatoid. Which component? Sulfapyridine component useful for rheumatoid. And finally, secukinumab. It's an interleukin 17 blocker useful for refractory rheumatoid arthritis. Interleukin 17 blocker, secukinumab. So I think all the most important biological DMARD over doctor. And now we want the last one thing called gout. Just 5 minutes, we finish. And this one I told already, sulfasalazine causes adverse effect of oligospermia, causing male infertility. Be careful, be careful. Okay. And the last topic today's session going for gout. Just one page. Very simple. For treating gout, we have 2 to 3 options. First, for treating acute gout, I just want something called painkiller. Patient is present with pain, swelling in the first metatarsophalangeal joint. I just want only painkiller. For example, I can go for colchicine, or I can go for NSAIDs, or I can go for steroid. So question, the drug useful for acute gout. Co-stimulation. Ask somebody. Co-stimulation. Batacept are blocking the CD8086. Actually, if we study microbiology, they may say T cell, T cell, and then antigen presenting cell. Here's something called B7 molecule. It is the family having CD8086. The CD86 are, when acting on T cell, they're going to cause T cell stimulation. Okay. Abatacept are targeting against CD8086, thereby preventing the activation of T cell. That means these drugs are ultimately inhibit T cell activation. Okay. T cell activation blocker useful for rheumatoid. Okay. Now coming to gout doctor. For acute gout, I go for colchicine. What are all the MCQ regarding colchicine? Remember, colchicine, a drug acting by inhibiting microtubule. important. Mechanism action important. It inhibit microtubules, inhibiting mitosis, inhibiting neutrophil motility, inhibiting chemotaxis. That's about mechanism. Inhibiting microtubules of the neutrophil. Okay. And colchicine causing adverse effect. The most common area GI toxicity like diarrhea, especially bloody diarrhea. That's the most common area. But it also causing other problem like myopathy, and contraindicated in liver failure and kidney failure patients. That's what colchicine kinetic. But for MCQ, remember most common problem GI toxicity like that to bloody diarrhea. Okay, remember colchicine useful for acute gout, but you should know colchicine also useful for treatment of familial Mediterranean fever, useful for managing pericarditis, Beckett's disease, and also undergo trial for treatment of atherosclerotic cardiac disease. It is now trying for treatment of MI case, coronary artery disorder case also we're trying. Okay, colchicine has a lot of new trial, undergo trial for treatment of ischemic heart disease also. Okay, that's what colchicine. Next, NSAIDs. NSAIDs useful for acute gout. The most common NSAID indomethacin. It is the most potent drug, also having uricose uric property. It's the most popularly useful NSAID. And remember one point. For a acute gout, aspirin contraindicated because aspirin causes uric acid retention. It causes uric acid retention, thereby aggravating gout. So aspirin should not used to for treatment of acute gout. Whereas indomethacin has uric acid, that's a very good NSAID. Okay. Now we know acute gout mean either we can go for NSAIDs or steroid or go for colchicine. Whereas chronic gout, look at in chronic gout, the problem is hyperuricemia. Hyperuricemia. So, for treating this case, either I want to control the synthesis of uric acid or I want to promote excretion of uric acid. So, look here. We have something called xanthine oxidase enzyme blocker like allopurinol, febuxostat. These two drugs are inhibiting synthesis of uric acid. So they're going to control uric acid synthesis. Allopurinol and febuxostat useful for chronic gout mechanism inhibiting synthesis of uric acid. And then among the two, allopurinol danger drug. It causes hypersensitivity reaction, especially in patient with the HLA-B 5801 gene. So before giving allopurinol, better you do genetic screening test to rule out this gene. In HLB 5801 gene, in this patient, high risk of allergic problem. Okay. And then, very special. Xanthine oxidase inhibitor. Drug interactions are very important. Allopurinol and febuxostats having drug interaction with azathioprine and 6-mercaptopurine. Remember, I go slow. Very special. You must know. Look here. Azathioprine, one of the immunosuppressant. 6-mercaptopurine, anti-cancer drug. Both the drug undergo metabolism by xanthine oxidase enzyme. Now tell me, if we give allopurinol with azathioprine or with 6-MP, these will not get metabolized, so this drug's level going to get increases. So xanthine oxidase inhibitor will increases plasma level of azathioprine, will increases plasma level of 6-MP. So this drug toxicity going to occur. Now I want to ask Sakshi, Pavana and all other people, can you please answer? If at all, if I give allopurinol with 6 mercaptopurine, I know 6-MP level going to get increases and going to cause more problem. So you should tell, if I want to give allopurinol with 6-MP, what I should do. Can you please answer? What I should do? If at all, if I give allopurinol with 6-MP, reduce the dose of 6-MP. Okay? Dose reduction. Very fantastic. Good, good, good. All are too good, man. So reduce the dose of 6-MP. Very fantastic. Good, good. Okay. Next question. See, febuxostat, a xanthine oxidase enzyme blocker, it is safe in patient with kidney failure. Comparing to allopurinol, febuxostat is safe in patient with kidney disease, but it causes adverse effect of hepatotoxicity. The important adverse effect, hepatotoxicity, rarely stroke, CVA. Oh, next, very special. For treating gout, we have something called recombinant uricase analog. Uricase is the enzyme causing metabolism of uric acid. They converting uric acid into allantoin, thereby easily the allantoin undergo excretion. So we have pegloticase, rasburicase, both are recombinant uricase analog, and they are going to convert uric acid into allantoin, thereby easily uric acid undergo degradation. So all are very useful for treatment of severe hyperuricemia. For example, in case of tumor lysis syndrome. In this case, for rapid control of uric acid, I can try IV, intravenous rasburicase or IV pegloticase, useful for managing tumor lysis syndrome induced hyperuricemia. But remember, these drugs are contraindicated in patient with Jesus deficiency. In this case, they cause adverse effect of severe hemolysis. This is also important. Rasburicase and pegloticase may cause hemolysis in Jesus deficiency. And another point, we have IL-1 blocker like anakinra, canakinumab, Rilonacept, all are IL-1 blocker useful for treatment of both rheumatoid as well as gouty arthritis. Okay, that finishes important MCQs on gouty arthritis. Time now is about 7:46, almost 45 minutes extra. Actual payment is only for 9 to 7. Okay, but extra 40 minutes. Okay, no problem. Just for your benefits, I can do a lot. Okay, so one of the thing I can do for you, I can take extra time class for better understanding. That's all I can do. Okay, so do well, read well, all the very best. With this, today we are finishing my first session. Tomorrow, second session, we start with the CNS and remaining portion, doctor. Okay, I think so far comfortable. It should be comfortable. If you're comfortable, definitely you're going to get a very good rank. Okay, because you know already subject. It's a live rapid revision. You have notes, so just revise calmly. You can do a lot. Okay, all the very best. Thank you very much. tomorrow we see by 9 a.m. with starting with the CNS and continue with the endo and all other things. Okay. Meanwhile, thank you. Thank you. Good night. Good night.